Test. Test. It's working. You can shut down now. Thank you. Good morning, everyone. Thank you for joining us for the Medical Board of California's quarterly board meeting, day one. While this meeting is being conducted with participating board members and staff at the meeting location, this meeting is being streamed interactively using WebEx to allow for remote public comment in the same manner as recent meetings. Public comment for those who wish to speak will be heard for each agenda item, for individuals attending in person and remotely. To be ready for remote public comment, we ask that you please ensure that your comments can be heard clearly by being connected to the audio of this meeting through the proper method. If you're having difficulty hearing the audio of this meeting, it could be because the device you're connecting with has bandwidth limitations. If you do have difficulty hearing the audio of this meeting using your device, please click the ellipsis button at the bottom of the WebEx application or the audio and video menu item at the top of the WebEx application and then select Switch Audio. You'll see an option to call in and will be provided with a telephone number, access code, and attendee ID that can be used to connect to the meeting audio via phone. Using the information provided, it will automatically disconnect your device's audio and connect your phone to the name you joined the meeting with. By using this method, if you are having audio problems with your device, this will allow you to still participate and hear the audio of the board meeting. Please see the View Additional Meeting Information link on the first page of the meeting agenda for more information on connecting to the meeting and accessing meeting materials. Thank you, President Lawson. You can now start the meeting.
Thank you, Sean, and good morning to all of you. I'd like to first just ask us to all please turn our mobile devices or any of our computers to silent, please. For members of the public, you may notice that board members are accessing their laptops, phones, or other devices during the meeting. They are using these devices to access board meeting materials that are in electronic format. If you are a member of the media and require assistance or information, please see Ali Shembra. Ali's in the back. Ali, please identify yourself. She's waving. This is an official business meeting of the Medical Board of California, and disruptions of the board's business will not be tolerated. Government Code Section 11126.5 does allow a board to remove people who willfully interrupt a meeting and to clear a room if order cannot be restored by removing or muting the disruptive people. We do have designated time on the agenda for public comments on items not on the agenda, and we will ask for public comments on all agenda items. The board welcomes public comments on any item on the agenda, and it is the board's intent to ask for public comments prior to the board taking action on any agenda item. If for some reason I forget to ask for public comment on an agenda item and you wish to speak on that item, please raise your hand or come forward and you will be recognized. As Sean mentioned, this meeting is also being streamed via WebEx. Individuals attending the meeting remotely via WebEx will have an opportunity to provide comment and will be assisted by the host who is facilitating the WebEx meeting. During each agenda item, the host moderating this WebEx event will activate the hand raising and Q&A features of WebEx and will ask anyone wishing to make a public comment to indicate so by raising their hand or entering yes in the Q&A window. The host will then call on individuals who indicated they wish to make public comments by the name provided by the individual, which may be a pseudonym. When called upon, the host will unmute the microphone of the individual and they will have 3 minutes to make their public comment. This time period may be reduced depending on the number of people who wish to speak so that more people may be heard. The host will audibly announce when 30 seconds remain to conclude the public comment. After the individual's time for public comment has lapsed, the individual will be placed back on mute. And only one public comment per agenda item is allowed per attendee. During agenda item 2, public comments on items not on the agenda, the board has limited the total public comment period for individuals to 40 minutes. Therefore, after 40 minutes, no further comments will be accepted. During public comment on any other agenda item, 20 minutes will be allowed for the comment period. And after 20 minutes, no further comments will be accepted. Each person, again, will be limited to 3 minutes per agenda item. I want to remind all speakers to please stay on topic and keep your comments to the allotted time or less. Today's meeting will be run according to the Open Meeting Act as required by law, and we plan to end today by 5 p.m. I would like to now call this meeting to order at 11:06 a.m. Ms. Nadar, please call the roll.
Mr. Arkatov,
Here.
Ilia Rodriguez,
Here.
Ms. Chung,
I'm here.
Ms. Holmes,
Here.
Dr. Mahmood,
Yes.
Mr. Portillo, Dr. Solis,
Here.
Dr. Tarp,
Here.
Dr. Talbot,
Present.
Ms. Torres,
Present.
Dr. Sai,
Here.
Mr. Watkins,
Present.
Dr. Yep,
Here.
Ms. Lawson.
Here.
Thank you.
Thank you. A quorum is present. I would like to remind the members again that we will be taking a roll call vote on all action items. We're now moving on to agenda item 2, public comments on items not on the agenda. Before I ask for public comments, I would ask individuals making comments to not discuss pending complaints, pending licensing applications, or pending disciplinary actions that may come before the board for a decision. Such discussions are considered ex parte communications, as they could provide information to the members that is outside of the record in violation of the Administrative Procedure Act. Therefore, such discussions could create a conflict and lead to a board decision being challenged in Superior Court. The board can receive comments regarding the board's processes in general, but it cannot receive comments on specific case circumstances where a decision is still pending. In addition, the board requests the public to address the board as a whole and not individual members. And please be aware that public comments during this agenda item should provide information to the board members and is not a discussion between the board members and the public. The only action board members can take is to listen to comments and decide whether they'd like a future agenda item on the topic. No other action can be taken on the item at this meeting. Though this may seem at times like the board members are being unresponsive, following these guidelines is critical to ensure the rules of the Open Meeting Act are followed and to avoid compromising the speaker's goals or the board's mission. If you want to comment on an agenda item, please do wait until we get to that agenda item. Comments at this time are only for items that are not on our agenda. Please limit your comments to 3 minutes or less. First, are there any public comments from those present in the hearing room? All right, seeing none. Sean, are there any public comments on WebEx?
Yes, if you'd like to make public comment, do so by raising your hand. I'm just opening up that Q&A window right now as well too. So if you have a question, you don't have to type it in that Q&A window. You can just type your name or anything in there that you'd like to make a public comment. We'll get you called on. First up here, we have Susanna. Susanna, you should be receiving a prompt on your end.
Hi, good morning. Can you hear me?
We can, Susanna. Please go ahead.
Hi, my name is Susanna Zaraisky. I am the citizen sponsor of AB 3119, the bill that passed almost 2 years ago by all of the members of the Assembly and the Senate to add a class on long COVID and other post-infectious diseases to the CME requirements for doctors and other medical providers. The medical board has successfully ignored putting this bill on your legislative agenda since the bill was signed by Governor Newsom in September of 2024. I don't know what is going on. I have written to you, other people have written to your board. This is my 6th time testifying in your public comment period, asking you to add the bill to your legislative agenda. I think what you're doing is a desecration of the democratic process. You are not stronger than 120 legislators and the governor. They voted on something. You, as part of the democratic process, are supposed to discuss it in your legislative agenda. Doctors are supposed to have empathy for their and understand what's going on with them. You, as medical board members, are supposed to have empathy for Californians who have new medical situations that doctors did not learn about in their medical training. That is why doctors need to learn about long COVID and other post-infectious diseases. Some people get chronic fatigue after a flu, and they're misdiagnosed by their doctors because their doctors don't know what to do with them. I'm asking you to think about putting yourself in the shoes of the people who have long COVID, of the people who have post-infectious diseases and can't find help. Women are 31% more likely to get long COVID than men. There's a new virus strain right now called cicada, and some medical professionals say that the cicada virus can evade the protection of current vaccines. That means that more people are going to get long COVID. Or first they're going to get COVID and then they're going to get long COVID. And guess what's going to happen? They're not going to find doctors to help them, or there's going to be a long waiting list. When I got long COVID, the waiting list was 5 months at the Stanford Clinic, 5 months. The point of having medical providers learn about long COVID is so that they can help their patients without sending them to specialized clinics that have long lines. I made a video that you can all find on YouTube asking Governor Newsom to take action. It's called Newsom, take action on AB 3119, long COVID medical education. I'm asking him to fire the people on the medical board whom he appointed, who are acting like kings and evading the democratic process and not discussing this long COVID bill. You do not belong in the medical board. Thank you.
Thank you for your public comment. Next here we have Marion Hollingsworth. Marion, you should be receiving that prompt.
Okay, can you hear me?
Can Marion, please go
Okay.
ahead.
Good morning. Thank you. Good morning. My name is Marion Hollingsworth, and I'm a patient safety advocate. I have asked for this accommodation before, and I'm going to ask again. These board meetings are always during the day, making it difficult for working people to attend even online. Some people don't have the ability to leave a classroom or a hospital ward to just go online to make a comment or listen to an issue that they are particularly interested in. It would be great if you would occasionally have a meeting or at least one of the days during the evening or have one of those days on a Saturday. This will allow more consumers to have access to the board and make comments on a particular issue. So please making this accommodation at least once a year. Also, I also back what Suzanne, the previous commenter, said about making a CME requirement for doctors to take a class on long COVID. As someone who has a family member with long COVID, it is so important for doctors to know about it because so often they go, well, I don't know what to do with you. So that would help to have more doctors trained to know how to deal with it, since it is an ongoing issue and long COVID is not going away. So please make that a requirement. Thank you so much.
Thank you for your public comment. Had an individual on the Q&A say they'd like to make a public comment, but they identified themselves as anonymous. They could either enter their name they joined the meeting with in there, I can call on them, or they can just use the standard hand raising feature. That would work as well. Last up here right in queue right now, we have Rob Gordon. Rob, you should be receiving that prompt.
Sean, are you able to hear me?
It's a little low, Rob. Maybe if you could come a little closer.
How about now?
That sounds good.
Yeah, I agree with both the past callers. They both made excellent points, especially about what an undemocratic process this is. At the board meeting more than a year ago, when the couple members got extremely upset, you had a legislative analyst or whatever marketer to a legislative promoter that got appointed to the board. They just made some really, really good points at that time about just how you block how the what your board said that this was the first place people go to. It is the last place that people go to. This is the final step. After that, you're out of the democratic process. So you guys are an effective block. I wanted to make just that point. The other one I want to make really quickly is that, and I say this every single time, I believe you are entrapping people with the form on your website. No one should ask for help from the Medical Board of California unless you have an attorney first, unless it's already part of the legal system. You're going to get a cease and desist order, maybe today, certainly by Monday, about that. I'm also launching an investigation about your CEO and some accusations he made about me. So you'll be hearing about that also. You can reach me. Anybody wants to reach me, doctors or patients. I'm neither. You can reach me at abolishmbc.org, the website abolishmbc.org. I am an opponent of the Medical Board of California. I'm open to talking to anybody. Anyway, thank you for listening and have a great meeting.
Thank you for your public comment, Rob. At this time, I do not see any additional requests in queue.
Thanks, Sean. Just one last check. Are there any public commenters in the room? Okay, seeing none, we'll close that agenda item. We'll move on to agenda item 3, approval of minutes from the last board meeting. Just as a reminder, our minutes are a summary and a record of our votes, but the full recorded meeting is posted on the board's website. Members, are there any corrections to the February 26th and 27th, 2026 board meeting minutes? May I have a motion to approve those board meeting minutes as submitted?
Make the motion.
Sorry, who made the motion? Dr. Mahmood, may I have a second?
Second.
Second from Dr. Ayala Rodriguez. Are there any comments from the public in the hearing room? Sean, can you check for any public comments in WebEx, please?
Yes, if anyone would like to make a public comment here on agenda item number 3, please do so by raising your hand or type anything into that Slido window now. Give you a few seconds to see if anyone queues up. Not. Oh, here we go. Rob Gordon should be receiving that prompt now.
Yeah, just really quickly, it was mentioned that there's, I'm sorry, forgetting the board members, TJ mentioned that he's been talking to NBC. I'm just wondering if we can get that contact. We might, some of the opponents of the medical board might want the contact at NBC also. That's all. Thank you.
All right, Rob. Thank you very much. No additional requests in queue at this time.
Thanks, Sean. We'll bring it back to the board. We've got a motion pending to approve the minutes. Ms. Nadar, would you please perform the roll call vote for us?
Mr. Arkadov,
Yes.
Dr. Ayla Rodriguez, Ms. Chang,
Yes.
Ms. Holmes, Dr. Mahmood, Dr. Solis,
Yes.
Dr. Tarp,
Yes.
Dr. Tolbert,
Yes.
Ms. Torres,
Yes.
Dr. Sai,
Yes.
Mr. Watkins,
Yes.
Dr. Yep,
Yes.
Ms. Lawson.
Yes.
Thank you.
Thank you. The February 26th and 27th, 2026 board meeting minutes are approved. Moving on to agenda item 4, the president's report. As a first matter, it is my distinct privilege and honor to pause today and recognize someone who has given an extraordinary amount of himself to the people of California, our Chief of Legislation and Public Affairs, Aaron Bone. Aaron, 25 years of public service is not just a milestone. It is a testament to dedication, integrity, and a genuine commitment to public service. Aaron joined our board's executive staff in July of 2020, and in the time he has been with us, he has been an invaluable member of the team and a trusted voice on some of the most complex legislative and policy matters we face. But Aaron's record of public service extends far beyond our doors. Prior to joining the board, he served as the Information and Planning Officer for the California Board of Accountancy for nearly 4 years. And before that, he built an impressive foundation of experience holding positions with the Board of Equalization, the State Senate, and the State Assembly. Aaron, the work that you do every day matters deeply, and it has had a real and lasting impact on public protection and access to quality medical care. On behalf of this board, your colleagues, and the people of California, thank you for your expertise, your professionalism, and your unwavering dedication. It's now my honor to present you with a plaque in recognition of your 25 years of outstanding public service to the great state of California. Thank you, Aaron. We want to pick, someone's going to take a picture. Do you want me to come down there or up here in front of the? You go. In front of the seal. Seal. Dr. Yip, do you want to? Yeah, if you want to. Great, thank you. Congratulations again, Aaron. That is very well deserved, and I enjoyed very much the opportunity to work closely with you over these years. Before we return to the business of the board, I hope you will indulge me in a few personal remarks this morning. This is my last official meeting as a member of the Medical Board of California, and my final term on this board concludes officially next week on June 1st. I want to start with gratitude to the 2 governors who entrusted me with the privilege of serving on this board. I was first appointed in October of 2015 by Governor Jerry Brown. That appointment occurred shortly after the sudden death of my father, who was a physician. And that appointment was profound and really deeply personal for me. It gave me a way to honor my dad's life work through public service. Governor Brown reappointed me in 2018, and Governor Gavin Newsom reappointed me in 2022. I am grateful to both governors for their confidence in me and for their shared commitment to protecting the healthcare consumers of California. I want to also express my deep gratitude to my fellow board members, past and present, for the extraordinary honor of electing me to serve as your board president 4 separate times. You placed your trust in me to lead this institution. I've never taken that trust lightly, and it has been among the greatest honors of my professional life. When I reflect on more than a decade of service on this board, I see a board that has been tested and strengthened in equal measure. We navigated a once-in-a-century global pandemic together. We faced sunset review processes that forced us rightly to examine ourselves with honesty. We confronted attempts by well-organized, well-funded groups to intimidate and undermine our work. And through it all, the board kept its focus on the people that we serve, the patients and healthcare consumers of California. I want to speak briefly about the COVID-19 pandemic because it was a defining part of my service on the board. As I assumed the board's presidency for the first time in 2020, California and the nation were in the grip of a crisis that exposed every fault line in our healthcare system. The board was called upon to act with urgency, and we did. We worked to ensure that our enforcement mission continued without interruption while all of our staff transitioned to remote operations. We communicated with licensees about their obligations during the emergency, and we made clear unequivocally that the spread of medical misinformation by licensed physicians posed a very real and a very serious threat to public safety. That stance was not without personal cost. As some of you will recall, in December of 2021, members of America's Frontline Doctors, an organization that Congress was investigating for defrauding consumers, surveilled my home. They flew a drone over my house. They watched my kids leave for school. They followed me to my office, and they ambushed me in a parking garage with cameras. They later released a 21-minute video about me, which resulted in threats against me from across the country. It was, as I said at the time, a terrifying experience, but it was also clarifying for me. Those vile threats did not deter me, and they did not deter this board from our mission. What carried with me since then, and what carried me through that, was the immediate, unequivocal support of partners who stood beside this board and who stood beside me during that time. I want to extend a special thank you to all the board staff, my board colleagues, and also to the Federation of State Medical Boards and the California Medical Association, who did not hesitate then. They condemned the stalking and the harassment publicly and forcefully. They reminded Californians that vaccines are safe, effective, and life-saving. Then State Senator and physician Dr. Richard Pan also spoke out in strong condemnation, and many others across the healthcare and consumer protection communities from across the state and across the country made clear that attacks on public health officials are attacks on the public itself. I'm deeply grateful to each of them. The board has accomplished a great deal over the past decade. I want to take a moment just to reflect on a few things that I'm most proud of. We did successfully navigate together multiple sunset review processes, one of the most rigorous forms of legislative oversight that any agency faces. Those processes resulted in SB 815, signed into law by Governor Newsom in September 2023, which renewed the board through 2028 and enacted meaningful reforms. SB 815 was not just a renewal bill for this agency, it was a patient's rights bill as well. It established the Complainant Liaison Unit to improve communication between injured patients and the board, required the board to interview patients before closing their complaints, and it created the right for patients and their families to submit impact statements before physician discipline is issued. These were reforms that patient advocates had fought for over many years. We listened and we championed them. One of the initiatives I'm most personally passionate about is the development of a physician health and wellness program for California. Physician burnout, mental health challenges, and substance use disorders are real, and they affect patient safety. Beginning in 2024, this board began the serious work of new legislation for a robust, confidential, non-disciplinary physician health program grounded in national best practices. California has long lacked such a program, and with AB 408, we are working to change that. I'm proud that we set this work in motion, and I have every confidence the board will see it through. Relatedly, the board also worked to revise physician license applications, questions related to mental health conditions, reducing stigma, bringing our practices in line with current evidence, and encouraging physicians to seek help without fear of professional repercussion. These changes reflect the kind of thoughtful, evidence-based governance that I hope will define this board's legacy. None of this work happens in isolation. I do want to take another moment to recognize the advocates and partners who have made this board better. To Michelle Montserrat Ramos and Consumer Watchdog, your tenacity and moral clarity have made this board more accountable, more transparent, and more genuinely focused on the patients it serves. Michelle's advocacy was born of personal tragedy and has been sustained by extraordinary dedication. Through her work, families across California have found their voices in a process that too often left them feeling invisible. The reforms in SB 815 bear her fingerprints, and the patients who will benefit from them may never know her name, but we do. Thank you, Michelle. To the California Medical Association, thank you for standing by me when it mattered most. When anti-science extremists targeted me, and by extension this board, the CMA did not equivocate. Your immediate and public condemnation sent an important message that the medical community in California will not be intimidated by those who traffic in fear and misinformation. That partnership between the regulator and the regulated is at best when it's one of mutual respect and shared purpose. Thank you. I also want to recognize the Consumer Protection Policy Center at the University of San Diego School of Law, which was formerly known as the Center for Public Interest Law, which many of us still know it by. Founded in 1980, the CPPC has served for decades as an independent academic monitor of California's regulatory agencies, including this one. Its faculty, staff, and student interns have tracked our proceedings, published rigorous analysis in the California Regulatory Law Reporter, and they have shown up at our hearings to hold us accountable to our mission. That kind of sustained, principled oversight makes regulatory boards stronger. I'm grateful for the partnership, and I commend their continued work to future board members as a vital and trusted resource. To the Federation of State Medical Boards, thank you for your leadership at a national level and for the profound honor of the 2022 Award of Merit. Receiving that recognition meant more than I can easily express. The FSMB's decision to convene its Ethics and Professionalism Committee to develop national guidance on medical misinformation was exactly the kind of leadership that state medical boards needed. Sent a clear message that the integrity of the medical licensure system would not be surrendered to bad actors. I was honored to participate in that work and to be part of a national community of board leaders who refused to be intimidated. And I want to acknowledge the broader House of Medicine, which is a constellation of national medical organizations that came together during COVID to confront the disinformation crisis. I had the opportunity to participate in several of those convenings, and they reinforced for me that the challenge of medical misinformation is not unique to California. It is a national and generational challenge that requires sustained collaboration among regulators, medical societies, educators, and advocates. The work we do here in California exists within that larger effort, and I'm proud that this board played a role in shaping the national conversation. I also want to express my profound gratitude to the staff of the Medical Board of California. You are the backbone of everything that this board does. I want to especially thank Reggie Varghese, who stepped into the executive director role during a significant transition and has led with steadiness, professionalism, and a genuine commitment to the board's mission. Marina O'Connor, Carrie Webb, Aaron Bone, and so many others across every division of this agency, licensing, enforcement, legislation, communications, and beyond. You show up every day for California's healthcare consumers. Us board members, we cycle in and out, but it's the dedicated staff who carry the institutional knowledge and the mission forward. I've been honored to work alongside you, and I'm deeply grateful for the opportunity to collaborate with each of you. Thank you for bearing with me. I also want to thank the families and communities of California's Central Valley, particularly in Bakersfield and the greater Kern County region. You came to our meetings year after year, and you would not let this board look away from the maternal mortality crisis unfolding in your communities. You shared stories of daughters, partners, and mothers lost to complications that should have been caught. You were grieving, and you were also organizing, and you were right. In August 2023, I made it a priority to take this board to Bakersfield, what was believed to be the first time the board had ever held a quarterly meeting there, and to dedicate the majority of that meeting to listening and learning about maternal health outcomes. The purpose, as I said at the time, was to educate ourselves so that we could be part of the solution. We followed that meeting with a meeting in Fresno in April of 2024 to continue that engagement with the broader Central Valley. To the families who shared their stories with us, Tracy Dominguez and so many others, your courage has made this board better. We've not forgotten you, and the work is not finished. And to the many other advocates, patient safety organizations, legislative staff, and community members who've showed up at our hearings, submitted public comment, and pushed us to do better, thank you. A regulatory board is only as good as the public it serves, and the public's engagement with this board has made it stronger. As I close, I want to speak to the future because the work of this board has never been more consequential. As we all know, artificial intelligence is transforming healthcare at a pace that our regulatory frameworks have not fully matched. California has taken some important early steps. AB 3030, effective in 2025, requires healthcare entities to notify patients when generative AI is used in clinical communications. But the deeper questions about AI's role in diagnosis, treatment, and the standard of care are questions that this board will need to grapple with in the years ahead. The opportunity to ensure that AI serves patients rather than displacing physician judgment is both urgent and profound. Telehealth has also permanently changed the landscape of healthcare delivery in California. Nearly half of California adults reported using telehealth services in 2022, and that number has only grown since then. The board's role in ensuring that telehealth services meet the same standard of care as in-person visits and that licensure requirements keep pace with cross-jurisdictional practice will be ongoing. The opportunity to expand access to care in underserved communities through telehealth is extraordinary, and this board has a role to play in making that both possible and safe. California faces a serious and worsening physician shortage, particularly in primary care in our rural and underserved communities. The board's licensing processes, its work on expediting licensure for qualified physicians, and its partnership with medical education institutions will all have a role to play in addressing this crisis. I encourage the board to continue seeking ways to be a partner in expanding the physician workforce, not by lowering standards, but by removing unnecessary barriers to qualified practitioners who want to serve California. And there are reforms over the years that we did not complete that still deserve our continued attention. The burden of proof standard for physician discipline, clear and convincing evidence here in California, while 41 other states use a lower threshold, it still remains an obstacle to accountability. Also, the public membership majority that would strengthen consumer trust in this board was not achieved in SB 815. These are unfinished items on a long agenda, and I encourage this board and its future advocates to keep it pressing. Over more than a decade, I've watched this board grow. I've watched it struggle, adapt, and persevere. I have served alongside extraordinary colleagues, physicians, and public members alike who bring dedication and expertise to work that is often thankless and frequently contentious. I've seen our staff navigate seemingly impossible circumstances with professionalism and grace. The mission of the board to protect the people of California by ensuring that their physicians are competent, ethical, and accountable is as important today as it has ever been. I leave believing deeply in that mission and in this institution's ability to fulfill it. To the members of this board, it has been the honor of my professional life to serve alongside you and to lead this institution 4 times as your president, carry this work forward. To the patients and advocates who trusted us with your stories, your grief, and your hope, you're why we're here. Thank you. And to this board, California is lucky to have you. It has been a privilege. Thank you. Thank you all.
Hello? Yeah. In honor of Christina Lawson, President, Medical Board of California, who served this board from 2015 to 2026. With profound gratitude, we recognize Christina Lawson for her exceptional leadership and unwavering dedication during her tenure as President of the Medical Board of California. Her vision and tireless efforts have played a pivotal role in advancing the health and safety of California patients. With heartfelt gratitude, we recognize Christina's tireless work to build bridges between healthcare professionals and consumer advocates, fostering a collaborative environment focused on improving patient safety and advancing the public interest. Christina's commitment to addressing the well-being of physicians culminated in her championing of AB 408, the groundbreaking physician health and wellness legislation. Her vision for a more supportive, balanced healthcare workforce led to critical reforms aimed at improving the mental health and wellness of physicians, ultimately benefiting both practitioners and the patients they serve. Through her dedicated advocacy, Christina ensured the medical board's actions remain patient-centered, transparent, and accountable, while also supporting the health and sustainability of the medical profession. Her collaborative spirit and dedication to innovative solutions will have a lasting impact on the future of healthcare in California. Thank you, Christina Lawson, for your unwavering leadership, your work with consumer advocates, and your profound contributions to the health and wellness of California's medical community. Your fellow board members and your board staff is proud to
Thank you.
honor you with this plaque and certificate. And I ask Ms. Christine Lally, the acting director of DCA, to join me on the podium.
It's bittersweet. Work.
There we go. Really can't believe this day has arrived. It never seemed possible, but I just, on behalf of the department, President Lawson, I just wanted to give our heartfelt gratitude for your more than a decade of service. I was thinking back to when you started, when you said 2015, I was in a different role, you were in a different part of your life, and here we are. And the years of collaboration that in partnership, we've been able to have, as well as the former director, Kim Kirkmeyer, who sends her congratulations and gratitude as well. Unfortunately, she's out of town, or she would also be here today to send you off in style. But we wanted to, again, just give our thanks and gratitude for your very, very dedicated service. You've always gone above and beyond and led with, heart and integrity, and we are all better for it. So thank you so much. I think back to our board member orientation, and we always say, it's not going to be easy, but it's going to be worth it. And I think your more than a decade of service is proof of that. So thank you so much.
Thank you. I appreciate that very much. All right. Thank you all. Continuing the work. Next, I'm pleased to announce the appointment of Dr. Solis and Ms. Holmes to the Maternal Health Task Force. California has made significant progress in reducing maternal mortality, particularly through the work of the California Maternal Quality Care Collaborative and its development of evidence-based toolkits that support improved maternal and infant health outcomes and advance our shared goal of eliminating preventable maternal morbidity and mortality. The task force will identify opportunities to collaborate with CMQCC, the California Department of Public Health, and other maternal health experts and agencies in support of our mission of consumer protection. I'm grateful to the families and patient advocates who continue to bring attention to this critical issue, and I look forward to continued public engagement and meaningful progress towards ending preventable maternal deaths. Finally, I am reporting on the following contacts with interested parties. As is typical, I receive a number of communications and I forward all of those on directly to board staff. Are there any questions or comments, including contacts with interested parties or comments on the president's report from board members? All right, seeing none, are there any comments from the public present in the hearing room today? Welcome.
Hello, my name is Lucas Evanson. I'm not speaking on behalf of the California Medical Association today. I'm sorry I wasn't able to prepare a comment. So I will just personally thank you for your service on the medical board. I have honestly marveled at your leadership. I think my personal biggest takeaway has been just your commitment to both the medical board's values and your own personal values as you lead the board through some of the most tumultuous times of the past 100 years. Well, maybe not 100, but maybe a long time. And I'll also just make an observation, since I feel comfortable saying this, since I was not here while CMA stood behind you and defended you from those who were stalking you. So I don't know why they did that, but my observation would be that they probably felt relieved or lucky to have someone that they could stand behind and could defend, because that doesn't exist everywhere in the country. So I just hope that you feel thanked and honored because your work here has been truly impressive. Thank you.
Thank you. Are there any other public commenters in the room? All right, Sean, let's open it up on WebEx.
Yes, if anyone would like to make a public comment on the president's report, please do so by raising your hand or typing anything into that slide-in window. We'll get you called upon. First up here, we have George. George, you should be receiving that prompt. Okay, George, I don't see it coming off mute there, so we're going to move on to Rob. Rob, you should be receiving that prompt. Rob, your line's open. Okay, Rob, I'll come back around to you. You work that out. If you raise your hand again, we'll get you back in queue. Next up here, we have Alex Rounds. Alex, you should be receiving that prompt.
Hi, I just want to say thank you on behalf of the California Association of Licensed Midwives. We're also in a time of transition, and our new leadership is looking forward to working closely with the medical board and MAC, but recognize the incredible amount of work around especially maternal health that has been moving so quickly, and that there's so much more work to do there. So just thank you so much.
Thank you for your public comment. Here, we'll go back to George. George, you should be receiving that prompt again.
Can you hear me?
We can, George. Please go ahead.
Sorry, I put my name in as George Clooney today. It's Eric Andrist. It's amazing how you all see things so differently within your little bubble than how the rest of California sees this board looking in. Christina, we started almost around the same time, but as longtime advocates, we weren't even really noticed in your thanks today. And I know we've had a lot of back and forth and that you didn't like a lot of what I said, but you know, I do a lot of good and I help a lot of patients and do a lot of good. So it was noticed that you decided to only mention the one really public person, Michelle. You spent most of your original term, and I did hen scratching here. I didn't know this was going to be on today. Most of your original term sitting on your hands. The first several terms before you even were voted presidents, you barely ever said a word. You never raised your hand. You never talked about anything. And I used to comment on that. You ended doing nothing but to promote the CMA agenda and block transparency and advocate participation. It's because of you that the advocate meetings that I can't remember her name now, the other president, started for us, you stopped them. That's why advocates don't have a voice anymore with the medical board. Your soapbox on misinformation was two-faced, as you spouted so much disinformation during your term yourself. It was pathetic. You milked it to draw sympathetic support from the board and clearly have manipulated and scared new board members to follow you. You never listened to advocates. You stopped the advocate meetings. You pretended, and they tossed, oh gosh, sorry, I'm having trouble reading my hand scratching. They tossed it out as some of the meetings. And then you tossed it, you'd pretend to listen to us, and then you just toss it out as you left the board meetings. As I've said before, your physician father is nothing but rolling over in his grave for what you've done to side with a doctors union instead of patient safety. I will personally follow your political career to make sure that the public knows exactly where your allegiances lie. I hope now that you're gone, the board will feel free to really protect patients and not their political ambitions, and the CMA, a group whose majority of California doctors refuse to join. There's a reason for that. You're such a politician. You mentioned all of the correct buzzwords in your thanks speech and thanked only the people who couldn't really hold you accountable and that you refused to work with. You'd go off and have your meetings with the CMA. You never had private meetings with any of us real advocates that are out here working on in the trenches. So I say good riddance to you, Christina Lawson. You've done a lot to let dangerous doctors off the hook. That's your legacy, Christina Lawson, on this board, that you have let a lot of
Please
dangerous
conclude.
doctors walk. Thank you.
Thank you for your public comment. Next here, we'll go back to Rob. Rob, you should be receiving that prompt again.
Any luck this time, Sean?
Yeah, we hear you now, Rob. Thank you.
Okay. I guess I'll start with something nice for Christine. She does know how to run a public meeting, and I've heard other opponents of hers, including Eric, say that. But in this organization, when that's all you have, it really blocks public discourse. I'm one of the voices that has been silenced. When you talk about the San Diego guys, you're talking about, I always forget their names too, consumer protection, whatever, at the University of San Diego. That's because that's one of the institutions. They kind of have a play opposition to you. I have reached out to them. I think of the San Diego guys very different. The judge, in whatever, that's Office of Administrative Hearings, local attorney generals, the guy who I thought was interviewing me, but did a frame up of my real psychiatrist. I could go on and on. I think I'll just quickly make the point about vaxxers, because that was a class in spin. Just let me say, I'm a pro-vaxxer. I believe in vaccines. I have an undergraduate degree in microbiology and public health. You are not hearing the whole truth from that community. Erica's right. You're in a bubble. That's not the whole truth of what's going on. They're not anti-science people at all. There probably are some of them, but that's not the majority of what is going on. So maybe that was my bubble a little bit too, but I did learn from reaching out to them. So, this whole thing is really about an abuse of power. We're heading up to an American holidays that's always been held to me. I made it clear that I did not accept the concept of forced psychiatry and fabricated psychiatric conditions that were endorsed by you. This organization cooperated with the prosecution against me. So, I'm not leaving with any fond memories of this whole thing. And I do agree, it should follow. I said retaliation in my last comment. I'm really done, but I have to say very much I was talking about political retaliation, nonviolent. So anyway, good luck with whatever you decide to do, but there's still victims out there.
Thank you, Rob. Next up here, we have Anne. Anne, you should be receiving that prompt.
I don't know why it came up. This is Tracy Dominguez. I just wanted to thank you, Mrs. Lawson, for hearing the voices and families in Bakersfield throughout California while supporting Save a Mom, Save a Family. Your compassion and willingness to listen and helping bring awareness and change for mothers and families across the communities. Thank you very much.
Thank you very much. Next here, we have Michelle. Michelle, you should be receiving that prompt.
Good morning. I'm Michelle Montserrat Ramos, and I'm with Consumer Watchdog. Board President Lawson, it's been an honor to work with you. We have gone through sunset reviews together, and as you mentioned, we have accomplished critical processes through legislation, which will begin to make the enforcement process more equitable for families. We're able to obtain these victories for consumers and patients due to your support, and we'll always be grateful for that. Although we have been on opposing sides due to current legislation, we have always believed that we will always have more in common, and that is to continue to support actions that will protect consumers, patients, and families. Thank you for your service to Californians. We will wish you the best. Thank you.
Thank you, Michelle. This time, there are no additional requests in queue.
Thank you, Sean. We'll bring it back to the hearing room. Are there any last public commenters present in the hearing room? All right, moving on to agenda item 5, which is a presentation by the Interstate Medical Licensure Compact. Marshall Smith, the IMLCC Executive Director. I'm pleased to welcome our speaker, Marshall Smith. Mr. Smith has more than 35 years experience in government and health administration. He's been Executive Director of the Interstate Medical Licensure Compact Commission since 2017, overseeing its growth from 17 to 45 member states and territories. We very much appreciate you joining us today to discuss the Interstate Medical Licensure Compact. It's a mouthful. Welcome.
Thank you, Madam Chair. I'm joined with Rick Masters. He is our the General Counsel for the Interstate Medical Licensure Compact Commission. And if we could start the slideshow. Okay. This is, I believe, the first of many conversations that the board will need to have about the Interstate Medical Licensure Compact Commission. So what I wanted to do is provide some groundwork about that discussion and about what the commission is, what it does, what it doesn't do, and some of the options that you have as in the state of California about joining the Interstate Medical Licensure Compact Commission. Is it? All right. So what we do is actually very simple. There we go. The Interstate Medical Compact Commission was founded on the principle that each state has the sovereign right, pursuant to the 10th Amendment of the Constitution, to define what constitutes the practice of medicine by physicians authorized to practice medicine in that state. What the compact does is it creates an alternative pathway or an expedited pathway for physicians to obtain the full and unrestricted license to practice medicine in your state that they would obtain if they went through the traditional method. We have alternative high bar, bright light standards that physicians have to meet in order to be able to use the compact process. And I'll cover those in just a second. And the next slide, please. One other thing I wanted to mention, so the California Medical Board, or the Medical Board of California, sorry, you are the first to publicly hear this announcement, but we now have our 44th member state. The legislation passed in the state of Alaska yesterday and is on the way to the governor's desk. So we're very excited about that. We have 6 more states to get into the compact. So the compact itself is a governmental instrumentality, which is a fancy name for meaning that we become a part of each state's government. It is the mechanism by which our process becomes expedited. It is the way by which we are able to get licenses issued to physicians on average in 7 to 10 days. The way that we're able to do that is that physician is licensed in a state. That state already has all of the primary source documents. They know where they went to medical school. They know the attempts that it took, number of attempts to pass the USMLE or the COMLEX. They pull a fingerprint-based background check, and they pull the MPDB report and the DEA report. So they have current information about that physician. The physician fills out an online application. That online application is verified by that member state. The other states then issue the license based on that documentation, the application, and the certification from that other state. That ensures that the physician is eligible. Your state then issues the license. You do not have to get those documents. You don't have to do the fingerprint-based background check. All of that's been done by another member state. Physicians that have used our process, there are currently 43 member states, are able to get 42 licenses in 7 to 10 days through our process. It's a high standard. Our member boards do incredible work. We have issued over 120,000 letters of qualification, or these documents that boards have said are the valid document that the physician meets the requirement. Of those 120,000, 80 have been found to not be valid. Once the board, and most of those are through boards doing their own internal auditing, they found that there was an error made by staff. They found that there was updated information that they needed to express to the other member boards. That's a pretty good odds, and our states do an incredible amount of work to do that. So back to what the compact is and what is a governmental instrumentality. The U.S. Constitution, when the founding fathers started our country and made that decision 250 years ago, that we were going to do this, it's less than that for the Constitution, sorry, is they realized that states had to be able to make arrangements and agreements between each other. That's what a compact is. That's what we are. It's a legal agreement between your state and the other states that are part of the compact. The next slide. Our organizational structure, just putting this out here so you understand it. We are governed by our commissioners. We are a commission-run organization. We have an executive committee. As the executive director, I also serve as the secretary on the executive committee. Our commissioners meet twice a year. We just met on May 12th. Our commissioners approved our budget. We had several other discussion items, but we do meet at least once a year in person. And each state appoints 2 commissioners to serve on that commission. We do have a staff. We currently have 24 staff members on our staff. Next slide, please. So there are currently 46 member jurisdictions. If you'll let me add Alaska to that, it's 43 states plus the District of Columbia and the Territory of Guam. That represents 54 different medical boards. We currently have 40 of those member boards active and in full participation. We have 2 member boards that are still working on being able to obtain fingerprint-based background checks, so they cannot act as a state or principal license yet. And we're working with them. And then we have 3 member jurisdictions. Once the legislation passes, it takes about 3 to 6 months of training to get the board ready to do it, and then about 2 to 3 months after that to actually fully implement the process. We have over 60,000 physicians that have used our process, and over 200,000 licenses have been issued. It's important to note that while the compact may sound like it is something that is new and unique, it is not. Physicians get licensed in multiple states all the time. What we do is we create a mechanism so that your board retains control over the practice of medicine. You issue a full and unrestricted license. We have a different pathway to do that. I like to use the analogy of when you go to the airport, everybody has to go through the X-ray machine. There are 2 ways to get there. You can do the traditional way, which is fine and great and works very well, especially here in the state of California and our other member states, or you can do an expedited TSA approved method where you have a quicker pathway to that X-ray machine. The compact works that a similar manner. If you'll go to the next slide, the compact does have authority to make rules and has bylaws that govern its practices. We also have a series of policies that define what we do. These rules, policies, and bylaws are binding on all of our member states as part of the compact. We have an extensive rulemaking hearing. There are at least 6 opportunities for our member boards to provide comments during our rulemaking process, and the fastest we've ever done a rulemaking is about 9 months. So it is a very deliberative process. It's very involved, and it involves a lot of time and effort to make sure that we get it right. And all of these rules are on our webpage, and you're welcome to review those. The next slide, please. So I also wanted to do a little bit of level setting, especially as it relates to shield laws. I know this is a very important issue to the state of California. It's a very important issue to a lot of our member states that are currently part of the compact. The opposite is also true. There are states that believe that it's appropriate to restrict the access to care, women's health care issues. Those states have an equal right to enforce that and to provide that level of protection to their citizens as a state that develops its shield laws does. The thing about it is, and the most key takeaway of all of these items that I've listed there for you to read at your own leisure, is that one state may not take action against another state's physician for doing the practice of medicine that's licensed in that state. And I'll give you the most common questioned activity and the situation that we're made very aware of is there are physicians in Colorado, which is a member state, that are able to perform abortions. They are also licensed in the state of Texas, where they are not permitted to perform abortions. Texas may not investigate the activities of that physician in Colorado under their Colorado license. They can investigate that physician in Texas. They can investigate how they follow their Practice Act, but they are not allowed to cross that border. And the Dobbs decision, for all of its detractors and proponents, reinforces that idea. Joining the compact makes your state's shield laws stronger. It reinforces the idea that your state has the right to control the practice of medicine in this state, and it controls that right through the issuance of a license. Put up some more items about that because this is an important issue. There have been states, recently New Mexico joined the compact. They provided, they may not change the compact language. It's a common contract between all of our states, but they did add provisions that provided instructions to their medical board regarding issues as it related to their shield law. And I'll give you the one of several examples, but I'll just give you one. That example is they instructed their board that they may not participate in a joint investigation if that joint investigation is in regards to the performance of women's health issues or related to their shield law. Joint investigations, and I'll talk to that for just a second, is the ability under the compact for our member states, investigative units, to talk to each other. Most states have very siloed investigative properties. Their investigators, the board cannot acknowledge that an investigation exists. They can't share that information with any other member state. The compact allows for the voluntary creation of joint investigations between our member boards so that those member boards can compare information and those investigators can share information with each other. We've had 2 joint investigations, and the one that I'm the most proud of because it really did protect the public in a very strong manner. There was a physician who was licensed in 12 states through the compact. That physician was sexually abusing patients in most of those states. There were ongoing investigations in all of those states. They could not gather sufficient information or evidence to be able to take action. The compact, 5 of those states formed a joint investigation. Those 5 states investigators compared notes. They now had more than enough information to be able to take action on that physician. Within 45 days of opening the joint investigation, the physician had lost all 12 licenses and is currently serving in a federal penitentiary. So it is a powerful weapon that is made available to our states. It is used judiciously and importantly. So Let's go on to the next slide. The other thing I wanted to address, kind of the elephant in the room, was the Oregon white paper. A copy of that was provided to you, and and I can provide that to anyone that is interested in that. The state of Oregon, their medical board has repeatedly determined that joining the compact, and they have stated publicly that joining the compact, they believe, is a threat to the public health, safety, and welfare of the citizens of the state of Oregon. The compact itself does not believe that. We are currently operating in 43 states, the District of Columbia, and the Territory of Guam. However, the compact does support each state's right to determine whether they want to join the compact, and the right to determine what is best for their citizens. We did respond to that at the request of the Oregon Hospital Association's chief medical officers, and a copy of that reply was given to you. There are three of the highlights that I would like to make. First is that the state of Florida did join the IMLCC in March of 2024. Those boards, the two boards in Florida, process about 75 license requests a week, and they receive about 55 letter of qualification requests, or those are Florida licensed physicians wanting to use the compact to be licensed in other states. There are 154, as of April 30th, there are 154 of our 60,000 physicians that have been disciplined, resulting in 314 actions. Joining the compact makes it easier if a physician is disciplined for your board to take action against that physician. And that's why there are 154 physicians and 314 actions. And finally, 84 of the, as I mentioned before, 84 of the 120,000 LOQs, or letters of qualification, have been determined to be invalid. We immediately notify all of the member boards of that fact so that they can take action on that. Some general comments, and I'll be winding down in the next couple of minutes, is that about 62% of our physicians get one, the average number of licenses obtained is 4 per physician. About 62% get 1 or 2 licenses. The reason they like, and although they're getting 1 or 2 licenses, it's a known factor. They know that they will have those licenses in 7 to 10 days. They also avoid the verification process. So if you're applying for a license in a traditional process, and you are licensed in another state, you have to verify that information to the board that you're applying to. And you apply to another board, and now you have to provide 2 to that. That process is eliminated through the compact process. About 14% of our physicians get 7 or more licenses. Those are physicians generally that are doing telemedicine around the country. It takes about 37 days on average for physicians to get their letter of qualification, with 52% of them getting them in 30 days or less. Here's where I say 7 to 10 days, but the actual percentage is, looking at all of our states and all of our applications, it takes on average 20 days to obtain a license that's requested through our process, with over 50% of those in 7 days or less. We have some states that issue licenses in 48 hours of getting the application. So it is a quick, effective way to do this. The other question that's often asked are, well, the state of California has its specific continuing education and renewal requirements. Do those go out the window with joining the compact? And the answer to that is no. You retain the right to establish the renewal requirements for those physicians in your state, just like every other state does. You will never, where it helps your staff and the process is that you will never get a renewal application through the compact process where the physician has not certified that they've met all of those requirements. So you're able to move that quickly. There are costs associated with the compact. We charge $700 to process an application for a physician. $400 of that comes to the compact. $300 is paid to the state or principal license. So if you are a member of the compact, you will receive $300 for each letter of qualification verification that your board does. So you have California licensed physicians. They're filling out their application. Your board certifies that it's true and correct. You're paid $300 to do that. We know the average cost for a physician to apply to a single state is $385. So a physician who uses our compact and applies for 2 or more states, it's an economic advantage to them. The license fee, your board will collect its full license fee, and the compact will pay that full fee to your board on a weekly basis through our remittance process. So this is not there is not a state that has this has become a financial burden to join the compact. It is most of our states, they see an increase because they will see a 10 to 15% increase in the number of licenses that are issued, but their licensing costs are based on what it costs to process that license. We've had several states that have adjusted their fees based on joining the compact, but those again are decisions that you as a board make regarding how you charge, what fees you charge to issue that license. So my final comments are, these are the 9 criteria that all of our member boards have agreed that if these steps are met, they will then issue that license without doing any further or any additional requirements on that physician. So first, the physician has to select a state of principal license. It has to be a state in which they have a relationship and they have a full and unrestricted license that's been issued by that board. A relationship is considered that they live in that state. 25% of their practice occurs in that state. Their employer is located there, or they use that state for federal tax purposes. About 80% of our physicians use the first bullet to establish their relationship with their state of principal license. A lot of California licensed physicians are currently using the compact, and they're doing that because they're using the 25% rule. 25% of their practice takes place in Arizona or Nevada, and they can use that state to then obtain that letter of qualification and then get those licenses. And finally, the last slide is, these are the 9 standards. These are high bar standards. They're bright light standards. There are no appeals to these standards. If a physician does not meet any of these standards, they must then use the traditional process to obtain their licenses. All of our member boards have agreed that if these standards are met, they will issue a license to that physician. So they have to have attended an accredited medical school. They can have no more than 3 attempts at the USMLE or COMLEX. They have to have their graduate education basically in the United States. It has to be ACGME or AOA approved. They have to be board certified at the time that they are applying for this process. They can have no prior convictions or criminal activity on their background check. They can have no history of licensure actions by state licensing boards on their MPDB report. They can have no actions listed on their DEA history. The state board that is acting as a state of principal license cannot have an active investigation. And the physician has to agree to do a fingerprint-based or a biometric-based FBI background check that will pull a national review of criminal activity. So with that, thank you for giving me the time. And as again, I believe this is the first of many conversations. The compact will be beneficial to the state of California. There actually were 3 professors of economics at San Jose State University, which you might be aware of. They did a study that we were unaware of. They looked at the compact, they reviewed the compact and its impact on states. It found, 1, that it's the single most effective way to increase the number of physicians practicing in a state. 2, that it significantly impacts the ability for patients to receive physician care in rural and underserved areas. Over 50% of our doctors that use our process do that so that they can obtain a license to practice in a rural and underserved area. And 3, they also found that it not only increases the number of physicians you're getting licensed through the compact process, you will see a 10 to 15% increase in the number of licensees issued or requesting licenses from the state of California. And there is a significant increase in the traditional license application process. So thank you. I know I probably went a little long, but I appreciate this opportunity and look forward to talking with you more.
Thank you for a very informative presentation. Are there any questions or comments from board members to begin? All right, we'll start here with Ms. Holmes.
Thank you for that. I was just curious, given that when you talked about discipline, and there are 41 other states that have different standards of evidence than we do, How would that actually work in our state? I mean, would it work?
So what the compact, it's part of the statutory language that's put in there, that being disciplined, I'm sorry, should have taken a drink. Any discipline issued by a member or by a state licensing board is considered a disqualifying event for the compact.
Mm.
That means that their ability to, the physician's ability to continue in the compact is ended. And that means then your board, if you've issued a license through the compact process, can make a decision whether you immediately terminate that license that you've issued or allow the license to lapse when it comes up to renewal, and the physician would then have to apply to your state through a traditional process to get that. Whether your state is able to use another state's disciplinary actions is something that each of our member states determined, but it is considered professional, or it is considered unprofessional conduct as part of the statutory agreement. So the answer to your question is yes and no. If you can certainly use other boards' activities, you're able to, through the compact, obtain all of their disciplinary and investigative records so that you can then make that decision and use your own counsel to determine how you proceed. Does that make
Sort
sense?
of, and obviously this would be a big thing that I would want to understand in a lot more detail because I feel like it's a flyby and I don't actually, I'm not clear. So I would ask the board or the staff to, make that understandable to me as a member of the public.
Yes, ma'am.
And my other question was just maybe to the board is why aren't we in it? What has been the issue? I'm new. So why are we not in it?
I can't answer for the board, but
I can't answer it either, to
yeah,
be honest. So
this
that's
is
why
our-
we're
this
having
has
this
been our first-
conversation. Yep.
I'm sorry, Madam Chair.
No, I mean, Reggie might be able to,
Well, I
Answer
think
that.
it
I
was
mean,
asked before by others, and the response is that there was no legislation put before this board to take a position on.
Right.
So this idea was floated, but there was not a formal legislation introduced for us to take a position one way or the other.
Yeah, I mean, just for a reminder about the background and the genesis of this conversation and the context of our last meeting as we're thinking about legislation that is pending, that is seeking to expand access and expedite licensing and do these things, that many of which the compact is already doing. The thought was, well, perhaps we should have a conversation with the compact to see if this is a strategy that makes more sense than these individualized bills that are sort of chipping away at our licensing authority here, right? For very good reason, right? With telehealth, with access being much easier across the country, with the Cleveland clinics and the MD Andersons of the world and all these various things. So that's why we're having this conversation today, to think
And
about
it
whether or
made
not.
sense post-COVID
Right.
era, because during COVID time, when patients that received cancer care at MD Anderson, for example, for post-care, they couldn't travel because of the COVID travel restrictions. So the physician who treated that patient in MD Anderson, if they are not licensed here, could not follow that patient back in California. So a lot of things start to fall in place and make sense post-COVID era. So I think this is the right time we are discussing this.
Yeah.
Thank you.
I have one more question. So would that address the concern from the last meeting from one of the members of the public around having access to a physician's for a second consult or at, chronic disease, all that kind of stuff? So this would sort of address that issue rather than a one-off, one by one. Okay. All right. Thank you. Thanks.
Madam Chair, if I could also
Please.
amend, so one other thing, Ms. Holmes, is that the one thing about discipline is if a member state takes an action that suspends, revokes, prevents a physician from practicing, whatever terminology is used, all of the member states are required to take a similar action and open an investigation. And so the state will determine whether they want to continue that suspension or not. But it's a public safety issue that if you have a physician that some state has felt is not safe to practice and they've taken formal action to do that, all of our other member states are required to do the same thing pending a final decision by their investigation. Thank you. Thank you, Madam Chair.
Dr. Tsai?
I have a follow-up question. So if a licensee has an issue with one state and is being disciplined, as you mentioned, then the member states can let that license lapse or take action. Does that mean that when I apply to the interstate compact, my license is in a special category than a full unrestricted license in a member state? Because obviously there's due process rights and whatnot. So if I'm being disciplined in one state and automatically my license in another state is subject to different terms than a regular licensee who's not in the interstate, does that do, in terms of legislation that California has to look at, does it need to be in a separate category than a California medical license?
Yeah, that's a very good question. The compact creates a special licensing pathway to get to a full and unrestricted license. It also creates terms and conditions on that physician to use that pathway, just like if, again, to use the airport example, if you're going to use the TSA, you have to give them your social security number and all of these other sorts of things. So it does not, so clearly I want to state, it does not create a special category of licensure. It creates a special pathway to that same licensure. It's the same license, whether it's traditional pathway or through the compact. But by using the compact process, the physician has agreed to the terms and conditions of using that special pathway.
Okay.
But it doesn't impact the type of license.
My second question is, as you mentioned, it's a $700 fee, which $300 goes to the state, 400 goes to the compact. In California, we charge a higher license fee. Will that be adjusted, or do we need to send the licensee an additional state supplement that because you're in California, you have to pay more?
Right. That's a great question. And let me clarify that. One, if you are selected as the state or principal license, that physician is already licensed here and they've already paid their fee to obtain that license. The $300 is paid to the board to do the administrative work to issue that letter of qualification. If you have a physician, does that make sense?
So
the
it's
$300
in
is
addition to your, okay, very good.
It's to cover the administrative costs for that California licensed physician to get a letter of qualification. That's the verification process. It's to cover those costs for the board, to do the fingerprint background check, for the staff time and effort to do that. A physician, let's say we have a physician who Nevada is their state or principal license. Nevada will get the $300 for issuing that letter of qualification, and that physician says, I want a California license, an Arizona license, a Colorado license. They will pay the fee to obtain that license that you would to obtain it through the traditional process. So yes, so that you do not have to do a supplemental request for payment.
I see. And my last question before I let Dr. Yip go is oversight of the commission. Who is in charge? I mean, there's a board and everything, but who's the ultimate oversight of the commission?
It is our commissioners. They have the statutory and the legal authority to govern the compact, and each state appoints 2 commissioners. I like to, if you remember the movie Aladdin with Robin Williams, where he said, as the executive director and the secretary, I have great and immense powers, but a teeny tiny living space. I can only do what my commission authorizes the commission to do. They have complete and total authority. They are the only authority that can issue rules and that can change the bylaws.
Dr. Yip?
Thank you. I think it's timely for this discussion. One question I have is, based on the analysis and the licensee, what are the top 3 specialty in the licensee that goes through the program? I would think of radiologist, a big one, maybe dermatology, psychiatry. What has been the data?
So that's a very interesting thing about the compact is that we do not know what specialties our physicians use. That is information that is appropriate to each of our member states. They can gather that information if they choose to, but the commission itself does not. We survey our physicians when they do renew their license. We know that almost 48% of our doctors that use the compact are intending to use it for telemedicine or remote purposes. And we know that about 48% of them use the compact so that they can expand their direct patient care, either because they're in a bordering state border area or they are following their patients as they're moving snowbirding from one state to another. And about 4% of the physicians use it for academic and corporate purposes so that they can provide expert testimony in all 50 states. So we do not know the specifics of why, what the specialties the physicians have. It also brings up another important point that all of this data and all of this information that the compact has in our system does not belong to the compact. It belongs to our member state. So any request for data out of that system, anything that's done in that system other than by redacted or compiled information belongs to our member states. It does not belong to the commission. So we can't release data. We can't release information. We can compile information and release those type of reports, but we cannot do the specific information. Does that help? Okay.
So second question is that I think I get a clear, this is more like licensing pathway, but let's say Dr. A in California being accused, investigated, but no settlement, no decision yet. Would your member state have that information, or if that licensee up for application, would the information be shared by your member state?
The investigative information. So once a physician is in the compact and they've been issued licenses, the sharing of investigative information is voluntary. A state board is not required to share investigative information. They are required to share it if they've issued public discipline. But during the investigative phase, it's entirely voluntary. That's where, again, I gave the example of New Mexico instructing their board that if this is the purpose of the investigation, they may not participate in that. And that's specifically addressed to it. So it becomes voluntary. If you believe you have a physician practicing in California and Nevada, and it would be helpful for you to talk to the Nevada board, you can request that board form a joint investigation with you. You can also request that they share that information, but it is not an obligation unless you've issued public discipline. And once you've done that, you are obligated to share that with other boards. Thank you, sir.
So we'll go to Dr. Ayala Rodriguez first, Mr. Watkins, I see, and everyone else's hands on this side.
My comment is about the commissioners. So you mentioned that there's like two per state. For example, the state of California has the largest amount of physicians, and commissioners play such an influential and key role in the management of medical complex program. In that particular case, has the complex ever taken any consideration about the amount of physicians that a state has, like to determine the number of commissioners?
There was a very early decision or very early discussion in the compact's creation about creating just 2 commissioners without regard to the size of your physician population in the state. And that was that licensing boards, and I'll say it indelicately, licensing boards all do the same thing. You look at physicians, you determine whether they can practice or not, and whether they're able to practice safely in your state. And based on sort of that discussion, and that is the foundation of it, the decision was made that each state gets 2 commissioners without regard to the size of their physician population.
All right, Mr. Watkins.
Yeah, thank you so much. My question is more, since we live in a data-driven age and AI, is as the compact produce measurable evidence of patient outcomes. Because during the talk, it's heavily weighted on the accessibility and the speed at which doctors can get into the compact and immediately have access to a whole lot of the market, so to speak. But my concern is more on the public protection end of it. And what data has the compact collected to satisfy, are we making patients more safe by the compact, or are we just letting more doctors loose into our different markets? That's my question.
Yes, and that's an interesting thought process that we go through quite frequently, because part of our mission is to provide safety, patient safety, and ensure that we are doing that. I would give you a couple of examples, and then I will give you my impression from my commissioners and from what our boards, in direct answer to that. Are we just opening a floodgate and providing marketing opportunities and for physicians, or are we really protecting the public? So one example of where the compact had a significant impact on patient safety is during COVID, and we all have COVID stories about what happened, but there was a hospital in North Dakota, in a very rural area, that was going to shut down. All of their physicians had COVID and they could not practice. That meant they didn't have physician oversight and the hospital was going to close. Within 48 hours, working with the medical board and our compact process, we were able to get a physician licensed so that they could then continue to operate in that hospital. So that's one way in which we can ensure that patients are safe and able to receive care, is because we provide that quick access to that care and to that physician oversight. Another example is, and it was one of the conversations we had with several of the First People leadership in Alaska, was that by having the compact in Alaska, what it will do is it gives them options. They can now, instead of having to go to a local, the members of their tribe having to go to a local city to get medicines and to see a doctor, they can use the compact process and telemedicine to get a physician who can, and they will open a clinic on their lands that will allow someone to get that care, and they can receive care via telemedicine. They can get prescriptions delivered through Amazon and however else those things are all done. I go to my doctor, I get my prescription, I go to my pharmacist, I get my pills. But so as a general statement, my third and final comment about that is that the state of Michigan, there were several issues, and I won't go into all of them, but there was a point at which the rural authority in the state of Michigan determined that approximately 60% of the doctors in the Upper Peninsula of Michigan, which is a very rural, very isolated place, get their licenses through the compact process. And it's the reason that 60% of the clinics in that area are open. To the specific question, are we opening this up? And are we creating just a different mechanism for physicians to create new markets? I guess I would say that is something that is inherently possible by joining the compact, but where it is not something that's going to happen is because the compact doesn't regulate the practice of medicine. It doesn't regulate that license that's been issued. Your board does that. All of our boards do that. So if you have physicians, that if you decide that every physician needs to do better at underwater left-handed basket weaving, you can decide that that's what's a requirement because you decided that's what protects your public. So Is that opportunity there? Absolutely. Is it prevented? Yes, but it's prevented not by the compact, it's prevented by all of our member boards protecting the public in their state. So we don't have a national mandate to do that. Each of our states does.
So right now, there's no way to establish that. So that is just, we would just look at this and assume that there's sufficient public protection outcomes. Because these are all anecdotal. Every example you mentioned was more access. And I see the conversation is a lot around making more doctors available, which gives them access. I am more concerned about the outcomes that has produced at that patient level, because that's ultimately what the mandate is. We protect the public. And if there's real evidence of that happening, then we don't have to use anecdotal type evidence, because everything, I mean, I'm sure you can get that information. It's just a suggestion.
Thank you.
That's what I suggest. Thank you.
Dr. Tolbert?
So for full disclosure, I've used Compact before. So just so you know, moved around a little bit. So I think of like this in two ways, protection of the public, and from the protection of the public, my questions then become, is this process rigorous enough that we can agree that the public is sufficiently protected, and that in terms of the 9 common standards that you discussed. And I guess that'll be an ongoing discussion with the board, staff, and the board itself, and that sort of thing. The other thing is, I do think that the access is a big thing, because as part of the board, I feel like we're also promoting increasing the ability for some physicians to practice. In my previous roles, I've used compacts to increase the mental health across a 5-state medical school, and we're able to treat patients or our students as patients in rural areas. And it was a private, done in a way that it was HIPAA compliant, and so it improved access. And I think that we want to improve access so that our patients get the care that they need, regardless of where they are, but do it in a way that's safe. And so ultimately it'll boil down to, is this a safe process? The other thing I want to say is, and maybe for a discussion at some point, is how does this actually affect, will this have a positive effect, I would assume, on staffing, in terms of, does this help lessen the burden on our staff so that we can spend time doing more other things and not have to hire in some of these positions, because part of this might be offloaded if it's appropriately done. So.
Thank you. If I could address both. So I think one of the markers is, are those 9 standards effective? We have over 60,000 physicians that have used the compact process. We have about 160, I don't remember the exact number, about 160 that have been disciplined. It is a high bar standard. These are high quality physicians. They also know, I mean, if you're a doctor, you can all understand this, I'm sure. You're not going to use our process if you're skating right on the edge, because if you get disciplined in one state, you're going to lose everything. And so it does create a high bar standard, and it does create that patient safety. Our safety net, again, is the ability, not from the compact. So now you're hearing Marshall Smith's opinion. The reason why I think having a national physician license is not a good idea is because instead of having one group that does the investigations for the entire country, one group that looks at all of the activities around the entire country, we have 58 boards that are part of our compact. Those boards care about their state. They care about the practices that's happening in that state. And you can discuss and have all of those sorts of conversations. But the compact process creates patient safety because it puts that responsibility and authority on that state board. And that's what you do. the staffing issue, we are working with Reggie and his staff, and we've had a couple of conversations about this. We're talking to some of our other states that have implemented the compact. What they have found is that it actually does create that efficiency that you're talking to, in that these are squeaky clean license applications. That means your licensing staff can then focus on the difficult applications because you've got an IMLCC application, they've met all of your criteria, they don't have any discipline, they don't have any criminal background check, they're board certified, you can process them. What we found in some of our larger states, Texas and Florida, they initially start because they're going to get a lot of applications at the very beginning. They, over the course of a year or two, they have cut their staff related to the compact process in half, but they've continued to be able to provide a high level of evaluation because they have those staff and they're able to focus on more than just compact things. So what they do, if you don't mind me talking the technical part of it, is I'll give you the example of Texas. They hired 12 staff to initiate the compact process. They've been a part of the compact now for 3 years. That 12 is now down to 4. Those other 8 still do compact applications as an overflow, but they also are able to then focus on the other applications. So it is, but again, that's something that your board staff will figure out the best way to do that.
All right, we have a few more here, Dr. Jim. Dr. Solis.
Hello, can you clarify of the states who have already joined the pact? Did the allopathic and osteopathic boards work together? And then how does because I think there was mention that this requires legislature and so forth. So just curious how the logistics work.
Yeah, so each state joins the compact and I'm sorry? I'm sorry, each state enacts the statute. That's why you have an attorney sitting there, so you say it right. Each state enacts the compact. Each state then empowers the issuance of license to whatever board they do. Most of the boards are joint boards, but there are also boards where there's a DO board and an MD board. They then operate within whatever framework their state has established, but they both issue licenses. So a state that has an MD and a DO board can't go live or start processing applications until both boards have signaled that they are ready to proceed.
Dr. Thorpe, then we'll go back to this time.
Thank you. So my understanding is that the advantage of this compact is that people or applicants who have a pristine record, have no disciplinary history, and have met all these common standard criteria have a clear path to licensure in multiple states, including if California decided to do that, it could be in California. The discipline and the oversight of those licenses once they get given is still with this board. It doesn't leave and doesn't go to the compact. Our quality of care in California is still decided by the Medical Board of California, and our disciplinary actions are still the responsibility of the Medical Board of California. The only difference is that the licensing process is expedited for those people who have an excellent slate, so to speak. If those people who have an excellent slate are disciplined, they're automatically taken out of that pool.
That's absolutely correct.
Is that correct?
You are correct.
Okay. Just another comment. I think one of the reasons we traditionally have not been part of the compact is the concern that in California we have had, there have been some states that have been viewed as less rigid in their licensing standards. And California has been very diligent about wanting to make sure that the criteria for licensure here is not diluted by somebody who has a license in a state where there's less rigor. And I think that was at least part of the concern historically. That may not be the case any longer. Because by the way, I appreciate your presentation. It was actually extremely, uh, it was helpful to me. But I think that's part of the problem is, are we at risk of diluting our quality of licensure by becoming part of the state compact? And at least I mean, we need more information, as everybody has said, but so far what I've heard gives me confidence that that's not true.
Thank you. I believe that is not true either. It works because we create a fast way to get the license, but the state still controls how that license is used. So yes, thank you, sir.
All right, Dr. Yep, and then
Thank you. For on the warranty sharing, if a physician here is being investigated before decision, settlement, etc., and we know he also practices in Arizona, etc., do we need consent from the licensee that we can approach the other board regarding any other activity being investigated? Or California asked Arizona, do Arizona need to give their consent? How does it work?
Yes, so that is all part of the agreement that the physician makes to use the process. They agree that and understand that boards may exchange information. There's like with any other application process, you have those list of things. So it is one of the requirements that, again, the applicant has agreed that they understand that boards may share information. It's part of their consent when they use this process.
That's good.
And again, again, I want to stress that it is voluntary. There is no obligation unless you formed a joint investigation or you've issued public discipline already to share your investigative information. But we found that it's very helpful for them to be able to do that, especially if they're seeing a pattern or an issue with a physician and they know that they're licensed in multiple states.
Dr. Mahmood?
So I'm just curious, which are other 4 or 5 states who are not part of this, and what is their concern? Are you aware of any? And go ahead, and I will follow up. I will have follow-up question after.
Okay, yes. So the states that are not a part of the compact are, I have to see the map in my head, Oregon, California, South Carolina, Virginia, New York, and Massachusetts. There's currently active legislation in Massachusetts. They formed a task force to look at and make a recommendation, and that task force is expected to issue their reply in July. The primary concern of the task force were the shield laws that were in Massachusetts. After conversations with them and providing that with that, a straw poll done by the chair of the task force found that the recommendation of the task force will be that Massachusetts should join the compact. Oregon, you've seen their white paper. They again continue to believe that it is a threat to the public health, safety, and welfare. And I vehemently disagree with that, but I also respect their right to make that decision. The other states, New York has introduced the bill several times. It's got the strong support of their medical board. It has the strong support of their hospital association and physician medical society. But it just can't get enough legs to get through the legislative process. It's been introduced for the last 5 years in a row, and it just doesn't move beyond hearings. Virginia has they just never took action. And the same thing with South Carolina. One of the things about the compact is that we can't advocate or introduce the legislation. It has to be introduced and advocated for by someone within that state. So it's
And
frustrating.
And my follow-up question is that you've been around like 10 years now? Yeah. And all
Really
these,
25 years old. This is what this job does to you. Yeah.
I mean, your organization. But yeah. Uh, if all the things, has there been any concern? Has there been any issues that clearance letter has been issued and then later on the certain state board found something, okay, there was something missing and this was not appropriately done or something?
Yes, that is the 80 that I mentioned. There are 86, I believe, out of the 120 letters of qualification. It's where the state has gone back, either the state itself, so that this is another, you bring up another very important point. So if you receive a letter of qualification and the application and your board believes it has something that has been missed by that state or principal license, you can challenge that. We have a process, administrative process, that allows the state to challenge that letter of qualification. The ultimate decision maker is that state or principal license. So if we then, I'll shortcut the explanation, but the state board says we think there's discipline, or we think there's a criminal record, or we believe that they're not board certified. Can you ask the state or principal license to review that process? The state or principal license reviews that process and makes a final determination about eligibility. That state or principal license is the only authority that can make that decision. And as a member state, again, that's why I have counsel sitting here, but you are not, no state is allowed to question the decision made by another state, and there are reasons for that. So there have been 80 situations where it has been found that the physician should not have gotten that letter of qualification because they didn't qualify. The majority of them are because they received their graduate medical education in Canada, not the United States.
Thank you.
And I'm supplying to the board that list, a redacted list of those, or the board staff, I'm sorry.
Other board comments before we go to public comment?
So how do you define discipline? And for instance, is a letter of reprimand considered discipline and would be reported?
Discipline is defined in our statute and rules as a disciplinary action taken by a state licensing authority that is reported to the National Practitioner Data Bank. So so there are some states, I'll give you an example. Ohio is one of them. They issue public non-disciplinary letters. They're reported to the NPDB, but they are not disqualifying because they are not disciplinary actions taken by that state. Whatever term the state uses, letters of qualification, or letters of admonition, letters of concern, whatever it is, if it is reported to the National Practitioner Data Bank as discipline, it is considered discipline for the compact.
Okay. We are going to open this up for public comment now.
Thank you very much.
Thank you very much. We appreciate it. Is there any public comment from those in the room?
Hello. My name is Lucas Evanson, speaking on behalf of the California Medical Association. CMA appreciates the board's decision to bring this item up for discussion and consideration. California physicians want a licensing process based on education, training, experience, and ethical criteria, and also one that avoids unreasonable delay in application processing. Today's presentation makes the case that the IMLC accomplishes that. We do, however, think that given its one-size-fits-all approach and the unwieldy process for withdrawing from the compact, that careful evaluation is needed before any decision about joining the compact can be made. Since the Dobbs decision, California has passed multiple pieces of legislation that seek to protect California physicians from activist enforcement by other states that have different laws about abortion and gender-affirming care. The compact language allows member states to conduct joint investigations, issue subpoenas enforceable in other states, and impose reciprocal discipline across state lines. Section 10D of the compact also requires the automatic suspension of licenses in other member states for 90 days based solely on disciplinary action taken elsewhere before California independently evaluates the underlying conduct. Finally, pursuant to Section 24B, any California law in conflict with the compact is superseded by the compact. We encourage the board to fully explore what those provisions could mean for California physicians. Just because there has not been an issue does not mean that there will not be an issue. We also encourage the board to fully explore the costs and workload requirements associated with joining the compact. Would the $300 provided to a state of principal licensed by the IMLCC cover the board's costs to process the letter of qualifications? Are there additional costs that the board would bear for administering the requirements of the compact that are not covered by the fee? What is the estimated cost for performing those? How would the workload associated with the compact applications and administration impact processing of applications filed outside the compact process? Thank you for your diligent review of all the aspects, both potential risks and benefits of joining the IMLC.
Thank you. Other commenters in the room? Right, Sean, let's open it up on WebEx, please.
Yes, if you'd like to make a public comment on agenda item 5 here, please do so by raising your hand or typing anything in that Q&A window. First here we have Marion Hollingsworth. Should be receiving that prompt.
Okay, can you hear me?
Can, Marion, please go
Okay.
ahead.
Thank you. Hello, this is Marion Hollingsworth, patient safety advocate. I think it's great that the Interstate Medical Compact can be used to give care to people in other states, particularly in rural areas. I'm reassured that the compact seems to be good in investigating doctors for violations and for taking actions if it's determined that that is warranted. I also appreciate your high standards for any physician to be a member. However, I will say it's alarming that it's voluntary for state boards to share investigative information. This board allows doctors to routinely practice for 3 years, even with multiple death cases, before they release an accusation. This state routinely allows potentially dangerous doctors to practice unfettered despite using drugs at work or having an egregious patient death. And this board also has a disclaimer that the information on its website is not necessarily accurate. Profile page info is from the doctor. So if a doctor claims to be certified, that's not necessarily accurate, as I found by looking them up on the ABMS. My question is, which state does a consumer use to file a complaint if there is a patient harm issue? Is it the state where the doctor is licensed or the state where the patient lives? Does the consumer file a complaint with their state and hope the complaint is forwarded to the compact? Do you wait for an actual discipline before you take action, even in cases where the doctor's license has been suspended? Remember, as I said, this board does take 3 years to reach an accusation and another 1 to 2 years to reach a discipline. That could leave a potentially dangerous doctor active in the compact until that decision is reached, which could be 4 to 5 years. Maybe you have already answered these questions, but it's not clear in your materials. If you can't answer today, can you make that clear on your website? Thank you.
Thank you for your public comment. Next here we have George. George, you should be receiving that prompt.
It's Eric Andrist. The CMA needs to stop representing that they speak for all of the doctors in California. He just did it again now. And for many of you new board members, you need to really research and find out what the CMA is, what they do, and who they represent. Because weak-minded board members like Christina Lawson, they follow them for their own political careers when it's their outlook is to protect their doctor members who paid fees, not patient safety. The California Medical Association is a voluntary membership organization, essentially a professional trade association and lobbying group that represents the business and political interests of its physician members. It does not speak for all California doctors. And in fact, roughly half of the state's licensed physicians don't belong at all. When the CMA takes a position on legislation or policy, it's representing the interests of its dues-paying members, which are often primarily economic interests, not patient safety priorities. And over the years, since we've been doing this patient safety advocacy work, trying to get bills passed and all kinds of things, the CMA has come down and actually thwarted patient safety measures. So keep that in mind, new board members. Don't believe everything that people like Christina Lawson say, who follow them like, like they're fans of the CMA, but they're just doing her political career a favor. That's all that she's doing it for. Thank you.
Thank you for your public comment. At this time, I don't see any additional question queue.
Thanks, Sean. Anyone else in the room? All right, are there any further comments or questions from board members? And I guess just something to think about is what next steps might look like. So any suggestions or thoughts about what next steps might look
I
like?
have a
Dr. Tsai?
question before we start the next process. Maybe to Reggie and maybe to Mr. Hawk. How will this impact our current credentialing process? They use the 9 common standard. Is that the same? Is that above? Is that below what we do? If we had joined the compact, will there be significant changes in the licensing process for us? And as somebody mentioned, the $300 for the letter of qualification, will that be something that sort of pays for the cost, or is that significantly below? Do you have any input? And of course, the corollary to that is, as the executive director, our neighboring states, Arizona and Nevada, how do they view this compact? Is it a good thing, or do they regret they ever joined it? What's their input?
So the first part, response to the first part of your question about how the licensing processing actually changed, we really need to look at the legislation first of all, and then study that much more carefully to see what are the. I know we just saw the 9 listing; those are gold standards, that many states. But what are the residency requirements? How many years? 3 years, 2 years? What are the how do you qualify that physician? So all that will be studied after we look at the legislation, that the model legislation that will be studied by the staff, and then eventually bring to the board. And there's one board, I think it was Massachusetts, a task force, so we can look at multiple ways to look at that to see if this model will fit in California or not. Now, I have the opportunity to talk with the other states, and my own previous state, I was there when Oklahoma implemented IMLCCA compact. So I was part of that implementation team. So, but I don't want to bring their standard here to California. I mean, I'm not saying they're substandard or anything like that, but I do have some experience. But I also, during that time, had opportunity, and even recently talked to other my counterparts in other states, and I have opportunity to sit in Federation of State Medical Boards compact briefings and discussions. All I heard was positive. Now there were some issues with delays in the process because the volume, and sometimes like Mr. Smith pointed out, the initial stage when it is implemented, there's going to be a floodgate of people. There's a lot of people who say, well, this is an opportunity to obtain a license in California faster. Now, on the flip side of that coin is the director at the Washington board already told me a few weeks back, let me know ahead of time if California is going to join the compact, because he needs to hire a lot of staff in his state, because California physicians who will be applying and to obtain a license in their state. So it's going to impact many states. So overall, total, I would say positive responses. So, but more discussions to happen going forward. Thank you.
Other thoughts, comments? Dr. Ayala Rodriguez?
Just that I would support a follow-up discussion with those details that Dr. Tsai mentioned, because I think that definitely there's more information that we have to learn and discuss to feel more comfortable for either direction.
Thanks.
Yeah,
Mr. Watkins?
I would also just like, actual data. For me, this is all sounding good, but what lacks continually is a lack of data about how this actually impacts the public safety aspect. And so as much data as we can get from all these conversations from other states, that would be awesome if we know how long it takes for just the time period before it gets reported to enforcement, to how many, when the states actually know, and also, do they actually do it? If they say, okay, discipline in California, we say 3 years or 5 years, do the actual, because it's reciprocal, right? So do the other states actually follow suit right down the line? I would, because that's an important selling point of this, because it demonstrates, that statement says there's strong public protection. But I just want to see the data for that. And since we're also bringing in the best doctors, so the probability of that, of we having serious complaints kind of goes down if you have such rigorous entry requirements. And I think sharing that data would probably be great to have to make this decision to move forward. Thank you.
Ms. Holmes.
Thank you. I think there's just an action item at this point. I might be wrong, and if I'm breaking protocol, correct me. But I think that we should task the staff to do some analysis on these dimensions, the access, the safety, the data, everything that got raised, and have come back with a recommendation or analysis.
Yeah, I think also because the osteopathic medical board would be involved here also. I mean, some sort of joint task force, right? At some point where there's 2 members of this group and 2 members of that board, providing some direction to the respective staffs about what the issues are is probably in order. Mr. Varghese.
Ms. Lawson, I just want to recognize Erica Calderon, who's my counterpart at the DO board, osteopathic board. She's here to listen to the entire conversation, and her staff too. So
Welcome. We are glad you are here. Okay, I think staff's heard from us. Staff need any more direction at this point about next steps?
no, we will have continue. We already had 2 meetings with Mr. Smith and his team. We'll continue to have that discussion, and of course, Mr. Watkins, we will be working with them to get the data. If they have the data, they will be supplying that. If not, they will be pointing to the states where we can collect that data from, if they are willing to share that. And the same token, please feel free to send my way any more questions you have about this as you study this more, because we'll have continued dialogue with Mr. Smith and his team. Thank you.
Okay, thank you all. We were going to do this a little bit later in our agenda, but I'm going to break us for lunch right now until 1:30. It's 1:08 right now. But if we go too much further, we're going to find ourselves at dinner. And so let's break for lunch, but let's please be back in what is 22 minutes at this point. So thank you. All right, welcome back to the May board meeting of the Medical Board of California. It's 1:33 p.m. We are going to move on to agenda item 6, executive management reports. And for this item only, we had a request offline to take these items separately for public comment. So for this item, we're going to take 6A, B, C, D separately for public comment. We'll go from there. Sean, you'll start us off.
All right, good afternoon. For ISP updates here, I just wanted to give a quick updates through our projects here. So staffing update wise, we've managed to recruit and have a start date now for our enforcement business analyst position. That'll help a lot with breach changes and reports and things like that. And starting to work on recruitment for IT supervisor 1 position that we lost with a retirement a couple months back here. So infrastructure update, we've been rolling out laptops. We're down to the last 5 to 10 individuals that have been difficult to swap out. They've been on leave and things like that. So that project's almost wrapped up. Expect in the next week or so, we'll finish those out and start the long process of now surveying out all that old equipment and sanitizing it and donating it to schools and other organizations, things like that. In regards to the complaint tracking system, we're still doing testing with the executive office and enforcement staff to fine tune everything in there. So looking forward to more testing on that and getting you guys further updates as we proceed. On the iOS application on April 7th, we deployed our newest update. We found that a lot of individuals have automatic updates turned on their cell phones, and so it updated the application for them, and they may or may not have heard in our board meetings the warning we gave that it will change how their licensees are stored in the application. It stores them now in iCloud data, and so we've noticed now that we've got some additional metrics on it that a lot of devices have updated. Last count, there was around 800 devices that we've now seen registered in the application, and a large portion, I don't have an exact percentage, but I put around like at least 80% are not currently following licensees because that app either automatically updated, they lost the licensees that they're following, they need to go back and put in there. Working on an update now to the application so that a notification will pop up on their phones letting them know, hey, you're not using the app to its full potential. We advise that you put some licensees in there, so that we can start getting those metrics of how many users are following how many doctors and things like that. And I have all of the physician board members in on my app, and like I noticed Dr. Ayala Rodriguez renewing his license a couple weeks ago. So I'm happy to report after the initial launch, when the Department of Consumer Affairs was moving around some web services and the services were a little slow in responding, the last couple of weeks have been up to the speed and performance that we were expecting from it during our testing and things like that too. So keep an eye out for all the rest of you renewing here shortly too when it's your time. With the consultant expert management application, that's our CEMA, we call it. We've prepared some updates for the new functionality they requested regarding training and things like that, and the reimbursement rates that those individuals can get in certain specialties and things like that. The testing for it was all approved by the unit that's responsible for working that application. We're now just working with them on what of the 40 plus reports they had in the old system they need available for go live on the new system. We'll be launching that here hopefully in the next couple of weeks. But happy to get that one going for them so they can automate a lot of those processes for renewing the contracts for those licensees. Now that it'll automatically send out renewal notices and things like that, it takes a lot of burden off of staff that have to do that to free them up for actually farming out cases to those consultants and things. On the doc stats there, the docs unit intake staff in our call center went through and they had a new registration form that made it so that we can accept electronic signatures of all kinds from all of these different users on the docs system. And so they completed a process where we gave all of the docs users the new form, told them they had to re-register. I want to say it was over 6 months they had to go ahead and fill in that new registration. the individuals that did not get back to them in time on that, we sent out a 30-day warning notice saying that, hey, your account is going to be deactivated. We expect a lot of them or people who had separated from their organizations anyways and things like that. But those that we didn't hear back on, we went ahead and disabled those user accounts. So the first time in the history of the doc stats that we've been providing you guys, you'll see the user counts are down, over our last reporting period because we did deactivate so many users, but the number of documents coming in is still following the same trend and things like that. So the active programs and schools and their users are still uploading the same documents. We've just weeded out a bunch of old, dead, probably deactive accounts. This was over a month ago that we did this. So anyone that did lose access and claimed to have not received those warnings probably already been re-registered now and stuff like that. So I expect it to be a one-time kind of a thing. Going forward, we'll be looking at accounts that don't have logins in a certain period of time and looking to deactivate those automatically so that we don't have to do another big cleanup process like this, hopefully until there's some other reason to have a re-registration or something like that, which we hope to avoid. For the Voluntary Physician Registry, just a informational update there. A few more volunteers have signed up. It's a rather small program there. For the HCI survey, the Department of Healthcare Access and Information, their survey, we're tracking a couple pieces of legislation along with Aaron's assistance that could increase the number of questions that we're asking, both for all license types, and then there's another specific piece of legislation specific to licensed midwives that we might be looking to add some questions in there too. Till we know the outcome of that legislation, we won't be making any of the changes, obviously, but we're tracking those, and our percentage increase to that theoretical limit around of 90% is creeping ever so closer to it and stuff like that, but it's mainly just informational update there for you guys. For the Breeze online complaint form redesign, we had a meeting with the Department of Consumer Affairs to review the vendor provided code changes, and they weren't exactly what we had asked for. So it's been sent back to the vendor now for some additional corrections. Waiting to hear back from the Department of Consumer Affairs on when we can test those again. Essentially, when you're adding the involved party types into your complaint, the patient information, witness information, it should be very much like how you would add a address to a license record where it shows you a screen and you can click the add button, you can add as many things as you want. And it wasn't as user-friendly as we had hoped and we had designed with them when they set out to work on it. So we've kicked it back to hopefully get it as good as can be. So waiting on more information about when we can test that again and hopefully get it implemented. As such, so I don't have a date for that, so I can't give you an update on when that complaint form redesign will be done, but hopefully by the next time it comes back, we'll be able to get that configured. For the Breeze electronic only renewal project, just information only updates there. Still seeing the numbers have kind of stabilized, but we're still seeing a lot of licensees that are waiting till that last month to renew their license. We'd like people to renew as early as possible, given that we give them a first notice at 180 days. I'm same type. I probably would wait till the last minute if I was doing it too. So I know we'll never get that number down to 0. But they're getting their email notices early and often, so we're hoping people take advantage of that. We'll just continue to track that. Wallet card usage continues to kind of follow along the same numbers there. Everybody seems to enjoy that, the wallet card feature now, and the plastic cards are a thing of the past. We look forward in our strategic plan. It does call for the iOS application or the iOS wallet license that we want to still design to. So programming resources providing on that. After we get a few more projects knocked out, we hope to be doing that. Couple new items to add on here now, the CME audit enhancements. I think I touched on it briefly last meeting, but we're finalizing the transactions and the processes that now when you're selected for a CME audit, they do a random CME audit every month and they send an email out to the licensees. It's a manual process right now that our IT unit helps with, where we do mail merges and try to take the burden off of staff. But still an email that goes out, and then they monitor an email mailbox for responses coming in, and they have to process those responses and then send a confirmation back to the licensee that, they've passed their audit or whatnot. We're looking to do all that through Breeze. So much like how you renew your license now, you'd get an email through the Breeze system letting you know you've been selected for the CME audit. You can log into the Breeze system, start that transaction, upload your documentation that way, and then it'll show on your Breeze dashboard that that process is pending until the licensees or until the analysts that are responsible for working those CME audits verify all of your information. And then as soon as they approve that they've received everything they need on their end, the system will automatically send an email to the licensee to let them know they've finished their audit. If they need any additional information, that'll be a deficiency letter, much like a renewal situation where they'll get an email and they'll be able to go back onto the Breeze side, upload more documents if they need to, and continue on with that. We hope it gives the licensees a better view of what's happening with their CME audit process, so they know when it's completed, and it will also take the burden off of our staff of manually sending a lot of those emails and things like that, because they're already doing the work tracking the information in Breeze. This will just automate a lot of the notifications and things like that to make them more reliable and timely for licensees. And finally, the outpatient surgery settings database project. We've started that. A developer has been working on it for a few weeks now to revamp the outpatient surgery settings database system. It's an old system that is due for cosmetic and technical updates and things like that. There's some issues with inputting data into the system right now. We're taking a total rewrite position on it and building it so that staff internally, the way they previously did it, they can input information on behalf of these accreditation agencies. The phase 1 launch will replace that, so our staff can go in there and put information in on behalf of the accreditation agencies. With quick to follow, hopefully phase 2, that will allow the accredited agencies themselves to log in there and update their own information, with our staff just making sure that it's accurate and timely, and being more of the gatekeepers of the information, not having to do so much of the data entry themselves. So that information gets out to the public interface that's searchable so that the public can see that information quicker. And since it's truly not our information, it's the accreditation agency's information anyways, we'd like to put that responsibility on the accredited agencies themselves to be entering that data in there. It'll provide a lot more data quality if we can make sure the fields as they're entering them, dates and things like that are in the proper formats, things like that, clean the data up and stuff like that. So it's just a quick update on the projects that we're tracking in ISB and reporting for you guys. If you have any questions.
Thanks, Sean. Are there any questions? All right, seeing none, we are going to open this up for public comment. Are there any public commenters in the room? How about online? Sorry, Sean, you probably are in charge of that, and now you've got to get back to your computer.
It's okay. I feel more comfortable back here anyway. So if anyone would like to make a public comment for agenda item 6A, please do so by raising your hand or typing anything in that Q&A window. First up here, we have Marion Hollingsworth. Marion, you should be receiving that prompt.
Okay, can you hear me?
Yes, we can, Marion.
Okay, let me scroll up to my comment on here. Hello, this is Marion Hollingsworth, Patient Safety Advocate. Regarding the new app format for the iPhone, it's actually working well. I like the notification history. I think it's very helpful. And speaking of notification history, there's one drawback so far. I'm getting repeated notifications on a doctor that has the same public actions change, but nothing has shown up that's different since the initial new accusation. The same accusation from April is up and hasn't been replaced. This happened about 8 times so far. Sometimes at odd hours, like 8 o'clock at night or early hours of the morning. Perhaps it's a glitch in that particular doctor's case, but the rest of the new format seems to be going well. I use the app regularly and see the changes, so it's helpful to me. And I was wondering if there was any new update. I don't know if I missed you saying that. If the app has been offered to phones other than iPhones yet, or if that's just iPhone for the time being. Thank you so much.
Thank you, Marion. Next, here we have Michelle Montserrat Ramos. Should be receiving that prompt.
Good afternoon. I'm Michelle Montserrat Ramos, and I am with Consumer Watchdog. The online complaint form redesign. We've urged the board and board staff to involve us in the review stage of the online complaint form and to consider our recommendations, as we are the stakeholders who use these forms. Locating a complaint form online is complicated. It requires 4 steps to find a complaint form. Users must scroll halfway down the page to access the boxes that lead to the complaint section, to file online, or to obtain the mail-in complaint form for submission. You have to search to find the How to File a Complaint video, which is different from those previously posted. Unfortunately, this video lacks accuracy because it doesn't explain the 4 steps needed to access the first screen. Most importantly, it skips right past the most vital element of the consumer complaint form, the summary of the patient's complaint. Although you have a lot of text on your website, there's no clear guidance on what information needs to be included in the summary of the complaint. This is one of the primary reasons why your staff receives complaints that do not contain all the information you need to move a complaint forward. Why create extra work for your staff when you could provide clear upfront information that empowers the public to file effective consumer complaints? It would streamline the process for everyone involved and ultimately improve efficiency for your staff. The Osteopathic Medical Board did not have a video. They invited us to meet and accepted our recommendations for their video on how to file a consumer complaint. It is surprising that this board remains hesitant to partner with us in developing this important resource for consumers, while the OMBC welcomes the input and has developed a video. Collaboration on this video would not only enhance public understanding of what you need in a complaint, but it would save your staff time and save your board money, making the entire process more effective. With Sunset Review on the horizon, how does this board work with the Osteopathic Medical Board in your joint efforts to protect consumers? Considering that the OMBC does not have IT services, what is the possibility of working with them to ensure that they also have a consumer complaint tracking notification system? Many of our families have needed to file complaints with both boards, and it would benefit the public to have the same tools available with both boards. Thank you.
Thank you for your public comment. At this time, I don't see any additional requests in queue.
Okay, we'll bring it back to the room. Any public commenters? All right, seeing none, we are going to move on to the licensing program summary. Mr. Hawk?
Right. Thank you, President Lawson, and thank you for your service to the board. You will be missed.
Thank you.
I'm Douglas Hawk. I'll be presenting the licensing program summary. So in Q3, we received 2,717 initial license applications. That's 1,910 physician and surgeon's license, 575 transition to physician and surgeon's license, and 232 postgraduate training licenses. We issued a total of 1,828 licenses, and that breaks down to 1,781 physician and surgeons and 47 postgraduate training licenses. In the licensing program, we're always looking for ways to make our processes more efficient, and some of the recent updates and things that we've been working on. As mentioned by Sean, we conducted the re-registration process for docs. So what that does is allow us to accept additional electronic signatures, which results in less deficiencies, which generally results in faster processing times for applications. As Sean mentioned as well, we're working to allow physicians to upload their CME documentation electronically, which make our process much more efficient, save time for staff. We're also working on allowing midwives to apply for licenses electronically. Right now, that's a paper process. We continue to collaborate with DCA to update our procedure manuals for all our processes to make sure we're accurately reflecting paperless workflows, our newly revised processes, and updated document titles. For our webmaster update, we responded to over 3,000 emails in the last quarter. The most common topics were license updates, initial renewals, and CME requirements. For our outreach update in Q3, We conducted 3 in-person events, and our outreach coordinator is back there. She visited during this last quarter the College Medical Center in Long Beach, the University of California, San Diego, and also she was at our February board meeting in Pasadena. During these events, topics discussed included PTL requirements, first and second time renewal requirements, and just other general licensing questions and process questions. An update for our call center. In Q3, we received 11,535 calls with an average wait time of 1 minute, which is incredible. The top 3 topics addressed by our call center during this quarter were renewal assistance, complaint questions, and application questions. And that's a brief update from our licensing program.
Thanks, Mr. Huck. Any questions? All right, any public commenters in the room? How about online?
Yes, if anyone would like to make a public comment on agenda item 6B, please do so by raising your hand, or typing something in that Slido window. Give a few seconds to see if anyone queues up. Not seeing any requests at this time.
Great, we'll bring it back to the board. Still no questions? All right. Thank you, Doug. We will move on to the enforcement summary. Ms. O'Connor?
Good afternoon. I will be providing the enforcement summary today as our former Chief of Enforcement, Ms. Smith, retired in May after 31 years with the state of California, of which 25 were with our board. We thank Ms. Smith for her commitment to the protection of California patients and wish her a fulfilling and well-earned retirement. I also am very lucky to have our Deputy Chief of Enforcement, Kenny Watson, with me today to help answer questions. All right, to start off my enforcement update, I'm happy to report that complaints continue to be initiated in the central complaint unit on average in less than 10 days of receipt. While the average complaint processing time in CCU is 158 days, it continues to decline since the beginning of this fiscal year. 2,263 cases have been referred to the Complainant Liaison Unit since its inception on January 2nd, 2025. Of these, staff have conducted 1,136 interviews with complainants. The expert reviewer and medical consultant program continue to look for new outreach opportunities and will be working more closely with the licensing unit on their outreach events. In the third quarter of this fiscal year, the Complaint Investigation Office closed 40 cases and 16 were referred to the Attorney General's office. The Discipline Coordination Unit has been working on data reconciliation reports with the Attorney General's office to support more efficient case tracking and monitoring. Also in the third quarter, there were 36 licensees placed on probation, bringing the total number of licensees on probation to 546 as of April 1st. This concludes my update, and we're happy to answer any questions. Thank you.
Thank you, Ms. O'Connor. Are there any questions? All right, seeing none, are there any public commenters in the room? How about online, Sean?
Sorry, I have a little trouble with my mic there. If anyone would like to make a comment on agenda 6C, please do so by raising your hand or type something into that Slido window. First up here, we have Marion Hollingsworth. You should be receiving that prompt.
Okay, can you hear me?
You can, Marion.
Yeah, thank you. Hello, this is Marion Hollingsworth, patient safety advocate. In looking at the enforcement statistics, it's alarming that there are so many citations this year. The fiscal year is not yet over, yet you already have more than 200 to 300 citations more than previous years. According to your own statistics, you have 477 citations listed for the first 3 quarters of this year. Compare this to 22 for fiscal year 21-22, 195 for fiscal year 22-23, 135 for fiscal year 23-24, and 179 for fiscal year 24-25. And as I said This year is not yet over. These are your own statistics, by the way, on page 12 of 6C, by the way. Can you explain this sudden interest in citations? Is this a cheaper way to let doctors off the hook for patient harm, for failing to take the required drug testing, and for testing positive for controlled substances? I can even name a high-profile doctor who had an egregious case with a childbirth case, but instead of giving a full investigation, he was just given a citation that is now off his record. But this is a high-profile position in the state, and it appears to have resulted in a cheap citation that he was able to buy out for just $350. It's outrageous that this board is being so lenient with using citations for medical harm or substance abuse violations. According to your own website, citations are supposed to be used for minor issues like record keeping. Doctors should not be able to plead down to a citation for record keeping by lying about the condition of a patient on their records. This is what happened to the high-profile doctor case I mentioned. It was impossible for board members not to know him given his position. This is an example of how the board can choose to be lenient with high-profile cases and using citations instead. I would hope the number of probations and revocations would be higher, but it seems that citations are easier and cheaper to crank out. Please be more judicious with the use of citations so that dangerous doctors don't get away with paying off their complaints with a $355 check to clear the citation. Thank you.
For your public comment. Next here we have Michelle Montserrat Ramos. Should be receiving that prompt.
I'm Michelle Montserrat Ramos, and I'm with Consumer Watchdog. Average HIU investigation days, to break down the type of case and how many days it takes to investigate. Do all the substance abusing physicians fall under category of self-abuse of drugs or alcohol, or are some substance abusing doctors fall under the category of unprofessional conduct and mental physical illness? Administrative outcomes for physicians. It appears that the majority of disparate actions this board is taking are citations. You will notice the proposed action citations and fines. It is noted that of 88 additional citations that the board issued, the board anticipated approximately 25 informal conferences per year at a cost of $3,359. What are the informal conferences and who is involved in them? We bring up citations for another reason, as we have viewed disparate actions involving substance abusing doctors who have been caught under the influence while practicing, who are put on probation, and when they do not comply with their probation and skip multiple drug tests, the board will issue a $350 citation for skipping multiple drug tests. Then when the substance abusing physician continues to skip required drug tests and then fails the random drug tests, the board will again issue a second citation for $350. Then when the substance abusing physician continues to fail random drug tests, then the board will finally review and investigate those findings and then add 1 year to an already existing probation. This isn't really adequate discipline for a licensee who is caught practicing while under the influence. Finally, we're requesting board staff to include in board statistics, for the number of 805 reports you receive quarterly, and for what reason, and how many educational letters you distribute, and for what reasons. Thank you.
Thank you for your public comment. This time there are no additional requests in queue.
Great, thank you. I know we have one question from a board member, Dr. Thorpe.
Thank you, Ms. O'Connor, for that report. I do have a question similar to one of the ones that was mentioned here. If you look at the graph, let's see, it's on page 6. For average days to complete complaints in the central complaint unit. In 21-22, the average days were less than 100. In 23, it was about 110. And then it's progressively gotten higher every year since that time till now. It's closer to between 160 and 180 in fiscal year 25-26. I just wondered what's the Can you explain that to me, or why is that? And then I have a couple of other questions about a couple of the statistics.
I'm probably not going to be answer the whole history of the flow of those numbers from back in 21, 22, but Kenny might be able to provide a little more information on the process and why some of those timelines have gone up.
Yes, well, first I'll say it, and what's maybe lacking and needs to be added to the regular report we send is that the complaint liaison unit tracking time is included in CCU's age. So on average, without referencing the exact statistics, CLU's time frame is something like 45 to 65 days to process those complaints once CLU gets them. That time is encompassed in the days that you see in the graph basically here.
Adding time. So it's
That-
adding time. Yeah.
It
to each
adds
process.
time. CLU adds time. Granted, that's not been the case the rest of the graph because you're talking about several fiscal years. I can say there have been some changes I've made in CCU. CCU is one of the programs that is under my oversight. So in the last year, I've definitely been focusing on these values. One of the things we did was implement some technology changes. So staff now, for example, have desktop scanners, whereas before I had, approximately 50 or 60 staff using the multifunction copier scanners in the office, which, these voluminous records we get by paper sometimes can cause a problem. The other issues are staffing. There's been fluctuations in staff and CCU here and there. Certainly in my tenure, formerly Chief Smith was the manager 2 over CCU. That vacancy left a hole in leadership and could have contributed to some of these delays. It is something that I'm focused on.
Yeah, there could be a lot of factors to the gradual increase. The most recent increase, I think, is a lot in part to the complainant liaison unit, but there's been over time, there's been resource issues, there's been both staffing and equipment, as Kenny mentioned, but what I think has been contributed to some of the downward decline of some of the things Kenny has been looking at. They seem small, but because of the large volume of paper we still get for complaints, they can make a big difference. So we're still looking at ways anything we can do to cut down staff time and processing these. And one of the areas we're really focusing on and will be a big part of the new chief of enforcement when they come in is improving communication and coordination across the units. So if they make a change in one unit, how's that going to impact that case all the way through the process, especially since we have more units now handling these complaints?
Well, those are all great, but it feels to me like when you're getting increased efficiency with desktop scanners, that should lower the days. It shouldn't make them worse.
That was very recent.
I mean, and so you've gone from less than 100 in 2022 to 160 to 180 this year. I would appreciate you kind of looking at that and then bring it back maybe at the next board meeting.
Absolutely, we can look into it.
I mean, I'm not complaining about it. I mean, I think you guys generally are overall, certainly, average days in HQIU investigations are coming down. And I mean, I think there's a number of things that are really good. I just that seemed to stand out. And then I think the other issue was for me, why I didn't understand the same thing about citation and fines. Why so many all of a sudden?
So most of those are actually CME audit citation and fines because we had a backlog in our CME audit desk. We had some staff vacancies and we had temporary help come in and help with that. And we're working through that backlog. So that's why there's more referrals for citation and fine. They're coming from the CME audit. So you're going to see that high number for a while until we work through the CME audit backlogs, which we are working through. We've made a lot of progress. It'll eventually come down, but that's been that major increase.
Well, that helps. Thanks.
Great. Any other questions? Mr. Watkins?
Yeah, I'm on the citations too, and that's very helpful to know. Because if the CME violations or whatever is contaminating those numbers, then these numbers become inconsistent. So what I suggest is if you could break down the citations into when it is CMEs, probation violations, and then the regular citations, because that will kind of separate those numbers, and then you can get a better read for what is going on, especially the volume. That's 161% in like 1 year, and it's only 3 quarters. So thank you.
Yeah, absolutely. We can look into breaking that out for future board meetings.
Any additional questions? Okay. Thank you, Marina. Thank you, Kenny.
Thank you.
Thank you.
Moving on to the administrative summary, Mr. Varghese.
Good afternoon, members and Madam President. Thank you. So I will keep my summary very brief. The report and also the numbers and the graphs and charts are all attached to the report. So this past quarter, we continue to have meetings with the board leadership and also with other board members on a regular basis. Also, staff met biweekly with Ms. Castro, Senior Assistant Attorney General, and with Stephanie Whitley, HQIU Deputy Chief. And also, staff met with other organizations and groups on a variety of topics, list of those organizations and groups, and the topics are listed in the staff report. Staffing update, board's vacancy rate is still below the 10% mark. It increased slightly this past quarter from 4.3% to 6.51% due to some of the vacancies, but we are actively trying to recruit to fill those positions now. Budget update, happy to report board strong fiscal health. Current fund condition and future projections show a positive outlook for the board's economic reserve balance in this budget year and beyond. Also, please take a note that we continue to maintain a debt-free financial position with no outstanding loan balances. Media relations and external communications. Yesterday, I had a chance to present at the California Association of Medical Staff Services, CAMS, their 55th Annual Education Forum in Long Beach, California. Presentation objectives included top areas of enforcement and reporting requirements, status and scope of physician health program, MBC's top area of focus, and board expectations of physicians. And on May 18th, 2026, the board sent an email to board licensees reminding them about financial scams and those impersonating board staff. And this continues to be an issue, and we posted some information on our website and also continue to post that in our newsletters too. On April 24, 2026, the board sent an email on behalf of California Department of Public Health notifying licensees in silicosis cases throughout the state. We sent out several such email brief out to licensees from CDPH. The board staff continued to post notices on Facebook, X, and send email to subscribers with information about the board's administrative actions. So those are my prepared remarks. Happy to answer any questions.
Thank you, Mr. Varghese. Any questions?
Not a question,
Ability to function as the president.
but just to trying to make you look good. Yeah, I just want to say, Reg, thanks so much for the leadership and the financial and the fiscal responsibility, and this is so different than when I joined the board in 2019. It was constantly from one quarter to the next, just we were on the brink of disaster. And so it's so refreshing to see that the board is, with the increase in the dues, that the board and your management, that we are not in that state anymore. And it's really refreshing. Thank you.
Thank you, Dr. Thorpe. It is not just my effort, it's also the staff back there in the office who are listening, and we're all strong behind this moment. Thank you, and with your support.
Any other comments, questions? How about from the room? How about online, Sean?
Yes, if you'd like to make a public comment about agenda item 6D, I'm sorry, please do so by raising your hand or type anything into that Slido window. First up here, we have Monty Goddard. Should be receiving that prompt on your end.
Excuse me. Good afternoon. I think we're at the point of the meeting after having had the president's report and the executive director's report. I have to ask or point out, it's been 5 months since we had the Patients and Prescriptions Forum at Sacramento State University. I was hoping to hear sometime today an update on what's happening as follow-on to that activity. I do have to say, I'm going to miss you, President Lawson. You're one of the few, you, Dr. Thorpe, I think TJ Watkins, and maybe Mr. Mahmood, Dr. Mahmood, are about the only ones left. And an item I think was significant that happened during your tenure that you did not list. And that was the approval in May of 2023 of the board's updated opioid prescribing guidelines. I think that's a significant accomplishment. I would have liked to have seen more adoption within the community that you guys license. But I'm concerned that the board is folks that have a history with that process, which was significant. You guys are all leaving. That concerns me. But bottom line is this, when are we going to hear what's going on as a result, as follow-on activity for the forum that took place in Sacramento? Thank you.
Thank you for your public comment. At this time, there are no additional requests. Oh, right. Michelle Montserrat Ramos should be receiving that prompt.
I'm Michelle Montserrat Ramos, and I'm a consumer watchdog. I reviewed the list of stakeholders that executive staff or the executive director had meetings with, which listed patient consumer advocates. We were not included in any of these meetings, yet the meeting topics included many that we and our team have brought before this board, including this board's commitment to create a maternal mortality task force. Although Board President Lawson mentioned the maternal mortality task force, and there is a concern of what outcome we will receive without her leadership, I see that the maternal mortality task force update is not on this meeting's agenda, regardless of the many board members who requested that executive staff give an update on the progress of the task force. I've taken note of the subjects that you have met with other entities, but only one of those meeting topics relates to the issue we brought before this board and the reason why so many young mothers and babies have died in the state and particularly in the Central Valley. It was Board President Portillo who stated that there should be some board members on this task force to ensure that we are getting the data that we are requesting. It would be effective to invite us to the meetings because we are the stakeholders that brought this issue before you, and we will continue to bring this issue before you until the public receives the information needed. If you send emails to all licensees to make them aware of tuberculosis diagnosis and prevention techniques, and emails reminding them of the importance of immunization and diagnostic suspicion of measles, then you can do the same for rising cases of maternal and infant mortality. Again, we're looking for real data of how many mothers and babies are dying from this crisis, how and why. The mothers and babies from the Central Valley did not die because of the many L&D closures. There have been no closures of labor and delivery units in the Bakersfield area. We cannot claim that a workforce shortage is the issue. These young mothers and babies deserve safe maternal health care, and they did not receive it. They were failed by each provider, by the hospitals, and others. That is the issue. If we're going to make a real effort at making a difference in maternal and infant mortality, then you need the stakeholders who are calling for this data at the table. Thank you.
Thank you for your public comment. No additional requests are in queue.
All right, thanks. We'll bring it back to the board. Any additional questions or comments? Okay, we will move along to agenda item 7, updates from the Department of Consumer Affairs. And we will take questions and comments after we hear from both Ms. Saldivar and Ms. Whitley. Welcome.
Hey, good afternoon, President Lawson, members, and staff. My name is Lucia Saldivar, and I'm the Deputy Director of Board and Bureau Relations at the California Department of Consumer Affairs. Thank you so much for the opportunity to provide a brief update from the department. Firstly, DCA would like to thank board members for completing their annual Form 700 submissions, which were due on April 1st. As a reminder, all new board members must file a Form 700 with the Fair Political Practices Commission, or FPPC, 30 days after their appointment and annually on April 1st of every year thereafter. Additionally, board members must file a Form 700 leaving office statement within 30 days of leaving the board. We appreciate board members' commitment to this important disclosure that provides transparency and accountability to the public, excuse me. We are also excited to share that this spring, DCA relaunched the Enforcement Academy Training Program, which had not been held since the COVID-19 pandemic. This 4-day training program offered DCA board and bureau enforcement staff an overview of the enforcement process, investigations, complaint intake, and formal discipline, as well as the opportunity to learn best practices and make connections across other programs. Our March session included staff participation from over 20 different boards and bureaus, and we are planning additional academies in August and October of this year. I would also like to extend our gratitude to this board's incredible staff who assisted with this effort. It would not have been possible without you, so thank you so much for your partnership. I also wanted to report that DCA's Diversity, Equity, Inclusion, and Accessibility Executive Steering Committee recently selected 15 employees from throughout DCA to participate as members of the inaugural DEI Subcommittee. This subcommittee will meet bi-monthly to develop and implement multiple initiatives and goals to promote positive organizational impact. The first meeting of this subcommittee is scheduled for July 31st of this year, and we will continue to highlight their milestones and accomplishments in the future. We wanted to remind members about the upcoming reorganization of DCA's oversight agency, which is quickly approaching. On July 1st, the Business Consumer Services and Housing Agency will be split into 2 new entities, the California Housing and Homelessness Agency and the Business and Consumer Services Agency. The new Business Consumer Services Agency will be responsible for consumer affairs, licensing and enforcement, and the Department of Consumer Affairs, which will be among one of the 8 departments under this new entity. DCA will continue to keep board leadership apprised on the upcoming transition. And DCA would also like to continue to remind members and staff to please book their travel in advance to secure the best rates. It's incumbent upon all of us to ensure that we are being fiscally prudent in our decisions, especially when we are traveling for board business. Lastly, for members who are serving or will be serving in their grace period and are interested in continuing their service on the board, please reach out to Member Relations. We are so grateful for your dedication to public service and are happy to work with you to relay your interest to your appointing authority. And you can contact our team at memberrelations@dca.ca.gov. To close, thank you all so much for your commitment to advancing the protection of California's consumers. And I would also like to join in thanking Board President Lawson for her years of service to the board. I'm available for any questions that you might have.
Thank you. Any questions? I guess we're going to take questions at the end after we hear from Ms. Whitley. Let's hear from Ms. Whitley first.
Good afternoon. I am Stephanie Whitley, Deputy Chief for the Division of Investigations Health Quality Investigation Unit. I appreciate the opportunity to provide the board with this update. I just wanted to add a little more to Deputy Director Saldivar's thanking on the department's Enforcement Academy reboot, specifically Rashaya Henderson, your supervising special investigator, was key in reviewing material for presenting. And Paulette Romero, who is your staff service manager too, who's over your probation unit, was vital in instructing that part of the training. So we're super appreciative to them too, specifically for all their work getting our boards and bureaus all on the same page on best practices. So I just wanted to make a note of that. HQIU currently has 17 investigator vacancies. This represents a 20% vacancy rate for us. We have 10 candidates that are in the background process, and 1 candidate has just completed that process, and we are now negotiating a start date. To accelerate hiring, we continue to screen new applications on a 30-day cycle for each office with those vacancies. On February 26th and 27th, the division's training unit supervising investigator attended the FSMB Trauma-Informed Regulation Training in New Orleans. The course provided valuable insights on boundaries, the neurobiology of trauma, and strategies for interviewing and investigations. As a part of the enforcement collaboration model, we will be working with the Attorney General's office to review and enhance our processes and existing training related to sexual misconduct investigations. We are grateful to Executive Director Varghese for supporting our participation in this meaningful training. We remain extremely encouraged by the progress of the enforcement collaboration model with the board and the AGO. HQIUI staff continue to see a positive impact on communication, coordination, and shared problem solving as we work towards our common goal of consumer protection. HQIU has made measurable progress in reducing its pending caseload on cases over 1 year old. These improvements are reflected in our updated graphs and board material 7B. We continue to hold our regular meetings with board staff and provide automated reports with case updates. We always look forward to our continuing collaboration with our board staff. And I too would like to acknowledge President Lawson's years of service. And I've been back 3 years since my leaving the medical board. But I just want to say your leadership has been amazing to watch, and you do it through grace and passion for this consumer protection initiative. And we know it's not easy, but it is seen. You are seen.
Thank you.
This concludes my update, and I'd be happy to answer any questions.
Any questions? Dr. Thorpe.
Yeah, I just had a comment for the DCA. One thing that is, well, first of all, the travel app that you guys use is very difficult to use, extremely difficult. And I don't know what you can do to fix it, but it would be helpful to make it more streamlined and more user-friendly. Number two, I don't go in and check my requirements for my board, what I need to be doing to be kind of current on my educational stuff. I'm busy enough that I don't just spend my time doing that. It would be helpful to get like a reminder a month before you're due or something, so that you could. I do get a reminder on the 700 form, which I appreciate. But the other things that would be helpful to get in the reminder, and maybe you're giving it to me and I'm just totally oblivious. I just missed it. I don't know, maybe that's possible, but I would appreciate that. Secondly, I do think that the collaboration with HQIU and AGO and medical board is really, again, that recommendation that we got from the
Enforcement monitor.
yeah, the enforcement monitor was an excellent one, and we can see the effect. So it's really encouraging. Thank you.
Additional comments? No further complaints about the travel app? It's not fun. It's not fun. Yeah, we should raise our hand. Everyone agree? Yeah. I suspect that's not something that's under your direct control. Anything else? All right, let's open it up for public comment. All right, seeing none in the room. How about online, Sean?
Yes, if you'd like to make a public comment on agenda item 7, please do so by raising your hand or typing something into that slide out window. Be a few seconds to see if anyone queues up. We've got Monty Goddard here. Monty should be receiving that prompt.
Wasn't going to comment, but since it's Department of Consumer Affairs on the agenda, and they were the ones that hosted that forum in Sacramento on December 17th, I was wondering if the update that I'm looking for is going to come from the Department of Consumer Affairs or one of the sponsoring boards like the Medical Board and the Board of Pharmacy. Thank you.
Thank you.
Thank you, Monty. At this time, there are no additional requests in queue.
All right, we'll bring it back. Thank you, Ms. Saldivar and Ms. Whitney.
Thank you.
We appreciate your time. Sure.
I apologize. I shouldn't even be talking. I don't have a voice anyway. But I just want to respond to Mr. Goddard and say that the forum that we had in November or December was, in general, I think, successful. It's still unclear how that there are so many facets to this problem that it's unclear how we're going to resolve the issue of opioid prescribing in the state. And we've clearly cut down the amount of opioid prescribing. But what we've done is we've disadvantaged a large number of people who have chronic pain that have no other alternative for care. And it's, our compassionate treatment has been, we've discouraged so many people that it's not working. But there is some additional planning in the process that will hopefully take us to the next level. So hopefully we'll have a chance to give additional updates later.
Thanks. Any other comments or questions? All right, thank you again.
Thank you.
Up next, agenda item 8, discussion and possible action on legislation and implementation plans. Mr. Bone. And you will share with us the slightly revised agenda in which we're going to take these items to facilitate some people making their flights and others in the room, et cetera.
Just gotta finish emptying my pockets here, Madam President. 2 law books. Pardon me. I'm sad that this is the last time I will be appearing before you, Madam President. So I just want to add my echoes to the prior comments about you and your leadership, and you'll definitely be missed. And I've learned a lot and grown a lot and really enjoyed working with you and under you. And you'll be missed. I'll get to the updated agenda order in a moment, members. Good afternoon. It's been a very busy time in the legislature. And as you all may be able to see and imagine from the big board meeting agenda that we have, that the staff have been tracking a high volume of bills that pertain to the board's mission and operations. Last week, the suspense file hearings for the Senate and the Assembly Appropriations Committees were held, and a few of the bills that were originally on the board meeting agenda were not approved during those hearings and therefore are not expected to move forward. Accordingly, those were removed from the meeting agenda. They're shown in strikeout. Next week, the legislature will be voting to approve most bills that were introduced this year and are still alive. The month of June will also be very busy as the legislature has to approve the annual state budget and wrap up most of the policy committee hearings for the year. Turning to today's agenda, the blue and green, color-coded tracker list provides the status of the bills that are on the agenda for discussion today. The bills shaded in blue are ones that we do not believe require discussion, but the bills in green are those that are mostly new to the board, and those were introduced too late to make it onto the prior board meeting agenda. There are no updates to share at this time on AB 408, but our practice has been to take public comment on this bill. And unless there are other questions at this time, Madam President, I recommend we go to that item.
Sure, happy to do that. Are there any public comments on AB 408 in the room? Here's one.
Hello, my name is Lucas Evanson, speaking on behalf of the California Medical Association. CMA continues to be appreciative of the board staff and the board for their leadership in working to make this long overdue solution a reality. Physician health programs have a long history of successfully improving patient safety by addressing physician impairment before patient harm occurs. 47 other state medical boards have recognized this success and implemented these programs as a proactive tool to identify and address impairment while supporting physician rehabilitation and ongoing oversight. CMA looks forward to continuing to work with the board this year as AB 408 continues through the legislative process. Thank you.
Thank you. Any other public comment in the room? All right, Sean, public comment on AB 408.
Yes, if anyone like to make a public comment on AB 408, please do so by raising your hand. Type anything in that window. All right, first up here we have Sigrid. Should be receiving that prompt.
Hi, good afternoon. My name is Sigrid Burris, and I'm a trauma surgeon and here representing the California chapters of the American College of Surgeons. AB 408 would create a confidential and evidence-based program that helps physicians address health challenges and helps us remain safe to practice and provide care to our patients. When physicians can access support without fear of discipline, everyone benefits. Physician health programs follow nationally proven evidence-based approaches that support physician wellness and safe practice. Physicians experience high rates of burnout, but often avoid seeking help due to stigma and fear of disciplinary consequences. The confidence barrier, and PHPs recognize mental health conditions and substance use disorders as treatable medical conditions, not moral failings, and encourage recovery without unnecessary penalties. Studies show that PHPs achieve long-term recovery rates for up to 90% of physicians with substance use disorders, keeping skilled and experienced physicians in practice and patient access to care. In California, most other healing arts boards and even attorneys have access to similar wellness programs, and physicians deserve that same opportunity. We from the California chapters of the American College of Surgeons look forward to continuing to partner with you and getting AB 408 passed. Thank you.
Thank you for your public comment. Next, here's David Granovetter. David should be receiving that prompt. Let's go here to Veronica Lasso. Should be receiving that prompt. David will come back around to you.
Hi, yes. I'm Veronica Loso. I'm a psychiatrist with UCSF. I'm also here representing the California Society of Addiction Medicine. And I also just wanted to speak in support of AB 408 and thank the board for supporting this bill and anything that we can do to push this forward because this is, as previously mentioned by some of the other commenters, something that California has unfortunately fallen behind in our management of physicians struggling with substance use disorders and mental health, and that this creates a safe, effective way to actually get comprehensive treatment to the physicians that need it in a way that keeps the physicians safe as well as patients by creating the avenues for folks to seek treatment in a non-punitive way. So we in the California Society of Addiction Medicine very strongly support this bill and would ask that you do the same. Thank you.
Thank you for your public comment. Go back to David now. David, looks like your line's open.
Yeah, can you hear me okay?
We can. Please go ahead.
Okay, thank you. So President Lawson and members of the board, good afternoon. My name is David Granovetter. So I'm a board certified addiction medicine physician, having practiced in California for more than 36 years. And I've spent more than 2 decades working in physician health and well-being and consultation regarding physicians whose health conditions may affect their practice. I'm also a physician in long-term recovery from the disease of addiction myself. So I serve as a board member of California Public Protection and Physician Health, otherwise known as C3PH, and I'm speaking today on behalf of C3PH in continued support of AB 408 and the creation of a California Physician Health and Wellness Program. The need for a structured program such as this in California remains urgent. You know, that need matters for physicians, but more importantly, it matters for patients. When physicians are struggling with substance use disorders or mental health conditions, sometimes cognitive concerns or other potentially impairing illnesses, the safest system is not one that waits passively until a crisis, complaint, or disciplinary event occurs. The safer system is one that creates a credible pathway for early identification, confidential engagement, expert evaluation, and treatment when needed, as well as structured monitoring to maintain accountability. Now, a well-designed physician health program is not a benefit program for physicians at the expense of the public. It's a patient safety program. It gives physicians a reason to come forward earlier before illness progresses to impairment and before impairment leads to patient harm. It also creates accountability with clear expectations, independent assessment, treatment compliance, monitoring, and defined reporting pathways, especially when patient safety requires action. C3PH continues to believe California has a critical opportunity to build a program that aligns with national best practices and reflects the experience of successful physician health programs in 48 other states. The core principles are straightforward with early intervention, confidentiality when appropriate, independent administration, clinical expertise, meaningful monitoring, and clear action when public protection requires it. We appreciate the board's sustained attention to the issue and its clear focus on protecting the public. AB 408 offers California an opportunity to build a program that supports physicians while strengthening public safety. We urge the board to continue in supporting the development of a strong, independent, confidential, and accountable physician health program for California. Thank you for the opportunity to comment. And on behalf of myself and C3PH, thank you, President Lawson, for your years of service.
Thank you for your public comment. Next here we have Rob Gordon. Rob, you should be receiving that prompt.
Sean, can you hear me okay?
You can, Rob.
Yeah, I'll keep this short about the THP program. You need to understand a concept called forced activism. That's when people, circumstances of extreme injustice by some organization forces you to be an activist. It may be something you're totally not interested in, like all this crap. But from my point of view, people don't know. A lying con man claimed he was my psychiatrist who I'd never even met outside of a non-consensual 10-minute online meeting. They pile in retaliation for my complaining about the services of a different physician and some of the billing fraud I saw at our federally qualified health center monopoly here in San Diego, Family Healthcare Centers of San Diego. In retaliation for that, they did all sorts of things. They took out a workplace restraining order. The medical board fully supported them, gave much more than a summary, really helped the prosecuting attorneys. So the hypocrisy on this is off the scale for me hearing about this. And I think this forced activism, by forcing us, to talk to the legislature, whoever, that we don't want to, you guys should pay for that. You are all unpaid volunteers. The issue of whether 13 unpaid volunteers should have as much power as you guys have is incredibly important. I won't go into that first. But you need to understand the rage. The public was overwhelmingly against it. But you're just persistent. And you're transferring the cost. I call it agents of failure transfer. You're transferring your failure, the repeated failure back to us, and we're paying for it. I call this cutting down trees in the rainforest. Somebody cuts down a tree for the rainforest, they never pay the full cost of that tree. They might make a tidy profit, but they never pay the cost of it. So anyway, you're causing outrage. It's almost like trolling. We have to use that to highlight other organization with such severe operational problems shouldn't be doing anything like this. So we're going to have to use that to highlight the other issues you're doing to try to get some leverage out of it, because it's grossly unfair that it's called separate but equal. You're giving physicians a separate program that the rest of us don't even have. The rest of us, you can just be told to take a urine test and you're automatically a drug addict. So it's the whole system is outrageous. That's all I have to say for now. I could go on for hours. Thank you for listening.
Thank you, Rob. Next here we have Marion Hollingsworth.
Okay, can you hear me?
Can, Marion. Please go
Okay,
ahead.
thank you. This is Marion Hollingsworth, patient safety advocate. I continue to oppose 408 because it allows physicians to hide their addictions without giving patients informed consent before treatment by that physician. I have said this before, informed consent should include all the risks and benefits of a treatment or procedure, and that should include an impaired doctor. You have already had an unusually high number of disciplined doctors and ones with accusations and suspensions this year. In fact, about a month ago, I counted the number of doctors disciplined in a few-week period. It included 38 doctors, and 19 of them had been disciplined, suspended, or given accusations for substance abuse, DUIs, being impaired in the OR. It's a ridiculously high number, and it's alarming from a patient standpoint. It's extremely frightening. 408 hurts the credibility of the medical profession by further creating fear in the safety of physicians. Patients should have confidence in their medical team before any procedure. Having 408 in place yanks away that confidence, making patients more unwilling to seek help. Please don't push 408 on the California consumers. Please save lives by not doing this. Thank you.
Thank you for your public comment. This time, there are no additional requests in queue.
Thanks, Sean. We'll bring it back to the board. Any comments, questions on 408? All right, we can move along.
Thank you, Madam President. Just a quick note about the order of the next items on the agenda. We'll be doing next F, AB 1637, and then we will jump down to item J, AB 2386. AB 1637 adds language to the Medical Practice Act to limit the authority of someone other than an authoring physician to change that physician's patient's notes. The board discussed this bill at our prior meeting and adopted a supportive amended position to ensure that medical assistants, scribes, or others authorized by that physician can make changes to those records. The board's requested changes were included in the bill along with the authority for another physician who is supervising a physician who happens to be an intern, resident, or postdoctoral fellow to make changes to those patient records. The board staff wished to check in with the members today to see if there was agreement that the current version of the bill is appropriate or whether additional amendments are necessary. If the board is comfortable with the current language, then we recommend that the board adopt today a support position. If not, we ask that you indicate what other changes may be warranted, and then we would suggest a revised support if amended position. Happy to answer any questions.
Thank you. Any questions? Dr. Ayala Rodriguez.
I know that I made like a lot of comments last meeting. I totally see the feedback that we provided reflected in there. Thank you so much for the consideration. No other comments. Thank you.
Great. Dr. Sy, are you?
Yeah. I'm also the ex officio member of the PA board, and in looking at this amended provision, my question would be, nurse practitioners and PAs usually have a practice agreement with the supervising physician, and they pretty much practice fairly independently. And how would that be reconciled with this legislation in terms of if the PA or the MP is seeing a patient and an addendum needs to be made? How would they go about doing that? Or if they don't need the counter signature of a physician. And the other thing is do we have any position from the nursing board or the PA board regarding this piece of legislation?
I'll respond to the last part first, Doctor. I'm not aware of any comments or input from those other boards. I think this is principally about, this is in the Medical Practice Act. This is principally relates to physicians. It's sponsored by, Union of American Physicians and Dentists. And then to your former question, if you look at the bill language, subdivision C, paragraph 1, it authorizes a scribe, medical assistant, or other authorized individual acting under the authority delegated by the authoring physician and surgeon. So as a physician and an attorney, I guess I would turn the question around to you, Doctor, as to whether or not you think that's sufficient to address the circumstances that you described.
No, I think that's the language is that they are authorized now, so it doesn't require a physician anymore to amend that right? So it solely delegates that authority without any other necessary steps, whereas, because I have an MP or a PA or my medical student, or sorry, my resident, they make the addendum and they're authorized under this piece of legislation. I wouldn't no longer be needed to countersign that addendum, right? Because it's more of a technical issue than what the bill addresses, and so that's sort of where my confusion comes in. Is they're authorized now, but once they're authorized, do I still need to countersign that, or because of this verbiage in the legislation?
So in the supervisorial relationship or in the delegated authority relationship, I think the answer is no, that this is separate and apart from standing orders or a PA written, supervisorial agreement. But at the right time, Madam President, if you want, we can go to public comment, because sitting to my left is a representative of the sponsor of the bill.
Okay, thank you.
Great. Dr. Yep, it looks like you're queuing up.
I actually can help answer the question.
Okay.
I was in the airport listening to the doctor's company CME on the documentation and what if you're in the hospital medical board. In reality, I'm comfortable with this amendment. I'm comfortable with the way it is. In reality, in practice medicine, your PA and prescribed change is still under our liability. It is our practice to review, to amend, and particularly now the comment is that there is electronic medical record. Anyone, anytime, make any entry is recorded. So it's important for physician, whatever this bill is, you have to practice the way we have been practicing, documentation, responsibility. And even though the MP will make a note, change it, it's still our responsibility to amend or to review or to accept the responsibility. Even in the hospital, a lot of electronic medical record system, even we added a note, it's electronically recorded. Who did it, who made it. So I think the safeguard there. Thank you.
Thank you so much.
Madam President.
Yes, yes, the way that I see it is that in this particular bill, we're talking about the specifics of who can edit it, right? And that's what we're discussing from that perspective. And I think that we go into the process, can an organization request for a supervisor to amend it, for a supervising physician to create an addendum? I don't think that that's like 100% addressed, and I don't think that it should be, because it's already, the question in this particular case is like who can edit it. And these are like the approved individuals that can edit it, right? Like the medical record. The other thing so to me, this is enough, this is sufficient. If people are concerned, for example, about like, do we need to have some form of disclaimer that this bill does not supersede or remove organizational policies, for example, to provide cross-collaboration documentation, when supervision occurs or collaboration occurs. Like I wouldn't have a problem with that, but I don't even think that that's needed, because in here, we're just like saying who's allowed to edit the medical record, and it's already there.
Okay, should we open it up for public comment? And here's some more.
Yes, my final thing is if it doesn't really affect how we do things currently, what's the purpose of the legislation? We're trying to achieve something, and if it doesn't achieve what it tends to achieve, and so that's why I'm thinking something's changing. But as Dr. Yip alluded to, nothing's going to change. So then, what's the goal? Are we achieving that goal?
I'm confident that the public comment period will illuminate that, Doctor.
Let's go to public comment.
Well, thank you. Madam President, George Osborne, representing the Union of American Physicians and Dentists. We're the sponsor of this legislation. The situation arose with one of our members, of an MD, in Central California, working for the Department of Education, conducts clinics throughout the district treating autistic children. She would submit her patient notes to the supervisor above her at the county office, and the supervisor would change the notes. because she said it makes the district look bad. So that's where the genesis of this bill came from. So then we investigated it and looked at it, and I looked at the statutes, the Medical Practice Act, and also the Civil Code. And if for this to be against the law in current statute, it would take a two-step process. First of all, the person changing the notes must have had a fraudulent purpose. So that's a pretty big bar to cross, and being an attorney, you'll understand that. And then secondly, then it's against statute. So we thought it'd be much simpler to say, if you change the notes, well, you just simply can't. It's against the law. And during the course of deliberation, including before your board, which I appreciate, and in consultation with CMA and other medical groups, including the emergency physicians and the OBGYN groups, we came up with a couple of additional amendments that have to do with practical application in their practices. That's where those additional amendments came from. Not something that we generated, but those were presented to the author by CMA and these other medical groups, and she accepted them. And that's really, that's where we are today. And we would appreciate it, of course, the board would continue its support. And I'm here to answer any other questions that the board might have.
Thank you. Okay.
So when you say that this physician supervisor, well, it wasn't a physician supervisor, it was a lay supervisor.
It was a bureaucrat who was not an MD.
Correct. Okay, thanks.
Is that clear enough?
Yeah. All right, Dr. Ayala Rodriguez.
Thank you. And for example, I'm going to use a recent example. So our organization went through an electronic health record implementation. So many times when electronic health records, when you adopt one, you have to create different profiles. So different profiles within an electronic health record have different rights. Some people can only view, some people can only write, some people can edit, some people can bill, some people cannot bill. My understanding in this particular bill is to be very, very, very specific that patient records, clinical documentation, people who have access to that should pretty much only be clinicians. Like, you're not a clinician, you're not a licensee, you're not part of that, you should not have that right. So I can see this bill, for example, affecting EHR implementations, because now that's no longer going to be a question. Now pretty much this is defined, you're a clinician, you have that right. You're a stakeholder, you have that right. You're not a clinician, you don't have that right. Because right now, that's an open question from the technology world as you do the implementations.
All right, let me see. Is there additional public comment in the room? How about online, Sean?
If anyone would like to make a public comment, please do so by raising your hand or typing anything in that Slido window. First up here is Rob Gordon. Rob, you should be receiving that.
Yeah, my comments might be, you can hear me, right?
Yes, we can, Rob.
Yeah, my comments might be a little bit scattered, but first of all, that supervisor should be charged with fraud to the maximum you can possibly do. The second thing, this has happened to me. I don't know really where to start, but the worldview or the attitude among the people who regulate this is that medical records are sacrosanct. They are the words of the prophets. I should say the attitude of the medical board and the investigators. They are just unvarnished truth, whatever people say. But the reality is, at least in my federally qualified health clinic, anybody could change anything they want, and they can do so with fraudulent intent, which was done with me. It was done in retaliation for reporting some billing fraud. In your world, you'd be protected under whistleblower laws, but we're just normal people out here. So I guess on the modifications that the board is making, I keep those records sacrosanct. If you're pretending they are, at least try to make them that way. I would require at least an initial from anybody who authored, who changed anything. You'd say, if I was changing, I'd say RG on behalf of, and at least then the records are intact. Right now, it's just, people can say whatever they want. They can go back into old, 5 years ago. I got new psychiatric diagnoses that way, and nobody cares. So I'll give some bonus, some information that doesn't involve you, so no need to be offensive. But HIPAA is absolutely fraud, and I can say that just unequivocally. Their success rate, their investigation rate is 0.007. It's infinitesimal. For any person who makes a HIPAA complaint, nothing happens ever. I mean, it's like 1 or 2 people since the program's been in existence, and the bigger frauds have simply never happened. The criminal intent has like a jail sentence and stuff, but everybody talks about HIPAA like it's just God's law. It's 100% a fraud. Anyway, I could go on for hours about medical records. They are not private, and they are not secure. So go, yes, get this building at least as a start.
Thank you, Rob. This time there are no additional requests in queue.
Thanks, John. All right, we'll bring it back to the board. Aaron, you need direction from us specifically as to,
If the board is comfortable with the current wording of the bill, then I would say a support position is appropriate. Otherwise, please clarify what other changes and then adopt a supportive amend.
great, Dr. Yip, do you have a question or comment? Make a motion.
A motion to adopt.
I second.
I'm sorry, adopt
Well, you didn't get,
support.
okay.
Thank you.
It's like we didn't get a position there. All right, we have a motion and a second to support. Any further comment? All right, Ms. Nadar, can you please perform the roll call vote for us?
Mr. Orkatov,
Yes.
Dr. Ayla Rodriguez.
Yes.
Ms. Chung,
Yes.
Ms. Holmes,
Yes.
Dr. Mahmood,
Yes.
Dr. Solis,
Yes.
Dr. Tarp,
Yes.
Dr. Tolbert,
Yes.
Ms. Torres,
Yes.
Dr. Sai,
Yes.
Mr. Watkins, Dr. Yep,
Yes.
Ms. Lawson.
Yes. All right, that motion passes. What's up next?
The next bill
Bill.
is AB 2836. Excuse me, 2386. 2386. This bill includes 2 significant proposals. The first would authorize participants in the Licensed Physicians from Mexico program, or LPMP, to obtain a permanent medical license from the board. Currently, those licensed under this program have a limited term license and have no opportunity to renew it. As currently drafted, the LPMP physicians will be eligible if they completed their 3-year licensing term in good standing, obtained certification from the Educational Commission for Foreign Medical Graduates, or ECFMG, passed all 3 steps of the United States Medical Licensure Examination, also known as the USMLE, received positive peer review evaluations each year, have an offer of employment somewhere in California, and have completed all required CME and otherwise meet the other requirements for licensure as a physician. The second aspect of the bill would require the board to issue a provisional medical license to those who completed postgraduate training in a program that is not currently recognized in California law. That is the Accreditation Council for Graduate Medical Education, ACGME, the Royal College of Physicians and Surgeons of Canada, or the College of Family Physicians of Canada. Those who have completed their training outside of North America are generally referred to as internationally trained physicians, or ITPs. In addition, to qualify under this law, ITPs must hold a full and unrestricted license to practice in another country and have been in good standing for at least 4 years, excluding any time in postgraduate training. They must have had no disciplinary action taken against them from a licensing authority, not been subject to adverse judgments or settlements that constitute a pattern of negligence or incompetence, nor committed any disqualifying acts or crimes. They must be ECFMG certified, pass steps 1 and 2 of the USMLE, and be appropriately proficient in English, be authorized to work in this country, and have an offer of employment from a sponsoring entity that is approved by the board. Once licensed, they shall be supervised by a California licensed physician who must enter into a written supervision agreement with the provisional licensee. The sponsoring entity must generally be a licensed facility or a clinic owned by a public hospital or health system Further, the sponsoring entity must ensure that the provisional licensee practices under appropriate supervision, maintains an appropriate peer review process, and is responsible for the medical services of the provisional licensee. The board would also be authorized to extend their provisional licensure period one time for up to an additional 3 years if the licensee demonstrates continued progress towards meeting licensure requirements. If they have passed step 3 of USMLE, completed 36 months of practice in California without any disciplinary actions, and received a positive recommendation from their supervisor or the director of the sponsoring entity's medical staff, then under this bill, they will be deemed to have met the instruction, education, and training requirements necessary to obtain an unrestricted medical license. Last August, the board heard a presentation from Dr. Hank Chowdhury, President and CEO of the Federation of State Medical Boards, or FSMB, who discussed their work along with other key organizations to help guide state boards consider how to evaluate potential pathways to licensure for ITPs. At that time, Dr. Chowdhury indicated various challenges that ITPs face, including immigration uncertainties and complexities, questions related to the quality of care provided by ITPs, and how to determine what training is substantially similar to the training typically required for licensure in the United States. The analysis of the bill provides links to various resources from FSMB's advisory committee formed on this topic and includes recommendations that revolve around creating strategies to determine whether or not ITPs have been appropriately trained and possess the proper knowledge and clinical competencies. Those recommendations from FSMB emphasize the value of adopting appropriate standards relating to assessment of an ITP, using specialty examinations that inform learning plans, provide multimodal evaluations, determining the qualifications of supervisors, and ensuring that ITPs are treated appropriately from an employment perspective during their time here. According to the FSMB, as of earlier this month, the state of Georgia became the 25th U.S. jurisdiction to enact legislation that provides a pathway for ITPs to obtain a full medical license. FSMB further indicates that 18 states have pending legislation that would also license ITPs, including this bill we are discussing now. Clearly, there is a lot of momentum surrounding this issue nationwide, with California actually being an early entrant into this space due to the Licensed Physicians from Mexico program. I have not been able to review all the laws of those various jurisdictions, but to the best of my knowledge, no 2 states have taken the same path. Several states have a pathway on the books that, similar to this bill, calls for their state medical board to determine whether the ITP's training is substantially equivalent to ACGME standards. I am not aware that any of those states have adopted a methodology to make such a determination. As currently drafted, the bill tasks the board with determining what is appropriate training, what should be required of sponsoring entities, and what are the appropriate fees to charge. This is certainly an important issue for the board to address and should be done so with the appropriate time and necessary resources in the view of board staff. So many questions are raised in this legislation that the topic deserves a substantial examination that ought to be supported by experts and possibly additional board staff. Accordingly, the board staff cannot endorse the approach in AB 2386 or in any other ITP licensure pathway. Unfortunately, due to the legislature's calendar, this board meeting today and tomorrow represents our best opportunity to weigh in on the bill. By the time that the board next meets in August 20 and 21, the legislature session will have 10 calendar days remaining, making it nearly impossible for interested parties and the legislature to consider any requests that the board may have at that time. Returning briefly to the Physicians from Mexico provisions of the bill, I'm almost done, Madam President. The board staff believe that the prior UC Davis evaluations have shown the competency of the pilot program participants and have improved access to care among the underserved communities who are the intended beneficiaries of that program. The bill, however, authorizes them to practice anywhere in California and without limitation on their area of practice. We believe that doing so could erode access to care among those underserved communities that they are intended to be, that they are serving right now, and create new consumer risks if they practice medicine outside of their training and certification. Accordingly, staff recommend that ongoing licensure be limited to those who have completed the pilot program and whose license was extended under the prior legislation cited in the analysis. The other recommendations from staff on the full requirements for ongoing licensure for this group of licensees are detailed on pages 8 and 9 of the analysis. As for the portion of the bill related to ITPs, staff believe that the board should first be provided appropriate resources from the legislature to thoroughly review the various state ITP pathways and FSMB guidance on these matters, including a substantial interested parties process to obtain a wide range of input. And if the board believes it is appropriate, recommend to the legislature new licensing pathways and appropriate statutory changes to license ITPs. We believe that a position of oppose unless amended is appropriate to seek the changes that I've described and are further detailed in the analysis. One quick clarification, Cedars-Sinai is no longer opposed to AB 2386. Rather, they are now on record as having concerns. I believe they have a representative online who will be able to elaborate further, and I'm happy to answer any questions.
Great, thanks, Aaron. Any questions? We open it up for, sorry, Dr. Tsai.
I have one. Under bullet point number 4, the applicant, applicant has no open complaints against their license and no history of enforcement action. That pertains to their medical license. Is there any other
Could you direct me,
criteria?
what page are we on the analysis?
Sorry,
Dr.?
9.
Page 9, sorry. It's a long
Yeah,
analysis.
The recommendations for oppose unless amended, amendment number 4, the applicant, which is the second bullet point on page 9, the applicant has no open complaints. Are there any provisions or recommendations that they have no criminal DUIs, accusations against them, or is it only pertaining to their medical license? The way I see it is, if they have a DUI, then of course now they become somebody that we should monitor. And so if they have just a clean medical record, this amendment would allow them to get that sort of transition to permanent license.
So we're talking about the LPMP provisions, not the
Right.
ITPs. No,
The pathway to unrestricted license.
well, for the physicians from Mexico, we're recommending not make it an unrestricted license. It would be ongoing licensure, but they would be tied to essentially doing the same type of work in the same type of communities that they're working in right now. But I think with respect to your point, and I'll let my colleagues weigh in, I believe if you have if there's a pending criminal matter, I believe that's treated as a complaint, and that would not qualify them because that would be an open matter.
So it's not just to the medical. Any
Right. Yeah. Yeah. Good question. Thank you, Doctor.
Shall we open it for public comment and hear more? Yes, public comment. Is there any public comment in the room? Great.
No, it's on.
Oh, cool. Thanks, Aaron. Good afternoon, Madam President and members of the Medical Board. My name is Navreen Randava, Legislative Assistant to Assemblymember David Alvarez, the author of AB 2386. Assemblymember Alvarez would like to thank Medical Board staff for their collaboration and input on this measure. Our office has appreciated the opportunity to meet with staff throughout this process, and we look forward to continuing this dialogue. As you know, California is experiencing a significant and growing physician shortage. By 2030, California will need thousands of additional physicians to meet residents' basic health needs, and millions of Californians already live in communities without adequate physician access. AB 2386 is intended to help address that challenge in a responsible and carefully structured way. This bill builds on the success of the Licensed Physicians from Mexico program and creates a new pathway for qualified, internationally trained physicians to serve California communities that continue to face serious access barriers. The purpose of AB 2386 is not to diminish California's standards, weaken consumer protection, or reduce the board's oversight role. To the contrary, Assemblymember Alvarez is committed to working closely with the medical board to ensure this pathway is rigorous, accountable, and protects patients' safety. We recognize and take seriously the concerns raised in the board staff analysis, including questions relating to training standards, supervision, competency, implementation, and consumer protection.
These are exactly the issues where the board's expertise is essential. The author's goal is to work with the board to craft a pathway that reflects California's high standards while responding to the urgent needs of underserved communities. The staff analysis recommends removing the new international physician pathway and replacing it with further study. While we understand the desire for additional evaluation, we are concerned that a study-only approach would delay action at a time when access crisis is already affecting patients in California. Fortunately, California is not starting from zero. We have experience through the Licensed Physicians from Mexico program, which has shown that internationally trained physicians can serve patients effectively when there is clear framework, appropriate oversight, and a connection to communities with demonstrated need. The issue is especially important for communities like Assembly District 80, which includes Southern San Diego County communities near the United States-Mexico border. In these communities, patients often face not only provider shortages, but also language barriers and cultural differences that affect access, trust, and health outcomes. We believe California can do both, protect consumers and expand access to care. Those goals are not in conflict, and other states have already shown that structured pathways for internationally trained physicians can move forward while maintaining medical board oversight and patient safety protections. For many underserved communities, patient safety also means timely access to qualified physicians before conditions worsen or care is delayed. With the medical board's continued engagement, we believe AB 2386 can become a thoughtful, balanced framework that strengthens California's physician workforce, improves culturally responsive care, and maintains rigorous standards for safe and effective medical practice. Assemblymember Alvarez looks forward to continuing to work with the medical board and staff as this measure moves forward. We respectfully ask the board to remain engaged with us in developing this new IMG pathway rather than adopting a position that recommends removal of the new international physician pathway. Thank you so much to staff and board for your time.
Thank you. Are there other commenters in the room?
Thank you so much, and really appreciate that you were flexible with us, and my wife will be very welcoming that I'm not arriving at 11 p.m. Good afternoon. My name is Dr. Ilan Shapiro. I'm a physician, an immigrant, and also a Mexican-trained physician who has been privileged to actually serve in California for the past 10 years, Florida for 5, and 3 in Illinois. I know perfectly well what's to be an international trained physician and an international medical graduate. And also I have the privilege to work in Altamed Health Services and be part of the co-sponsors of AB 2386. First of all, thank you so much for this engagement. I know that it's hard. I know that there's a lot of questions, but right now we need to solve them. At the moment that I see my patients and they need insulin, they need a physician. They need someone to actually engage with that part. And this conversation is part of that solution. Is it perfect? We'd love to tell you that it is. And it's clearly, we have a lot of things to do with this. But it's one part of creating that pipeline that we need to create to make sure that our communities, and especially right now with all the changes that we're having in our beautiful California, in our beautiful United States, to actually make sure that our community is taken care of. The objective of AB 2386 is not to lower the bar, is to build a structured and supervised pathway and qualify international trained physicians to serve the communities that we need the most. And that's so important for the things that we need to be doing. The board's oversight, it's needed. The collaboration and conversations that we need to have here, they probably will be hard, but we need to actually move forward. We have already understood the training and standards and also the patient safety that we have with the Mexican physician program. Then we already have here California data that is so important for us. California is not starting from zero. The experience of what we have done with the Mexican physician program, with academic pathways, with faculty, we already know where to start. Then the most important thing that I want you to know from my part is that we have had a lot of different states, including North Carolina, that has a lot of conversation regarding the medical board that actually amplifies the way that we can actually be having this conversation. And also, we already have what data we have here in California. It's very important to understand that right now we need to actually reflect what California workforce is, that culturally and linguistically needed physicians that need to be in our communities, and most importantly, to create that pathway. What makes California approach especially strong is AB 2386 brings together multiple safeguards: ECFMG certification, international board certification, supervised California practice, and other steps that actually enhance the way that we can actually do this. And we need your voice. We need your collaboration, and we need to make sure that right now this path, as part of the things that we have, is so important. Then I respectfully hope that you support this and we continue to engage in this conversation.
Thank you. Additional public comment in the room?
Good afternoon, and thank you for the opportunity to provide public comment today. My name is Andrea Mavisca, and I'm with the California Primary Care Association Advocates, representing California's community health centers and clinics, providers on the front lines of care for more than 7 million Californians. We are proud co-sponsors of AB 2386, which provides a timely and necessary solution to one of the most urgent challenges we face, ensuring patients can access care. California is experiencing a physician shortage crisis. Today, more than 11 million Californians live in areas without enough primary care doctors, and the state will need more than 8,000 additional physicians by 2030 just to meet basic demand. At the same time, community health centers and clinics are struggling to recruit providers. Over 70% report critical workforce shortages, and it now takes an average of more than 27 weeks to fill a physician vacancy. The shortage is compounded by a stark gap in representation that my colleagues prior to me spoke to, with Latinos making up about 40% of California's population, but only about 6% of physicians. We know that solutions like AB 2386 work. As again, my colleagues shared, California's existing licensed physicians from Mexico program has demonstrated that clear success. Participating clinics have reported improved detection and management of chronic conditions, stronger patient satisfaction, and better communication with Spanish-speaking patients who are more comfortable and more engaged in their care when treated by culturally and linguistically competent providers. AB 2386 builds on this proven model. It creates an additional carefully structured pathway for qualified internationally trained physicians to serve in California while maintaining the high standards that protect patient safety. More broadly, internationally trained physicians are already a critical part of our healthcare system, making up nearly a quarter of new residency placements nationwide and filling essential roles in primary care and underserved communities. Importantly, this bill is complementary to the licensed physicians from Mexico program. Together, these pathways expand our ability to meet urgent workforce needs now while continuing to invest in the long-term solutions. At this moment, amid growing demand, persistent shortages, and widening disparities, we cannot afford to delay. AB 2386 is a practical, evidence-based step to expand access, strengthen our workforce, and ensure every Californian can get the care they need. We respectfully urge your continued engagement so that we can move this critical policy forward and hope for your support. Thank you.
Thank you. Additional comments from those in the room? Okay, Sean, how about online?
Yes, if you'd like to make a public comment online, please do so by raising your hand or type something in that Q&A box. First here we have Lawson Mansell, I believe. Should be receiving that request.
Hi there, can everyone hear me?
We can, please go ahead.
Great. President Lawson and the rest of the board, thank you for the opportunity to comment today. My name is Lawson Mansell, a senior health policy analyst at the Niskanen Center, a Washington DC-based think tank. Assembly Bill 2386 would convert the successful but time-limited licensed physicians from Mexico program into a permanent pathway to full licensure and extend comparable pathways to other ITPs who meet rigorous qualification standards. AB 2386 builds on a track record of demonstrated success. The existing licensed physicians from Mexico program has produced strong outcomes. An independent evaluation by UC Davis Center found that participating physicians integrated seamlessly into community health center practice. This bill also follows a pathway already blazed by 25 states who passed similar legislation over the past few years. The bill before you today reflects the same design principles those states have adopted: clear eligibility criteria, structured sponsorship by licensed facilities, supervised provisional practice, and a path to full licensure. California is also in a unique position compared to other states that have already passed bills to implement this law without significant administrative burdens. The credentialing and oversight systems built for the existing Mexico program are already in place. At the Niskanen Center, our staff have worked with dozens of states that have passed these pathways into law. No two states have passed identical bills, as each state has unique challenges and standards. We stand ready to assist the board with crafting the right details for California on top of the already strong foundation with the Mexico program. Thank you for your consideration, and I'm available for any questions.
Thank you for your public comment. Next here we have McKay Carney. Should be receiving a prompt on your end.
Hi there, thank you. McKay Carney on, okay, great, you can hear me. McKay Carney on behalf of Cedars. Thank you so much. Wanted to express continued concerns, but very much look forward to continuing to work with the author and co-sponsors on additional amendments as we move forward in the process. Thank you.
Thank you for your public comment. Last here is Mike Zimmer. Mike, you should be receiving that prompt.
I think I just did. Thank you. My name is Mike Zimmer. I'm with World Education Services, a nonprofit social enterprise dedicated to helping international students and immigrants achieve their career potentials. Thank you, President Lawson, and members of the committee of the board for allowing me to testify. As others have testified, California, like most states, already faces a growing and significant shortage of physicians. In addition, particularly in California, recent census data indicates that 40% of Californians speak a language other than English at home, underscoring the need for a physician workforce with greater linguistic and cultural diversity. As an earlier individual testified, California was really a very early leader nationally in seeing the value of internationally trained physicians through the establishment of the licensure pathway for physicians trained in Mexico, which created one of the first systems for authorized practice of international physicians without requiring an ACGME certified training program. As others have testified, a large number of states have already enacted this legislation. I would point out that I could give you the states, but that would be boring, but it represents a broad political and geographic spectrum. Of those 25 states that have enacted the legislation, most at this point are still in the regulatory process, but 12 are now accepting applications, and a number of those states, I think 6 at this point, have already licensed physicians, having the medical board done their own review. Like the legislation adopted in surrounding states, AB 2386 contains the important provisions necessary to assure quality care, requiring completion of prior international residency or postgraduate training, previous licensure in a country of training, sufficient practice history, ECFM&G certification, USMLE steps 1 and 2, and a bona fide offer of employment from an eligible hiring entity. President Lawson, again, members of the board, thank you for the opportunity. We have worked with a number of states and stand ready to work with the board on crafting a system that works best for California. Thank you.
Thank you, Mike. Additional request here from Rosa Fernandez. You should be receiving a prompt on your end.
Qualified. I'm sorry.
Go ahead,
Are you
Rosa.
able to? Okay, I'm sorry. Good afternoon. I'm Rosa Vivian Fernandez. I represent San Benito Health Foundation. I'm the CEO of San Benito Health Foundation, a federally qualified health center located in Hollister, California. We've been around for over 50 years. We are the first recipients of Physicians for Mexico program who came in 2020 at the height of the COVID pandemic. I can not express to you the enormous positive impact these clinicians have had in access to care, and the number of individuals served, the number of visits, and the quality of care to our community. And we strongly urge your support of this bill in order to keep these clinicians who have completed residencies in their country of origin continue to be binationally licensed and continue to provide services to our community. We urge you support in order to continue to have positive positive impact, not just in our community, but communities throughout California. Thank you.
Thank you for your public comment. No additional requests at this step.
Okay, we'll bring it back to the board. Aaron, can you remind us what you need from us?
A position, the staff recommended position is oppose unless amended. And the amendments are voluminous and they're described at the base of the analysis.
Comments, questions, Dr. Mahmood?
Yeah, I'm so sorry if I was sleeping. So only thing they are asking is that no accredited education here, the residency training or something, everything else will be included in this, huh? That's what they are asking, the exemption?
One of the key exceptions would be the training, instead of being ACGME certified, or one of the training that we typically accept, which is available in North America, that you'd have 36 months of training
Yes.
in some other program in another part of the world that the board has to make a determination is substantially equivalent to ACGME training, which at this point, we're unclear on how the board would make such determination, nor do we believe that we have the resources on staff right now to do so.
And this will be only for the people who are already working here or for anybody?
No. These would be for those who don't otherwise qualify. This is a new licensure pathway for those who don't otherwise qualify for licensure under one of the typical ones that we have right now. But likely the most significant challenge that they're facing is that they do not have ACGME accredited training.
Yeah, but you know that the candidates will be in millions, not like 100,000. There are so many people like India and China and Pakistan and Mexico and all this stuff. How are you going to justify this thing and bringing all those people? And how are you going to justify people who go through the whole rigorous process? It's a huge challenge.
Yeah, agreed.
Okay, so yeah, I will be nothing on this.
Yes, Dr. Thorpe.
It is a huge challenge. But because of that, in spite of the great need that there is, and clearly there is a great need, I would move a position of oppose unless the bill is amended with the staff changes recommended in the text of the.
Move the staff recommendation.
Move staff recommendation, yes.
Thank you, Doctor.
Thanks. Is there a second?
Madam, no, hold on before that. What kind of amendments you will be talking about, Dr.?
They're on
Can we get
page.
some-
They're,
Oh, sorry, that's one thing I was sleeping.
Yeah, and so there's two pieces, Dr. Mahmood, to the bill. One pertains to the physicians from Mexico, those licensees. And then there's the ITP provisions, which have generated the bulk of the comments
okay, so we've got a motion and a second
for the staff
for
recommendation.
the staff recommendation. It looks like there's some additional comments. Did you have an additional comment, Dr. Ayala Rodriguez?
Yes. Yes, just very quickly, just like, because I also work in a community health center, and just like the reminder, like, I remember, year over year, we heard from UC Davis about the great performance, like from the License from Mexico program and how great they did. And I also remember like asking like multiple times about, is there any hospital work involved? And they're like, no. And I was like, is anyone intending to try to do hospital work? They're like, no, because I wanted to be prepared in general. Like, what if this at one point could change, right? And I was always reassured, no, it's outpatient, it's community health clinics, right? So for me, I really think that it's a very good initiative in terms of these physicians are addressing a gap that exists in California, and resetting all the time definitely takes a toll into a system if there's no way for permanent licensure and things like that. But at the same time, it was a system that in California, it was only tested in one particular health setting. And I do agree with the recommendations from the staff about narrowing to the scope of practice that was intended, like, for example, the OB-GYN, psychiatry, family medicine, the things like stipulated in there. But also at the same time, not to forget what was the gap that we were trying to address, which is making sure that we had physicians in medically underserved areas, which typically are handled by community health centers and alike. So I'm in support of the staff recommendation.
Thank you, Doctor.
Thank you. Yes, Ms. Holmes.
I really like the idea. On here, yeah, I really like the concept. It's boiling the ocean right now. So will there be time to amend before, the end of this legislative calendar? Or is it just too complicated to unbundle right now?
Sorry, to
Well-
reframe your question, are you asking, Ms. Holmes, is there time for the legislature to amend the bill as it's been proposed by the staff or in some other
And
way?
the staff work together before can you repropose, I guess is what I'm asking. Or
Yeah,
is it-
no, it would take, some of these are, yes, your board staff can work with the authors and the sponsors, if they're amenable.
They have to be amenable, yes, of course.
Yeah.
Okay. Yeah, I think it's just too much in here. So it needs to, maybe you guys can sit down and negotiate and pare it down a little bit and then come back later with other stuff, like a little bit at a time, incremental change.
And I think the proponents make a lot of,
Make a really good case. Yeah.
a compelling case for the board to take action to develop a pathway
Yes.
that is appropriate in the view of the board, which was going to take a long time to do anyway. But I think the staff are suggesting that we first need to do our homework to make sure that the pathway is going to be appropriate, and that, I'm not sure if this is something that pertains to something that Dr. Ayala Rodriguez said, is that in ensuring that they're going to be able to be credentialed in hospitals, be credentialed and be approved for payment from health insurers, otherwise be able to find employment here. That is more than just a licensure pathway. That speaks to the broader process that we think is going to be valuable to make sure that there's going to be a successful integration of these possibly future licensees into health systems up and down the state.
Thank you.
Is that responsive, Ms. Holmes?
Yeah.
Thank you.
All right, any additional comments or questions? Dr. Ayala Rodriguez.
Yes, just last one. Because I want to recognize also like one of the comments from Dr. Mahmoud. Like I also think that this physician shortage problem is like something that has to be continually addressed. I think that right now we're focusing on one particular program or one particular population, but this particular initiative is addressing like California's demographics, California's needs to a certain degree, but definitely this is like version one of all of the possible amendments that could happen with that program, and to continue addressing physician shortages so we can continue getting qualified physicians from different places in the future. But we have to start somewhere, and I think that this brings up a good proposal, and it's going to continue with more discussions, recommendations.
So we have a motion from Dr. Thorpe. I haven't heard a second.
We had a lot of seconds,
Oh,
but I don't know
okay.
where they came from. Just to my right, Dr. Yip.
Dr.
with the
Yip.
Second. Okay, if there are no further comments, we're going to take a roll call vote on this one. Oppose unless amended.
Oppose unless amended as
Recommendation.
detailed out in the analysis. Thank you.
All right.
Mr. Orkutab,
Yes.
Dr. Ayala Rodriguez, Kang,
Yes.
Ms. Holmes,
Yes.
Dr. Mahmood,
Yes.
Dr. Solis,
Yes.
Dr. Thorpe,
Yes.
Dr. Tolbert,
Yes.
Ms. Torres,
Yes.
Dr. Sai,
Yes.
Dr. Yep,
Yes.
Ms. Lawson.
Yes, that motion carries. We are going to take a brief 10-minute break and be back. So be back as fast as possible. Thanks. And then are we starting with G? 8G?
Yes, 8G, AB 1979.
All right, welcome back to the Medical Board of California meeting. It is 3:51 PM. We are moving on to agenda item 8G. AB 1979.
Indeed. This is the first of 4 bills related to AI that are up for discussion today. This bill places 3 key requirements on health facilities, clinics, including group and solo physician practices. First, they shall ensure that no clinical decision is based solely on the output of a clinical decision support system. Second, they shall ensure that a licensed health professional uses their independent professional judgment when reviewing and approving a clinical decision based upon the output of such a system. Third, they shall not use or deploy AI to direct, guide, supervise, or instruct unlicensed personnel to perform any function that requires a professional license. The bill defines clinical decision support system to mean an automated decision system or generative AI system whose outputs are used to inform clinical decision-making with respect to the provision, timing, or course of patient care. The bill also states that any business that offers consumers a healthcare chatbot to help manage their information or for the diagnosis, treatment, or management of a medical condition is subject to the Confidentiality of Medical Information Act. The board staff believe that the aim of the bill is laudable and are looking, however, to the board for direction as to whether or not the bill strikes the right balance in regulating the use of AI in a clinical setting. Accordingly, we have no position or recommendation, but we'll endeavor to answer your questions, Madam President and members.
Thank you. Questions, comments from board members? Dr. Thorpe.
Aaron, what's the advantage of having a position on this bill? I mean, is there, I mean, clearly you came to the conclusion that you didn't have a recommendation. Is there a reason that we should have? I mean, I agree with you that it's laudable that the idea of not having AI supervising clinical decision-making and that no clinical decision is based solely on a clinical decision support system and that that licensed healthcare professionals exercise independent judgment.
Yeah.
When they look at the output of a clinical decision support system.
It's kind of the unknowns, doctor, in terms of, for me, not being in the practice of knowing whether or not these we think are gonna achieve the intended outcomes. Are they going to be unintended consequences? Is the verbiage, appropriate? Things like that gave me pause, the staff pause in terms of not providing a recommendation. This is kind of a blue sky area for the board to start laying down some policy positions on these things.
Can I just have one other so I mean, that's the problem, is that nobody understands this to the degree that's necessary to be actually the people that really are developing AI are probably the only people that really understand exactly what it does and what it means. It's very anyway, that's my position. I guess my point would be I would say let's stay neutral on it.
Okay. Ms. Holmes, then Dr. Tsai.
Thank you. This is such a huge area, Aaron, I'm wondering, are there other things that are already in place? I mean, you're seeing lawsuits that are happening from, AI generated advice. You're seeing the space is moving rapidly at, a pace. I think we need to spend a bunch of time on this at this board. And we need experts and we need to continuously, it should be a standing item on every meeting. But I looked at who's opposing and I looked at who's supporting, and it's kind of to me, I'm not used to this space, but it's an interesting list. So I looked at that. Generally, just my view as like I feel that this is a really important frontier and something that we need to really stay close to. And so I might lean in on this one to say, yeah, let's go ahead, but I'm not a physician. I'm not dealing with this. This is like the advent of the electronic health record where everybody was, oh God, get that thing out of my practice. It's going to ruin everything. And we're at the same moment in time as how I feel about some of this stuff. So I will, I want to hear more, but I think we need to dip our toe in the space.
Okay.
Dr. Tsai.
Yeah, I think one of the issues is clinical decisions may not be based solely on on a system, on AI, right? So how can you prove that my decision was based solely on AI? I think one of the great examples is a radiation oncologist who treats cancers. Radiation is supposed to be targeting the cancer area. So traditionally, doctors would have to look at the CT scan and draw the actual areas to be radiated. With the advent of AI, you can plug that CT image into an AI system and the AI will map it out. Is it better? Is it worse? It's a lot easier. So then the AI generates the area to be radiated. So as a radiation oncologist, if I use that AI generated area to radiate the cancer, is that a clinical decision based solely on AI? Or I looked at it and then I said, yeah, I agree. Then that's no longer solely based on a clinical decision. So I think the word right, the wording is problematic, because how can you prove that something is solely based on AI unless I don't see the patient, I have no interaction with the record, I do not make any recommendations, and then I just put this information in and the AI generates a recommendation and the patient, it goes directly to the patient and the patient follows it. So I think, the language may be problematic, to say the least.
Dr. Tolbert.
I don't know. I think I'd probably want the AI to help with that demarcation of that cancer to make sure it's done mathematically. I think consistency wise or consistently, it would do a better job. That's just doesn't have human error, doesn't have fatigue. But that being said, I mean, ultimately, I think in the end, there needs to be a accountability, and the physician, regardless of how they get to that decision, should be accountable for whatever the care looks like. And if they're following the rules, then it doesn't matter how they got there as much as they have been thoughtful about it and they've done appropriate research on whatever clinical decision that they made. Because physicians have been using technology forever. It's just now this technology just blows all of the other stuff out of the water in a way that nothing else ever has. And it's changing so rapidly, it's just unreal. So it's even hard for us to keep up.
Other comments? We open up for public comment? Let's do that. Any public comments in the room? All right, seeing none, any public comments online?
Yes, if you'd like to make a public comment on this agenda item, please do so by raising your hand or type something in that Q&A window. First up here, we have Rob Gordon. We should be receiving that prompt.
Sean, you can hear me okay?
We can. Please go ahead.
This is probably less complicated than you think it is. It goes back to the records issue we were discussing earlier, where as it stands now, anybody can write whatever they want on your record. They can lie, and that's not even illegal. The signature that is put on whatever the decision is and the decision points, that's what's important. If that's text, your signature certifies that text. And, maybe the AI writes better than you. Maybe you wouldn't change a single sentence. So, the point that was made about, if it's an AI image or or radiology targeting area. The same way if you're riding a bulldozer, you're responsible for the machine. They don't tell you what to do. You tell it what to do. They'll try to do their own thing, but you're the boss of the AI. You're the supervisor, and your signature is the important thing. So that's all I have to say. That's all.
Thank you, Rob. At this time, I don't see any additional requests. They're live right here. President Lawson.
Doesn't sound like there's consensus as to taking a position. It sounds like there may be consensus as to not take any position. Not sure.
Can I ask a question? So is it better in terms of the legislative process to have a neutral position? Or, I mean, is there an advantage to say having an opposed unless amended position? Is there an advantage to doing that? Or is it, because I don't think, I personally would not support this currently.
Okay.
But I do think we shouldn't just throw AI out. Clearly, it's the next phase, and we need to, as a regulatory agency, we need to be working with it.
Yeah.
And so I guess I would be willing to.
I don't think there's a need to strain for a position, doctor, if that's kind of what you're, if the board doesn't have a consensus on whether this bill is good, bad, or otherwise,
We don't need to
that's,
take a position.
that's fine.
Okay.
Yeah, that's fine. And I mean, I did hear from Ms. Holmes, like the desire for more information, more discussion. We've had a couple of discussions, but maybe we need to focus in future board presentations on topics that are related to the issues that are presented in this and the other bills that are on the agenda, if the board feels that way. I didn't mean to cut you off, but
Holmes.
yeah.
I have a question.
Yeah.
I wish that some of the opposition was here so I could hear why they are opposed. Do you know why they're opposing? Because they use it for decision support, I would think, right? And like, I'm a consumer, I do it. I just had a diagnosis, I threw it into ChatGPT. Like, what does this mean? Say it to me in English. So I think what they're trying to do is to ensure that there's oversight over this. And I want the doctor to talk to me and tell me, okay, I ChatGPT, I know doctors hate this. I know you guys hate this, but we come in with our stuff. I Googled it. I got my medical degree on Google. Here I am, I have my stuff. So what does this mean? And I want you, physicians as the expert and the people to people to tell me, is this right? Am I getting it right? And so I don't see I get what I think what they're trying to do is to say, even what Mr. Gordon just said, that, ultimately you're signing off on something. And
Right.
so, and as a consumer, I just want to know that,
The decisions are being made by humans with a license.
correct.
Yeah.
That's it.
Yeah.
And I think that's what this is trying to do. I read it over and over again.
Yeah.
And I printed it out to bring it here to talk about it
So-
because I feel it's really an important topic and you're seeing
Yeah.
so much litigation in this space. And I think it's only the noise level is going to get into, major decibels. So why are they opposing?
Yeah, so, and looking at, so this bill is pending on the assembly floor right now. And so I've got the most recent floor analysis, and it talks about America's Physician Group, California Association of Health Plans, Radiological Society, Civil Justice Association, Epic, Kaiser. So opposes this bill, stating it will significantly hinder the ability of the entire health system to provide safe and effective care for Californians and imposes rigid statutory constraints on rapidly evolving tools that are already deeply embedded across clinical operations. The coalition argues that the bill would require inventorying and legally adjudicating a wide range of existing tools across EHR workflows, patient education, care navigation, imaging, medical devices, and enterprise analytics. They state the bill would cause them to redesign or disable many current capabilities, create new compliance, audit, and documentation processes to demonstrate independent professional judgment, and absorb downstream productivity losses.
That sounds very catastrophic, and I'm not, it sounds like a lot of hyperbole. I don't know. I honestly don't know. So, okay.
I mean, I do, these are complicated issues, right? I mean,
Indeed.
so, you know, and we're grappling with them in the legal industry, right? Which is my profession. I'm a licensed lawyer. And we talk all the time about, I mean, the standard of care as a lawyer is now such that you should be using AI as part of your practice, right? To not, and by the way, that changed from literally 1 year ago, absolutely no use of it in the legal profession, to now, if you're not using it, you're somehow breaching your duties to your clients, right? And I think the same is in the medical profession, right? Frankly, I want my results to be potentially enhanced, or to your point about the cancer, did we get it all? Because AI can see it better than the physician can see it, right? I do want a doctor involved still, but that's why I think this is so complex. And I think while that summary of the opposition, I'm sure included some hyperbole, these systems are all using these tools already, right? I mean, when you go to the doctor now and it prints out after your, I mean, when I broke my thumb and then it prints out a bunch of information for you, that's not because the doctor went and pulled the books and photocopied it or what have you. There's a system in place that allows it, based on what he's put in or she's put in, to provide you that information. That's an AI function, whether we think it is or not, right? It looks a little bit different than Claude or ChatGPT. So I think it's complex. And I frankly agree with some of the sentiments in that opposition, which are, we don't want to do something at this point too that limits us or that sets us back in terms of leading and innovating and creating new tools.
Sounds like no position, Madam President.
Probably.
Oh,
I think that's where we're at.
Yeah,
but I can't.
Which does not require a motion. I
Correct.
mean, if
okay.
we take no action, then we move on to the next bill.
It sounds like that's where
Okay.
we're at.
No,
Does
I-
anyone wish to take a position? Okay, we'll pass. What's next?
Switch screens here. AB 2311, which is item I. This bill would authorize a general acute care hospital that is owned or controlled by a healthcare district for a 10-year period to directly hire physicians to work in those facilities. Before that can happen, the medical staff in that hospital must vote to concur that a licensee's employment is in the best interests of the community served by that hospital. Further, those who are employed in this manner must not replace other licensees who provide services at these hospitals. Licensees who are offered an employment position must also be provided the option to contract with the hospital. Finally, the employer must not interfere with, control, or otherwise direct the professional judgment of that physician. If a hospital employs a physician as authorized by the bill, then it must publish a report on their website each year that discloses certain data about their recruitment and retention of employed physicians. Some of these newly added conditions are mirrored in the authority that critical care hospitals and certain pediatric care hospitals currently have to directly hire physicians. Those conditions may mitigate some of the concerns that some have with employing physicians rather than having them contract for their services in facilities. And staff do not have a recommended position on this one. There's a lot of bills that the staff don't have recommended positions on in this meeting for some reason. Corporate practice of medicine, hiring versus contracting, a lot of history on that particular topic. Happy to answer any questions, Madam President.
Questions, comments? None? Okay, let's open this up for public comment. Okay.
Hello, my name is Lucas Evanson, speaking on behalf of the California Medical Association. CMA has an oppose unless amended position on this bill. CMA has had productive conversations with the authors and sponsors of this bill. Thus far, the author's office have made amendments which address some of our concerns. However, CMA still has significant concerns with the language as drafted. Thank you for your consideration of our comment.
Thank you. Other public comments in the room? How about online, Sean?
Yes, if you'd like to make a public comment for this agenda item, please do so by raising your hand or typing something in that Q&A window. Give me a few seconds to see if anyone queues up. Not seeing any requests at this time.
Okay, we'll bring it back to the board.
If it's helpful to hear opposition comments that are presented in the floor analysis of the bill, Madam President, I'm happy to
That
share
would be
that.
helpful.
It cites the California chapter of the American College of Emergency Physicians are opposed to the bill and states that the exemption to California's bar in the corporate practice of medicine is a threat to physician autonomy and to patient safety. The group contends that it is of the utmost importance that physicians have the ability to treat patients according to their specific medical needs without the influence or pressure of an administrator. Hospital CEOs and administrative staff have different motivations and mandates and are bound by different ethical and professional licensure standards than physicians. They conclude that patients deserve to be treated by clinicians exclusively motivated by their medical care needs. California Society of Pathologists is opposed to the bill and states that for pathologists, independent medical judgment is essential to ensuring accurate diagnoses, appropriate utilization of lab testing, and overall patient safety.
Thoughts, Dr. Tsai?
Is there any insight as to why, obviously contracting versus employment, is there, they can't find doctors to contract with, or because traditionally the 4 specialties that are contracted with hospitals are the radiologists, anesthesiologists, pathologists, and ER docs, because those doctors provide services for the hospital. So I'm wondering, why is there an end around about, being able to directly employ physicians and create an exemption to the corporate practice of medicine, the prohibition against the corporate practice of medicine?
So in pointing to your staff's analysis, it talks about, it's a statement from the author and from the sponsor. So the sponsor is the California Association of Healthcare Districts. So these are local special districts that own a number of public hospitals throughout the state. They say the 33 wholly owned and operated district hospitals, 17 already have access to the authority to directly employ physicians. The remaining district hospitals, however, must rely on contracting with physician groups or individual doctors. As a result, these hospitals are forced to compete in competitive labor markets without the tools necessary to do so. Specifically, it would allow the bill to employ them directly with clear guardrails preventing any interference with clinical judgment, according to the sponsor.
Right. Excuse me, Dr. Thorpe.
Yeah, I mean, I think the issue in this particular bill is this issue about district hospitals and the fact that they're small hospitals that depend significantly on federally funded
Medi-Cal
program mechanisms like Medi-Cal. And it does, so what they basically do is they think that by offering a high salary and benefits that they can attract doctors that they can't attract if they just offer them a high salary with a contract. I don't quite get it either, but I know they think that that's an effective way to get doctors. I think the concern I have is similar to the ER doc's concern, is that initially it's well-meaning, but when push comes to shove, when things get tough, and when there's a problem with patient care, and there's a decision to be made, if I know it says you can't influence it, but there's all kinds of ways to influence it. And my concern would be similar, that I would be opposed unless it's amended more clearly.
Okay. Staff has no recommended position. Other thoughts? Dr. Ayala Rodriguez?
Yeah, I think that it's an interesting conversation because of the employed contracted. Like in my mind, like I was like thinking potentially there's going to be instances in which the hospital, even though if it was allowed to employ, they might not find anyone. They might still need to contract the actual contracted group in there and just keep them there, right? On the second one, it's in my understanding is that if they were able to hire directly, probably they would be able to sponsor visas, right? Because if they're not able to hire physicians directly, probably they wouldn't be able to do that. But if they are able to hire physicians directly, probably they could sponsor, in my opinion. I don't know. But if that was the situation, then maybe they would be luckier in terms of securing a physician, right? Like from that perspective, like, I don't know, like that's something that I'm like thinking about in terms of why also they would like try to consider that part. My concern is like, yes, like this could help reduce operational cost, but if a situation happens that they need to lower even like operational cost, it's going to end up affecting utilization management one day, and they could change the practice of medicine or the policies or the procedures. So I'm leaning more towards the opposition. Yeah.
Dr. Yep.
Just for discussion that there's always some good intent behind something. There's always something may happen not the way we want. I can understand those hospitals need to hire someone so that they can serve the public. On the other hand, generally, the new general doctor, they do not take the risk of running a clinic or get their own practice. They like the idea of getting hired, get a vacation, get a pension, get security, etc. But on the other hand, from the patient standpoint, some hospital may use that as advantage to make sure they fully utilize the service, discharge patient home probably prematurely, limit what needs to be admitted. In a similar situation, I see some hospital, their contract physician, not even high physician, because the contract physician at Yale Group, radiology, pathology, they don't want to lose the contract. They would listen to anything the administration would say. They would not speak up in medical ethics committee on behalf of the patients because they're afraid of losing contract.
Right.
So based on that, I'm not sure if I would support this concept. I think if we open the door, down the line, more doctors would be hired by entity, by facility that may control the finance, the way we practice medicine. And I think patients will be harmed.
Okay, so there are a couple people that oppose this. You want to make a motion to oppose?
I make the motion to oppose.
Okay. We have a motion to oppose the bill, not oppose unless amended, just oppose. Okay. All right,
Who seconded?
Dr. Mahmood.
Okay.
Okay, any further comment?
Question, just for the purposes of writing a position letter from this discussion. The comment, the concern from the board is the potential for undue influence from hospital administrators, CEOs, what have you, over the independent practice of medicine. Is that okay? Those are the head nods. Great. Thank you.
Okay, let's do a roll call vote.
Mr. Arkatov? Dr. Ayla Rodriguez?
Yes.
Ms. Chang?
Yes.
Ms. Holmes?
Yes.
Dr. Mahmood?
Yes.
Dr. Solis?
Yes.
Dr. Torp?
Yes.
Dr. Tolbert?
Yes.
Ms. Torres?
Yes.
Dr. Sai?
Yes.
Dr. Yep?
Yes.
Ms. Lawson?
Yes. All right, that motion to oppose passes. Aaron, what's up next?
AB 2497, this is item L.
Okay.
This updates various provisions of the Physical Therapy Practice Act, which are noted in the analysis. One of the most notable changes to the law proposed is to eliminate the 45-day or 12-visit limitation that applies to patients who wish to directly access the services of a physical therapist without the approval of a physician or a podiatrist. Under AB 2497, a physical therapist would no longer require referral or prior authorization. Instead, the physical therapist would be required to refer the patient to a physician or other appropriate provider if the patient's circumstances are beyond the scope of that physical therapist. Various other controversial changes that were initially proposed in the bill have been removed in recent weeks, including dry needling and limited authority to prescribe and order patient imaging. Staff do not have a position recommended on this bill, but the direct patient access provision could have a substantial impact on the physician-patient relationship, or otherwise how medicine is kind of currently practiced. Therefore, we look forward to hearing any feedback from the board members and can conduct any research that you all may wish and report back at a future board meeting. Happy to answer any questions.
Thanks, Aaron. What questions or comments do we have from board members? Dr. Mahmood?
So they completely eliminate any physician ordering or managing patients who need physical therapy. That's what is in other ways, right?
The bill would eliminate the present requirement of that 45-day period or the 12-visit limitation. I don't know about, you could have insurance or you could have other requirements that could come into play there, but that limitation that's in the Physical Therapy Practice Act that requires that would be eliminated. So patients could go and see if a PT on their own. The PT would then have the responsibility of stating, whoa, what's going on with you is beyond my scope, beyond my training, my capability. You need to go see this type of a provider.
And if PD decide not to, they can continue going on and seeing that. If PD decide, okay, I'll continue that, they would not need a physician requirement to order that.
Right.
What I get from this thing is that after certain visits, it's directly between the patient and the physical therapist to decide whether they want to continue or not. It is at the discretion of physical therapist if he wants doctor or not.
Yes, they would have discretion under their training and practice and practice authority to continue to see a patient without necessarily getting a referral or authorization from a physician.
I mean, in simple words, they say they don't need physician after that thing.
Yeah.
That's what the basic
Potentially.
English answer is. And I think that is going to really jeopardize the quality of care. And there'll be a lot of other vested interests will come up and they will keep on doing this. And there won't be check and balance. I think this, either we stay out of that or either just we oppose it.
Other comments? Dr. Thorpe?
So currently, a physical therapist gets a doctor of physical therapy. They don't just get a physical therapy license, they get a doctorate of physical therapy. So they go through significant training and, anatomy, physiology, et cetera. Currently what happens is that you can walk in off the street to a physical therapist's office and you can get 45 days of treatment without seeing a doctor or 12 treatments, but your insurance may not pay for it. And that that's just a negotiation with the therapist. What this is saying is that because the perception from the therapist is that there's delay in care from people that need rehabilitation. And currently there is delay in care because the insurance company holds it up. You have to have one treatment and then you have to get authorized by the medical director of the insurance company to get further treatment. A lot of times that takes weeks and you've had surgery and you're not getting care. I'm not saying, I'm just saying that's how it works right now.
Sorry.
So I'm not sure that we're going to change physical therapy practice by this law. It's going to be managed by health plans. And the health plan already is in the middle of it and it's not allowing it to happen.
No, I think, Dr. Taub, you're mixing the thing. It's not only the medical director of the insurance company. It's the regular doctor like you or somebody else who's seeing the patient. They send the patient there. That is a different story where the medical director is going to do that and kind of stuff. It is, they don't need an order from a doctor who is patient's doctor to go and see physical therapist, whether it's needed or not. If somebody has a fracture of hip and he wants to need 12 treatments, doctor doesn't have to evaluate it, or some other complicated thing, doctor doesn't have to evaluate it. That is totally different story whether the medical director of the insurance company does that. They are blocking everything all the time. But this is a regular private, whoever his doctor is Medicare or Blue Shield or anything else, and they want these things so that they can bill them and they get the money out of that. If doctor wants to stop after 6 cycles, they want to continue doing for 12 cycles or whatever the thing is, they don't keep the discretion. So they are taking away from somebody who has gone through the training of medical school and 4 years of 3 years of one specialty and 4 years of specialty. And no, the physical therapist went to school for 2 years and he can make all the decisions. It is just not good for the patient's safety. That's what the question is here.
So clear oppose over here, unclear, Dr. Thorpe, what you think?
I have a comment.
Dr. Sai.
I think the intention is good. I think the reason is right now to see any specialist, even in Los Angeles area, 2 to 3 months. If you want to go see a neurologist, you want to see a pulmonologist, 2 to 3 months. By being able to self-refer to a physical therapist, you can get treatment earlier. However, the problem Dr. Mahmood's alluding to is that this patient hasn't been medically evaluated. If I have low back pain and I go, I must have pulled something, and then I go see a physical therapist because to see an orthopedic spine surgeon takes about 3 months. Then I get treatment and the physical therapist does all the therapy, and lo and behold, they don't know that I have a tumor in my spine. And now there's a delay in treatment where if I went to an orthopedic surgeon, I would have gotten diagnosed, got treatment. So I think it's a double-edged sword. You want patients to be able to have treatment, but then you need that safeguard so that somebody evaluates the patient to deem it medically appropriate.
Exactly. Just to more clarify this thing, when people need to the point when they need a physical therapist, many of them can go to urgent care. They don't need an appointment and doctor can write it. They can go to emergency room, or people get the surgery and after that they get these things most of the time, whether they are pulmonary or cardiac or bone fracture. I think they have some kind of contact with the doctor. It is not, if somebody is having that bad a pain and kind of stuff and not seeing a doctor, going to physical therapy, that's even worsening the safety and security of the patient. That is putting him through the harm's way. So it is literally taking a thing away and blocking the doctor from that so that people can just go freely keep on doing that thing. Yes.
Today, I can walk into a chiropractor's office without seeing a doctor. I can go to an acupuncturist and not see a doctor. They penetrate my skin and I don't have to see a doctor. All the physical therapist is saying is, I want to be able to have access to patients. The truth is, I could have a spine tumor when I see the chiropractor. I could have some kind of debilitating neurological disease and see the acupuncturist. But the fact is, I don't have to see a doctor to see either one of them. And that's they're not nearly as well trained as a physical therapist. So I would actually be in support of this legislation.
Okay, so we have so far an oppose and a support.
Yes, I just have a comment. Like in this particular case, is there any possibility to require that if someone hasn't been seen, by a clinician, like to have the physical therapist also send them to the clinician for a medical evaluation? Because I do believe that there's a benefit, in having access to a physical therapist. Like I do agree with their level of education, assessment, and recommendations. When I have seen the reports, when I have seen multiple times, that they recommend higher level of care or different care. I've seen a lot of like expertise, like in their assessments as well. But I do acknowledge, like if a patient happens to go the wrong door and starts their in a case that shouldn't have started like from PT, like can we also recommend or obligate that if care starts with a physical therapist and they haven't been seen by a physician, nurse practitioner, by a medical provider, to force that referral? So it's like, okay, you can see them, but you still need that medical evaluation.
I mean, that's an option for the board, doctor. I mean, it sounds like then instead of the 45-day and 12 visit, there be, rather than no limitation, it sounds like you're talking about something that's north of 45 days and 12 visits, but is below the limitless.
Because in this particular case, in my opinion, it's like there's many places that have like next available appointment in 2 to 3 months, right?
Yeah.
So what you don't want to do is like force a patient to wait 2 to 3 months for a medical appointment and then be referred to physical therapy and then they start the treatment and things like that, because like the physical therapists do provide assessments according to their level of knowledge and things like that, but they should be able to refer back to the system and say, okay, I'm doing this, but maybe there's red flags, you need to be evaluated or you need to be seen by someone else. I think that we should explore that collaboration path.
Well, I think and so the bill right now contemplates that the PT will be the decision maker as to whether or not the care needs exceed their their ability and their training and some of the other things Dr. Mahmood said. According to the PT board, it's a 4 to 6 year accredited college program that they must go to get a doctorate in physical therapy. So it's a pretty high bar.
So I'd like to open this up for public comment and see if that will
Can I
help
make
us.
one more clarification before? So
1
I
minute.
just wanted to clarify on this comparison. When you go to see a chiropractor, you usually 95% of people pay out of the pocket. And if somebody want to go see a physical therapy out of their pocket, they don't have any problem. They can go and they can get private physical therapists home. They can go to their place. They don't need doctor. This is all about getting the authorization and getting paid. It is nothing to anything else. It is all about the money. And we are trying to get somebody who is qualified to order those things, take their doctor away and just giving them direct access. You cannot just go and get a CBC done if you want to get insurance without a doctor's order. But you can go to a lab and pay from your pocket and you can get it done. Those are all other things to compare, but this is a totally different phenomena which they are talking about. That's why I'm kind of passionate about this. Thank you.
Okay, public comment. Any public comment in the room? CMA has an opinion.
Hello, everyone. My name is Lucas Evanson, speaking on behalf of the California Medical Association. CMA is opposed to AB 2497. Physical therapists are valuable members of the care team, but limiting physician involvement at the outset of care may place patients at risk. While physical therapists are trained in rehabilitation and functional improvement, physicians are trained to evaluate systemic disease, order diagnostic workups, and manage complications across organ systems. Direct access would bypass necessary medical evaluations before treatment begins or continues. For these reasons, CMA asks that you oppose AB 2497. Thank you for your consideration of our comments.
Thank you. Are there additional public comments in the room? How about online, Sean?
If anyone would like to make a public comment on agenda item 8L, please do so by raising your hand or typing something in that Q&A window. Give me a few seconds. Not seeing any requests at this time.
Okay. Well, I'm not sure that added is going to tip the scales for.
I'll offer a
anyone else.
motion.
Thank you.
I think hearing everything that's said, I think medical evaluation is important. So that I would recommend a position of oppose unless amended, that physician referral be required even though the patient is self-referred. Because I think, A, it would provide good patient care to get a complete evaluation. B, it would expedite the referral process because patient can start seeking some sort of care. And hopefully this would even sort of decrease the the liability of the physical therapist for missing or misdiagnosing something, because I think ultimately the patient health is the utmost importance. And with this, we sort of have a compromise. So I move to support or oppose unless amended on this position.
Okay, okay. Dr. Mahmood seconds that. Mr. Bone?
Mr. Bone has it.
What, you don't second it? Yeah. Need some help?
At the right time to kind of like restate that to make sure that I.
So I move to oppose unless amended to include that medical referral or physician referral is required even if patient self-refers for physical therapy, so that it would require the physical therapist. If the patient walks off the street and says, I need physical therapy, do you have a doctor's order? No. Okay, well, I'll start, but you need to get evaluated. Here's a doctor to go see.
Isn't that what happens now, though?
The current law is you can do that for 45 days or 12 visits before you need a
Right,
physician's
but
referral.
this would allow there be nothing for an extended amount of time, right?
Right, it would remove that limitation. So what
Right.
it sounds like is we're opposed unless amended to that provision of the bill, period.
Right.
And that you think the current law of 45 days and 12 visits is the way to go. They should stay with that.
Right.
Okay.
So if they, well, yeah, so it's opposed, right? Then that would be a,
Well, because there's other things that the bill does, but the discussion has been around the direct access piece, which is the point of controversy, as we heard from the public commenter. So to restate that, I think oppose unless amended to revert to current law, to maintain current law about the 45-day or 12 visit. Is that?
I was just, is the 45 days or 12 visits, is that not long enough? I mean, would it because I agree that there should be a limit, but is it, because I know working, being in the emergency department, that it takes a really long time to get in to see people. And so if it's just an issue of, okay, we need 90 days instead of 45, that may be reasonable, versus, okay, it's just unlimited. You never have to go to see a physician and think about all of the other systemic causes of low back pain.
Okay.
It does not sound like a second. from
Help me
Dr.
help you.
Tolbert.
Yes, help me help you.
So we have a motion from Dr. Side, to oppose unless amended to maintain current law with respect to patient access, direct access. Okay.
Sorry, do we have a second on that?
I have not heard one.
Dr. Mahmood has seconded it.
Dr. Mahmood, thank you.
Okay. Dr. Thorpe.
It doesn't make any sense to have a board supporting a position that's already current law. I mean, what's the point? The law already says you can see somebody without obstruction for 45 days or 12 visits. Why would we say that we support? I mean, I don't think it makes sense.
We're opposing it unless.
It's amended to have to current law.
Correct.
Well, but there's other pieces in the bill, doctor, that are separate and apart from the direct access. So what I'm getting is the board is fine with the other pieces of the bill moving forward, but the board would oppose the bill if it doesn't maintain current law with respect to direct access, 45 days or 12 visits, whichever comes first. That's what I'm
Okay,
interpreting.
we're gonna vote on that.
There was a motion and second.
Yes, we're gonna vote on that.
Mr. Orkutov,
Yes.
Dr. Ayala Rodriguez, Ms. Chung,
Yes.
Ms. Holmes,
Abstain.
Dr. Mahmood,
Yes.
Dr. Solis,
Yes.
Dr. Torp,
No.
Dr. Tolbert,
No.
Ms. Torres,
No.
Dr. Sai,
yes.
Dr. Yep,
Abstain.
Ms. Lawson.
Yes. I believe that carries
7-3 is what I got.
with 2 abstentions. Yeah.
Yeah.
Okay, great. Thank you. Okay, we are, what are we doing next here?
Moving right along to 2575, which is M, the next AI bill. 2 of 4. 2 of 4. This one states that a health facility, clinic, or a group or solo physician practice that uses or deploys a clinical decision support system for patient care shall provide specified written notices to those who are using or viewing the outputs of such a system. The details of that required notice are fairly extensive and are described on pages 3 and 4 of the analysis. The bill requires the disclosure to be provided to those who will use the system at the time that they are hired, onboarded, or credentialed. Further, the notice must be provided at least 90 days before a new system is used or before material change is made to such a system. The notice must be included no later than February 1st, 2028, and annually thereafter. The bill also bars an employer from retaliating or discriminating against a worker who overrides or relies on such a system. Finally, it states that somebody who is sued for developing, modifying, selecting, or deploying such a system that is alleged to have harmed a patient cannot state as their defense that the healthcare worker should have overridden the output of the system and that their failure to override the system means that the defendant is not liable for the patient's harm. We also don't have a recommended position on this bill, Madam President. Happy to answer any questions to the best of our ability.
Comments or questions? Okay, are there any public commenters on this?
Hello, my name is Lucas Evanson, speaking on behalf of the California Medical Association. CMA opposes AB 2575. The bill's requirements will discourage physicians from using beneficial AI tools that can support patient care, particularly in solo and small practices. As California's faces physician shortages, burnout, federal healthcare funding cuts, and ongoing access to care challenges, we should be reducing unnecessary administrative burdens, not adding to them. Every additional minute spent on compliance is time taken away from patient care. CMA supports appropriate oversight of emerging technologies, including AI, but that oversight must be clear, targeted, and carefully tailored to avoid unintended consequences. AB 2575 does not meet that standard. For these reasons, we respectfully request the board oppose AB 2575. Thank you.
Thank you. Other public comments? Sean, how about online?
Anyone would like to make a public comment on agenda item 8M, please do so by raising your hand now. Type something in that Q&A window.
Too broad.
Give you a few seconds. I'm not seeing any requests at this time.
Additional opposition comments are similar to the bill that we talked about before, Ms. Holmes. You're very welcome.
How'd you know?
25 years of state service.
Any comments? Doesn't sound like anyone's interested in doing anything about this one.
Well,
I have a question. This is solely limited just to the user, right? The healthcare professional. It doesn't apply to anybody else except the person using the system, right?
The requirement on the disclosure is placed upon the health facility, clinic, or a physician in solo or group practice.
Right, to the user.
To the user, the employee, the
Right.
clinician, whoever is using the system. Yeah.
So not patients.
The disclosure goes to workers who are accessing the system.
Yeah, it feels more like a HIPAA.
Well, we, Madam President, did not take a position on AB 1979.
And it looks like I'm not hearing from anyone that they have a strong interest in taking a position here, and I'm seeing some heads. Not true. Okay, no position.
No
What's
position.
next?
SB 903. It's an AI bill. First. This one you talked about it at the prior board meeting. After that meeting, staff submitted a comment letter that included the items of concern that were noted in the analysis of the bill at that time. Since then, the bill was amended in a manner that did address some of the board's comments. As currently drafted, psychiatrists are the only board licensees who'd be subject to the provisions of the bill. There are other mental health professionals that would also be subject, but psychiatrists are the only one for us. SB 903 generally requires patient consent to authorize a provider to use AI to record or transcribe psychotherapy services and related communications in screenings. Further, the bill prohibits AI from being used by a provider who is providing psychotherapy services or conducting triage or screening to do the following: make independent therapeutic decisions, directly interact with clients in any form of psychotherapeutic communication unless the tool is consistent with FDA guidance for low-risk general wellness products or clinical support software and is compliant with HIPAA. Generate therapeutic recommendations, assessment results, diagnosis, or treatment plans without review and approval by the licensed professional. You cannot use it to detect emotions or mental states. Finally, or to assess an individual's health concerns or symptoms for the purpose of determining the urgency, clinical nature, or appropriate level of the individual's need for psychotherapy services. If the provider is using AI because they are required or authorized by their employer or contracting entity, then it's the employer or the contracting entity who is responsible for compliance with the law and shall direct the provider to follow this law. If the provider is using AI based essentially of their own volition, then the provider is responsible for using it in compliance with this law and for using AI in a clinically appropriate manner. The bill authorizes the appropriate licensing authority to take action against their licensees for violations of the law, and we do not have a staff recommended position. Happy to answer questions.
Great, thank you. Comments or questions? Dr. Thorpe?
I think that we should, I think one of the suggestions was to remove physicians from this bill.
It's an option, certainly.
In the scope of the bill. I think the bill is overly broad and that it's not clear. And I would recommend an oppose unless amended to seek, with the amendment being that they remove physicians from the scope of the bill.
Okay. Other comments?
I have a question. Aaron, the osteopathic board supports. So do they, I don't know if you're aware of the discussions or the concerns or.
I unfortunately do not know the details of that, Doctor. I regret that I don't have that information to share, unfortunately. I don't know if Ms. Calderon is still in the room, but.
Does not look like it. Public comment.
Hello, my name is Lucas Evanson, speaking on behalf of the California Medical Association. CMA appreciates the staff's thorough analysis of this bill. CMA has had productive conversations with the authors and sponsors of this bill. However, CMA continues to have many concerns with the legislation as drafted. The bill's definition of artificial intelligence tools and their permitted uses are overly broad and unclear. Without precise distinctions between administrative tools, clinical decision support, and autonomous systems, physicians will face uncertainty about what technologies are permissible, potentially discouraging the use of beneficial tools. Additionally, provisions in this bill limit the use of AI in clinical settings and could interfere with professional judgment. AI tools are most effective when they are used to assist clinical experience. Statutory language should reinforce, not constrain, a physician's role as the ultimate decision maker. CMA appreciates the recent amendments that addressed our concerns related to patient consent for clinician usage of AI tools and replacing the previous enforcement mechanisms with enforcement from the appropriate Healing Arts Board. Despite these improvements, CMA continues to request further amendments that would provide clearer language regarding which clinicians are captured in this bill, remove or revise multiple definitions listed in this bill, and provide explicit language that will allow for research and development of AI tools in the mental health space. For these reasons, CMA is opposed unless amended to SB 903. Thank you.
Thank you. Any public comments online?
If you'd like to make a public comment for item 8Q, please do so by raising your hand or typing something into that Q&A window now. First up here, we have George. Should be receiving that prompt.
Hi, Eric Andrist here. The purpose of the board is patient safety, not to protect doctors or worry about their well-being. I think many of you forget that, and many have personal opinions that elude any sense of your duty to protect patients. Richard just brought up that he wants to remove doctors from this, but he doesn't explain why or what that has to do with protecting patients. He just wants to remove doctors. That sounds like somebody from the CMA or past CMA who just wants to protect doctors, and that isn't the medical board's mission statement. So Dick, go back and read the mission statement and then tell us why that's in the name of patient safety. All of you, when you say something up there, you have to explain why it's in the best nature of patient safety, because the medical board's mission is patient protection. It has nothing to do with protecting doctors. Thank you.
Next, we have Rob Gordon. Rob, you should be receiving that.
Yeah, hi. There's this bill has a lot of problems, but I just want to kind of say something slightly unrelated. You were talking about informed consent. There is no such thing. It's really important to know. I mean, you've pointed out a few of them here. Legislations, it's just, you know, anybody can write in your medical records, all sorts of stuff. But on this one, it's troublesome for a couple reasons. You know, one of them is just, you know, it's gonna, I myself am building an AI advisor. It's kind of encroaching on that. But when you said the informed consent, it's important for informed consent. You know, these aren't supposed to display, or people aren't supposed to see these anyplace. It reminded me of that depression questionnaire they put on medical records. After 6 years, I almost have a doctor again that's being criminalized. And I'm 71. But I think it's called the public question. It's a depression screening. Don't ever, anybody listening to this, happens to be listening, do not ever answer that question. Whenever I look at that, I want to like add an asterisk to every question, but that's not how medical professionals see it. They just see it as you're depressed. I could go into that whole thing a lot because it causes a lot of damage. I don't know why those two things seem parallel to me, but you know, if you're going to allow one, don't allow the other. I just get rid of this bill. It just looks too confusing. It's blocking the future. There's a lot wrong with it. Anyway, I don't know if that made sense, but go ahead. I'm done.
Thank you for your public comment. No additional requests at this time.
Great. We'll bring it back to the board. Additional thoughts?
Yep.
Ms. Holmes.
Okay. I think they're on to something here because when I look at who's supporting it, like Portia Bell-Hume is a very community-based psycho, you know, they deal with mental health. And I think we are a group of very privileged people, and we are not the homeless who have psychological issues out on the street, et cetera. And I think that the public is vulnerable to AI psychotherapy. So I think they're trying to do something good here. And I don't know about the doctor part. I mean, to me, a physician in that space is prescribing medications and things like that. So I think they've tried to define the population that they'd like to sort of have some more oversight with using the use of AI. I've also read stories of people getting therapy through AI, which I don't know if that's good or bad. It's helpful. I can't calibrate that myself, but I do think that it again, back to my earlier comments, this is the Wild Wild West space. And I think we're going to see this over and over again of people trying to hone in a little bit on not letting AI take over the world and having you're seeing it all the time in all kinds of media. So I will listen more. I think it's very broad, and I think it is, you know, trying to, again, boil the ocean here. But I do, again, want to say I think they're trying to do something good here. And so And I thought your comment, you don't have a recommendation for us. I can't tell if it's striking an appropriate balance either. I just don't know.
Yeah.
I don't know.
Fair
We don't
point.
know. We shouldn't we shouldn't take a
I
position.
agree. I feel like, yeah, I don't know. But I really want to be more educated, and I guess the feedback I have is to take it back to the other, the building and say, hey, guys, narrow this stuff down so that it's really clear what we're doing with this and what it's not doing, because they're trying to, this is the second one that's so broad and a little ambiguous that it's very hard for me to feel conviction about any. I care about this deeply, but I don't know how to go on this. It's too broad.
Well, and the challenge that we would face, I think, at this stage, great
Nobody
comment.
knows.
Well, in that, if you sent me forward with that to say, hey, we need to make this narrower, or they would say, okay, great. Well, how would you write that, Aaron?
Yeah, but that's not our job, right? I mean, I don't know if that's our job. Well, so they should consult the stakeholders and talk to these people that are in favor of it and get more information about what it is, the problem that we're really trying to solve. Because those are really good organizations that are supporting this. They do a lot of good in the community. So that from that alone, I tend to want to support it because those are good places and they serve people. And yet I can't tell if it's too broad or not, and it's going to mess up other stuff. So sorry, I wish I was more.
No, appreciate your comments. Thank you.
Does anyone want to propose a position?
Well, I did hear a motion from Dr. Thorpe.
Dr. Thorpe's motion was what?
Oppose unless amended to eliminate physicians as on the basis of the bill is overly broad.
Correct. Well, and physicians, because that's who we are responsible for.
Yeah.
It's not because that's the only reason, is because this medical board oversees physician practice, medical practice. So that's why removing them. And I would be happy with a neutral position or a no position as well.
We didn't have a second on his, correct? Dr. Tolbert.
I second.
Okay, now we have a second. The motion is,
Oppose unless amended to eliminate physicians from the requirements of the bill.
to essentially take it out of our jurisdiction, so to speak.
Well, it would, I think the amendment would work out being to adjust who is the providers that are subject to the bill to make it, to state that physicians are not included.
I'm not, I'm just not sure
Psychiatrist,
that
yeah.
solves any of the issues or addresses anything.
And
I think we shouldn't take a position.
And I think it'll, because the osteopathic board, who are also physicians and surgeons, so we have two groups with diametric opposing views. I think that's going to be kind of.
My understanding is that we can also stay neutral, get more information, and provide a recommendation at the next meeting, right?
That's correct. We do have a motion pending now because we have a second.
With the second, yeah.
So it either can be withdrawn or we can vote on it, and you could vote it no on it if you don't agree with it. Thoughts?
If we withdraw it, what's the,
Taking no position. Otherwise, we're going to vote on it, and if we vote it down, there's no position, and if we vote for it, it's opposed unless amended.
so I would be willing to withdraw it if Dr. Tolbert is willing to withdraw a second.
Okay, the motion's withdrawn. We're not taking a position. And what's up next?
Would you believe it that it's an AI bill is up next, Madam? The final one, sadly. This is a different flavor. This would place certain disclosure requirements for advertisements that include AI to promote a health-related consumer product or service. The bill is intended to promote consumer awareness of the use of AI in these advertisements and prevent the non-consensual use of the image or voice of a healthcare professional in an advertisement. Essentially, if such an advertisement includes the image, audio, or video of a human-like healthcare provider that is generated or substantially altered using AI, then that ad must include a clear and conspicuous disclosure related to the use of AI. There are some exceptions to the requirement if, among other conditions, that the person depicted in the advertisement has consented to their use of their digital replica. The bill authorizes the Attorney General's office, local district attorneys, and the person whose image or voice was unlawfully used to take action to enforce this law. The board could also take action against the board licensee if they are the violator. The bill promotes transparency and accountability in health-related advertisement, and staff recommend a support position. Happy to answer any questions.
Thoughts?
Again, I don't know why we need a bill. There's laws for this. You can't do image and likeness without permission unless you're in a public group. So I'm not sure why this is necessary, but do you know why?
Well, the sponsor, a representative of the sponsor of the bill, Ms. Holmes, is here in the room with us, and perhaps they will illuminate as to why they sought the bill.
All right, public comment?
Hello, my name is Lucas Evanson, speaking on behalf of the California Medical Association. As the sponsors of SB 1146, CMA appreciates the staff's thorough analysis and recommended position on the bill. As the board is aware, advances in artificial intelligence have created new opportunities for innovation, but also made it easier than ever for bad actors to generate convincing deepfake images, audio, and video that falsely portray physicians endorsing products or providing medical advice. These AI-generated impersonations are increasingly being used to promote unproven supplements, miracle cures, and other health-related products online. Often, scammers clone real physicians' faces or voices without their knowledge or consent. By requiring clear disclosures when AI is used to generate or significantly alter a person's likeness or voice in health-related advertising, this bill will help consumers better recognize manipulated content and make informed decisions about their health. The bill also provides enforcement authority to the Attorney General to hold back bad actors accountable, ensuring consistent oversight and prevent abuse of the law. Importantly, SB 1146 does not restrict legitimate innovation or the responsible use of artificial intelligence in healthcare or other sectors. For these reasons, CMA respectfully urges your support for SB 1146. And to speak to Mrs. Holmes's concern, I think the reason that we are sponsoring this legislation is because we are seeing these things happen and not enough action being taken. Thank you.
Thank you. Public comment online.
Yes, if anyone would like to make a public comment on this agenda item, please do so by raising your hand or typing anything in that Q&A window. Give you a few seconds to see if anyone queues it. Not seeing any requests at this time.
Great. Bring it back.
I move to support.
Move staff recommendation. Second, from Dr. Ayala Rodriguez. Any further comment? Okay, let's do a roll call vote. That was easy.
Mr. Orkuta,
Yes.
Dr. Ayala Rodriguez.
Yes.
Ms. Chung,
Yes.
Ms. Holmes.
Yes.
Dr. Mahmood, Dr. Solis,
Yes.
Dr. Torp,
Yes.
Dr. Tolbert,
Yes.
Ms. Torres. Yes. Dr. Sai,
Yes.
Dr. Yep,
Yes.
Ms. Lawson. Yes. Thank you.
All right, that motion carries. Are we on 8U? Is that correct?
Yes. This is SB 1271, which requires the board to update its demographic survey provided to licensed midwives to ask whether they are eligible and available to ask as a clinical preceptor who is an individual involved in the training and education of student midwives. As drafted, the bill requires the board to update the survey by January 1, 2027. However, the board's information technology staff currently have other projects planned and scheduled for this year that could be delayed due to such an effective date. Therefore, board staff recommend that the board adopt a position of support if amended to seek an April 1, 2027 deadline to deploy an updated survey. Further, board staff, further, we suggest you direct us to email our licensees once this has been completed to encourage them to fill out the survey as soon as possible. Although the survey is presented to all licensees, including physicians, at the time of initial licensure and license renewal, it can be filled out or updated at any time. Happy to answer any questions.
Thank you. Comments or questions? Public comment? None in the room? Sean, is there any online?
If anyone would like to make a public comment on agenda item 8U, please do so by raising your hand or typing something in that Q&A window right now. First up here, we have Gabrielle Brown. Brown, you should be receiving that prompt.
Good afternoon. Can you hear me?
Yeah. Yep. Please go ahead.
Okay. Good afternoon, members of the board. My name is Gabrielle Brown, and I'm a Solis Policy Institute Fellow with the Women's Foundation of California. I'm here in strong support of SB 1271. California has made meaningful investments to confront maternal and infant health disparities, including the expansion of opportunities for people to be served by licensed midwives. Yet we remain at a critical moment. Maternity ward closures, especially in underserved communities, are reducing access to perinatal care, while Black women and birthing people continue to experience disproportionately high rates of pregnancy-related complications and mortality. Licensed midwives are essential to expanding access to safe, culturally responsive care, but growing this workforce requires sustained investment in the training pipeline. While the state has taken important steps, these efforts cannot reach their full impact without a strong clinical training infrastructure. Today, student midwives are struggling to complete required clinical hours due to a shortage of qualified preceptors. Without preceptors, students cannot graduate, and without graduates, we cannot build the workforce needed to meet this moment, especially as hospital-based maternity care becomes less accessible. SB 1271 offers a practical, data-driven solution. It does not change scope of practice or clinical standards. It ensures the state can collect critical data to understand preceptor availability, identify barriers, and strengthen training pathways. If we are serious about addressing maternity care deserts and improving outcomes, we must invest in the next generation of midwives. SB 1271 is a necessary step forward, and I respectfully urge your support. Thank you.
Thank you.
Thank you for your public comment. Next, here's Esperanza Mendez. Should be receiving that prompt.
Hi there, can you hear me?
We can. Please go ahead.
Great. Good afternoon or good evening. My name is Esperanza Mendez. I am a full spectrum doula serving the rural Coachella Valley, which is Eastern Riverside County. And I'm also an aspiring licensed midwife. I'm here today to speak in strong support of SB 1271. I represent not only myself as an aspiring midwife, but also the birthing families in my rural community who are currently facing the crisis of access. I have been a full spectrum doula serving Riverside County's more rural populations for nearly a decade. I have witnessed the physical and emotional toll that perinatal deserts take on families and birthing people. Many of my clients come from the Eastern Coachella Valley, where I was raised, and frequently have to drive anywhere from 30 to 60 minutes while in active labor to get the obstetric care that they need. Since 2012, nearly 60 hospitals and labor and delivery units have across California have closed. My neighbors to the south in El Centro have seen hospitals and birthing facilities shuttering due to staffing shortages and funding cuts. These closures turn rural areas into birth deserts. California labor and delivery units are closing at a rate 3 times faster than in other parts of the country. When hospitals close, community-based midwives are the only safety net left, yet our current training pipeline is too weak to sustain them. Currently, there's one licensed midwife preceptor local to my area, and as you can imagine, she's at capacity. This creates an impossible scenario for students like me, where we're forced to delay our education, travel hundreds of miles, or abandon the profession entirely. We cannot improve birth outcomes if we don't have the providers to attend births. By mapping preceptor capacity and targeting the training pipeline for rural students, SB 1271 ensures that every birth desert in California can grow. I respectfully urge you to support this bill, SB 1271. Thank you for your time.
Thank you. Last here in queue, we have Sarah Tooney.
Thank you. My name's Sarah Tunney. I am a co-president of the California Association of Licensed Midwives, and I'm speaking today in support of SB 1271. We are an organization that represents the licensed midwives in California, and I'm also acting as the program manager for the upcoming licensed midwife program at Saracoso Community College. So we're very much invested in expanding our workforce to address the shortage in California. And we're also really hoping to have licensed midwives entering the workforce who are highly skilled and have the opportunity to work with preceptors who are also highly skilled. So this data collection tool will help us identify other potential preceptors as well as the shortages that we may have, and help us find preceptors and perhaps in other locations to bring into California to support skill acquisition for this workforce, a new workforce.
Thank you for your public comment. A late request here from Rob Gordon. Rob, you should be receiving that prompt.
Yeah, I tried to comment on this several quarterly meetings ago. Was interrupted, wasn't able to really express what I was going to say. I don't really remember now, but at the time I was on one of my digressions and looking at the history of this organization to find out what went wrong. And I went back a little bit too far in looking at the history of medicine itself. And midwives are actually the first doctors. They their first profession is actually integrated with human evolution. When Homo sapiens came about at the end of the last ice age, I'm going to talk about anatomy here, which I know nothing about, but as humans' brains got bigger, women's hips got wider, there was some kind of twist in the birth canal, it required another human. The reason I'm saying this now is I did hear a snippet from one of your past meetings where I think the head of the midwives board came, and she said they're only one lawsuit away from essentially failing. And I don't think you should let that happen. You know, the Medical Board of California, you're supposed to, you know, if they're under you in the, you know, in the hierarchy there, then you should be helping them. That's a profession worth saving. However it has to happen. You know, think out of the box. Get one of, you know, California's billionaires to give them a fund or something. But that should be, you know, a red alarm. That's not a profession we should let go. It's part of humanity. Anyway, I don't know if that made any sense. I have no position on the bill. I haven't read it, but 2 cents worth for whatever it's worth. Thank you.
No additional requests in the queue at this time.
Okay, we'll bring this back to the board. Dr. Sai?
I'll let Dr. Allen make the motion.
Thank you so much. I think that like part of what this is trying to solve is the making it more visible to identify who's a preceptor, right? And they're identifying a way in making that happen. And our bandwidth is our bandwidth, but is there any other way that we could like also help with that? Because I was like thinking about the volunteer registry. It's like, okay, like maybe we're not able to provide that change on the tool until 2020 something, but can we list volunteers for precepting on the volunteer registry so people can have access to, oh, maybe they can access to that person or that person, like just in terms of the thinking outside of the box, like how can we help them meet what they need, not necessarily that particular way, because that requires some time and a specific technological changes. But until that happens, what can we do right now to help them? Yeah, just my thoughts.
That's a interesting question, Doctor. If it's helpful, the data that's going to be collected from this would be provided, as with all of the survey data, to the Department of Healthcare Access and Information, and that they would be providing a report to the legislature. But I don't understand it that the purpose is to try to connect person A with person B who needs a preceptor. It's for a more broader workforce development purposes. Because there's all kinds of confidentiality provisions that are within this. It says the HCI shall maintain the confidentiality of the licensed midwife information it receives and shall only release information in an aggregate form that cannot be used to identify an individual LM.
So then it would only be for workforce planning development for preceptors and the workforce, but not necessarily for implementation of how can we help today's needs, like finding a preceptor? It wouldn't really affect.
That's my understanding. Yeah. And then HCI would provide a report by January 1 of 2029.
Okay.
So it's, again, it's not about, I don't understand that it's about matching up
Yeah, yeah.
need to availability from a person-to-person standpoint. But laudable, I mean, we support what we're trying to.
Dr.
what they're
Tsai.
trying to do.
I move to support if amended to April 1st, 2022 or 2027 as staff.
Staff recommendation. Great.
Okay, motion-
Seconded. Second.
Okay, motion by Dr. Tsai, second from Ms. Holmes, I believe. Let's take a vote.
Mr. Arkatov,
Yes.
Rodriguez?
Yes.
Ms. Chang,
Yes.
Ms. Holmes?
Yes.
Dr. Mahmood?
Yes.
Dr. Solis?
Yes.
Dr. Tarp?
Yes.
Dr. Tolbert?
Yes.
Ms. Torres?
Yes.
Dr. Sai?
Yes.
Dr. Yep?
Yes.
Ms. Lawson?
Yes,
Thank you.
that motion carries. And I believe we have one more, SB 1311.
Correct, Madam President. This bill has some provisions that relate to a few licensed professionals that are outside the board, including dentists, veterinarians, and private investigators. But it does have a piece related to the Physicians from Mexico program. Specifically, it adjusts one of the application windows for the program, which was set up to essentially license on a cohort by cohort basis every maybe 3 to 4 years. This bill would adjust the current deadline for the primary application window from December 31st, 2025 to July 1st of 2026. There would not be a change in the overall volume of licenses issued by the board, but would provide the sponsor some additional flexibility to submit more applications. We don't have any concerns with this proposal. In addition, as noted in the analysis, this is going to provide us an opportunity to correct a drafting error in the law related to the test of English as a foreign language, or TOEFL. The word percent was included in that statute by mistake a couple of years ago when when the current version of the program was recast as in its current form. Most of the applications received thus far for this program do not qualify under the current wording of the law, as they have received less than a score of 85% rather than the intended score of 85. It's 85 out of 120. Board staff are comfortable with the proposed change in the application timeframe and believe that this is a good opportunity to address that issue with the score. So therefore, we recommend a supportive amended position to include that fix by deleting the word percent, which is indicated in the analysis. Happy to answer any questions.
Comments or questions? Board
comment?
staff is supportive, recommendation is supportive amended.
Correct. Should go to public comment?
Public comment? There's no one in the room? How about online, Sean?
Yes, if you'd like to make a public comment on agenda item 8B, please do so by raising your hand or typing something in that Q&A window. A few seconds to see if anyone queues. Not seeing any requests this time.
Okay, we'll bring it back to the board. Does someone want to make a motion to support staff's recommendation? To advance staff's recommendation? Dr. Thorpe is making that motion. Okay, we have a second from Dr. Yip. Let's vote.
Mr. Arkatov?
Yes.
Dr. Ella Rodriguez?
Yes.
Ms. Chang?
Yes.
Ms. Holmes?
Yes.
Dr. Mahmood?
Yes.
Dr. Solis?
Yes.
Dr. Tarp?
Yes.
Dr. Tolbert?
Yes.
Ms. Torres?
Yes.
Dr. Sai?
Yes.
Dr. Yep?
Yes.
Ms. Lawson?
Yes,
Thank you.
thank you. We will now have a recess until tomorrow morning at 9 a.m. We'll see you all back here then. Thanks, everyone.